call the Medical Board of California Panel A meeting to order. Please call the roll.
Dr. Bishop?
Here.
Dr. Carter?
Here.
Dr. Diego? Dr. Solomonson? Here. Ms. Yaroslavsky? Here. Myself?
Here. We have a quorum. And now I think it's proper that we go into closed session.
Is the sound off?
Yes.
Okay, great. Well, that's what we were doing now. I'll call it a desktop. That's right. Let's do that. Items not on the agenda. Oh, okay. Yes. Good morning. Okay, good morning. I would like to welcome everyone to the new Education and Wellness Committee. Previously, this committee was two committees, the Wellness Committee and the Education Committee, and as of at our February 2012 board meeting, a motion was made to move Wellness Committee into Education Committee, creating the Education and Wellness Committee. So I guess because in alphabetical order, the alphabetical order is Education, I guess that's why I'm chairing this instead after Giselle. But I'd like to remind you to all silence your cell phones and please your Blackberries off as well. They reverberate and they add static, and I think we have enough additions that we don't need any more noise. So I'd like to remind everyone also that there are public speaker slips in the back. If anyone would like to fill one out, they're more than entitled to speak. And Mr. Shunke has raised his hand, and he's happy to collect them, so if you'd give them to him, I would appreciate it. And now I would like to call this meeting to order and ask Mr. Wood to please take the roll.
Good morning. Dr. Carrion. Here. Ms. Chang.
Here.
Dr. Diego.
Here.
Dr. Deriso.
Here.
Dr. Levine.
Here.
Dr. Salmonson.
Here.
Ms. Shipsky.
Here.
And Ms. Yaroslavsky.
Here.
We
Thank
have a
you very
quorum.
much. So the next item of the agenda is public comment for anything that's not on the agenda. So I've got a list of people that would like some time to speak, and I'd like to remind you to keep your comments, please, between 2 and 3 minutes, and try not to duplicate what I've heard previously. And we will first call on Robert Banakdar, and I apologize for the mispronunciation, but I'm sure it's not the first time.
Good morning. I'm Dr. Banakdar from Scripps Clinic in San Diego. I'm a family physician there, and I'm here as an observer and to introduce myself to the board. My work in the area of physician wellness comes from my mentorship with the late Dr. Lee Lipsenthal, whose work is highlighted in the article that I work with Deb Nelson to contribute to this most recent issue of the Medical Board newsletter, as well as my time with the Scripps Physician Wellness Committee. As part of that committee, we are tasked, similarly to some of the people here, to find additional resources for our busy clinicians. We have 5 hospitals, 500 plus physicians, and one of the things that we're working on now is a fall CME series, which will be webcast across the 5 hospitals, as well as after the fact available as a web module that we want to make available to other California physicians and clinicians to help promote awareness of physician burnout and the continuum with wellness to burnout. So I'm here mostly to say I look forward to supporting the work of the Education and Wellness Committee, and I look forward to learning more. Thank you.
Thank you very much. Burton Goldberg.
I'm a patient advocate. I'm in the book of Suzanne Summers on knockout. I'm here to talk about cancer and the ability of physicians in California to practice alternative and integrative cancer treatment safely. Right now they're being castigated. And the purpose of Suzanne Summers' book called Knockout, which she devotes a chapter to me, is all about the doctors who are being castigated around the country as well as in California. And I have to send my patients quite often to Mexico or Nevada or Arizona. The difference between the integrative cancer care and conventional cancer care is enormous. We feel that losing your hair and regurgitating is not the way to treat cancer. And we pay attention to the causes of cancer, particularly dentistry, because as much as 95% of females with breast cancer have a dental involvement, the oral cavity. And because through the meridian system, which is really not recognized by most medicine, the paces of acupuncture, and the nervous system, there's a connection between organs and system. We pay attention to diet. So I'm here to advocate that we allow holistic physicians to practice in their own school and perhaps put people on your board who understand alternative medicine.
Thank you.
By the way, one of these will be delivered to all of you. This is a DVD I did, which will explain. And it shows in here that we can use chemotherapy, but we use it totally differently. We know in advance which chemo will target the circulating tumor cells, which are the major killers. So it's really important.
Thank you very much. I want to remind public speakers that this is an opportunity for you to speak to this committee as well as to the board when you're in public session. It's not really a conversation, so don't take anything personally that we don't respond to what your comments are, but we're very interested in hearing from the public, so thank you. Call Ginny Cuny, please.
Good morning. Like you heard that name, I'm Frank Cooney's sister. It's the first time I've been able to attend a board meeting here.
Welcome.
Thank you. I've been with his group from the get-go, and I have a very thorough background in alternative health for years. My husband died of brain cancer. He had the same kind Senator Kennedy did. And unfortunately, he was VA, so he couldn't have any alternative. I spent numerous hours on the internet and talking to people and spending a lot of money trying to find some alternative. And I did do a lot of things. I did do a lot of diet and a lot of stuff like that. But that kind of cancer, is very difficult. Yeah, I mean, if anyone could have been cured, probably Senator Kennedy could have been. But anyhow, I'm here to suggest that we really have some, like Dr. Burton, Mr. Burton was talking about, we really need some alternative stuff, diet and other types of things to help these people. It's a horrible thing to watch your loved person die of cancer. It's really bad. Thank you.
Thank you very much. Frank Cooney, welcome.
Thank you. My name is Frank Cooney. I'm the director of California Citizens for Health Freedom. And first I would like to comment that you have a book we give to each of you, Return to Healing, written by Dr. Saputo. And the particular section in there dealing with pain, which is a complete alternative to drugs and a very effective program, I would recommend that you read very carefully and look at it, because those type of treatments are not generally accepted and covered by insurance, but they should be covered by insurance. The second is to comment on the cancer. I would like this committee and the board to seriously consider sponsoring a cancer freedom bill for next year. There are over 2,000 citizens of California that go to Mexico each year. There are numbers of citizens who go to Arizona, Nevada, and of course a great number go to Cancer Treatments of America. We could have Cancer Treatments of America, I assume, in California. There are several programs in Mexico that are run by California licensed physicians. They'd like to practice in California. We'd increase the number of physicians here. We'd increase the number of treatment modality that would be here. And we'd also increase the economic status within California and have a more helpful situation that people do not have to leave California to go for treatment. And I urge you to seriously consider that. Thank you very much.
Thank you very much. Robert Rowan is the name that's printed. The signature that I can't really read is different. You're the same person as the signature, okay.
My name is Robert Rowan. I am one of your licensees, and I am an integrative physician. And I am here to tell you that it is very frustrating that in this state of California, where there is some tolerance for integrative medicine under the board, there is a law that makes the integrative treatment of cancer a crime. And I think it's abhorrent that patients have to go to Mexico, as Mr. Cuny said. I have right in front of me an article about the contribution of cytotoxic chemotherapy to 5-year survival in adult malignancies in the USA and in Australia. It contributes nothing at all. Yet in California, it mandates that only chemotherapy, radiation, and surgery be used for cancer. Otherwise, you're a criminal. I have also for you at least 2 cases of stage 4 cancer signed by patients themselves imploring you to sponsor legislation that will repeal this draconian law. One patient was an Indian Swami, 76 years old, on death's door, literally on death's door, and his devotee behind me will confirm this. He was seen by an integrative physician with only weeks to live, with stage 4 colon cancer, huge mets to the liver, dying. He's alive today, totally cancer-free. His doctor could be held criminally responsible for getting him better. There's another patient here who signed a letter. He had stage 4 malignant melanoma. He is now cancer-free. Integrative strategies. His doctor could also be held criminal under current California law. In California, a 14-year-old girl has a greater right to get an abortion without her mother's knowledge or consent. This is a minor child we're talking about, than you do, ma'am, to get the breast cancer treatment of your choice. I believe that is not right and something has to change. And I'm here to beg on behalf of patients and California citizens that this board sponsors legislation to repeal the law. I will leave these cases for you.
Thank you very much. Oh, you can, thanks. Maya Lafuro, and I apologize.
I know it's a tough name. It's Maya Lahawaru.
I got the first half, thank you.
So I took care of the Swami that Dr. Rowan was talking about. I was his caregiver, and he was at death's door for certain. The doctors who were caring for him said there was nothing more they could do for him, and they refused to give him any more treatment. No, they said he was too weak for chemo or radiation. So we wouldn't give up. So we looked for integrative therapy, and he immediately started improving. Immediately.
And day by day, he got better. He was bedridden. From 6 to 8 weeks to live, he was starting to walk again. He got out of his own wheelchair, and he was able to walk into the integrative doctor's office. And from there, he's completely cured. This is 2 years ago. So I obviously am for integrative care. I would ask that the laws be changed in California so that people could benefit from the integrative care. Because it was hard to find, for one thing. It was hard to find a doctor who would treat him. So this has been my personal experience, and I would like more people to be helped by this integrative care. So I really appreciate being able to speak about it.
Thank you very much. Lori Gregg. I have Dr. Lori Gregg. Welcome. Dr. Gregg, it's good to see you.
Good to see you all.
Former member of the Medical Board of California.
Keep doing your good work. It's easier to sit out in the audience. I just want to come here and speak a little bit on wellness, being a former medical board member and also one that brought the Wellness Committee into fruition. Currently, I'm the chair of American Congress of OBGYNs in California. We have an active wellness committee, and I also serve on my hospital well-being committee. And I really think it's in the mission of the medical board to keep the wellness portion going. You know, we certainly know from studies that a healthy, happy physician leads to more optimal care. We have a lot of studies showing the opposite, that an unwell physician, a burnt-out physician has more medical errors, that a fatigued physician can create harm to the patient. So I'd really encourage you to continue to work on that. A couple of suggestions on ways to do that is the medical board articles are excellent, and I encourage you to continue those. There's a lot of resources in the wellness community to do that. Also, building a list of resources or educational materials is one way you could do that. Partnering with the AMA, who has an active physician wellness committee, and also the CMA to create resources on the national and state level. And one thing with being an active member of the Wellbeing Committee is we find that we're a little busier doing some monitoring since the diversion program closed. And so I think one way we might be able to help those committees is by creating a resource guide or toolkit to help them be more proactive with maintaining physician wellness or recognizing unwellness in their colleagues. Thank you.
Thank you very much. So I'm going to ask for an approval of the minutes from the January 27th, 2011 Education Committee.
So moved.
Second? Do I have any public comment on the minutes, or do I have any changes or additions? So seeing none, then all those in favor of the motion, please say aye.
Aye.
Any opposed? So item number 5 is a presentation
disability insurance covers non-work related illness or injury. We also cover in the initial phase of a workers' comp kind of claim while that's being adjudicated. But it does include surgery, alcoholism, drug addiction treatment and recovery, pregnancy, childbirth, and other related disabilities. So here again we see the regular and customary work is the standard. And what's very important to this community is that employees must be under the care of a physician or a practitioner who has to certify to the illness or disability. And this is just the difference between disability and impairment. In paid family leave, this covers for only 6 weeks, but the rates are the same rate as at disability insurance. There's 2 types of paid family leave. The first one is for bonding, which requires written proof of a new child, such as a birth certificate, adoption papers, or foster care placement. It must be claimed within 12 months of the child entering into the family, and the child must be under 18 years of age. The other type, which involves you as physicians more, is to care for a seriously ill spouse, registered domestic partner, parent, or child. And a doctor's certificate of the seriousness of the illness and the need for care is required as part of that. It's also required to be signed by the patient or their representative. And mothers bonding with their child don't have to do a second 7-day waiting period. It rolls over from their disability, from their pregnancy, right into the bonding period. So this is this identifies the differences between disability and paid family leave. That disability insurance is up to 52 weeks per claim, and paid family leave is only up to 6 weeks. I will be talking later about elective coverage, which is something that many physicians can have to cover themselves when they're self-employed, and that covers up to 39 weeks. So the claim forms are specific between disability and paid family leave, and the claimants can get the forms. Now the disability is downloadable, but the paid family leave is in an optical character recognition form, so that has to be mailed, and the doctor's certificate is part of it. Not only doctors are able to certify, we do allow some other practitioners, including nurse practitioners. This is just a quick shot of the form for disability insurance, and the one page is basically the doctor's certificate. So when you're certifying, the parts that you need to put in are your certification, whether you're an MD or a DO, etc., the license number, and then what's very important is the estimated return to work date, the ICD-9 code, and diagnosis. I've been finding that I think a lot of people are putting down the chief complaint rather than the diagnosis. We have a very high rate of pregnancy incidental, which is not going to work much longer because as a primary diagnosis. In its nature, it's not a primary diagnosis. So I would like to have physicians start really paying attention to what's happening with the coding. I know that many times this is delegated, and it's very important to make sure that it's not just a symptom that's listed, that it's a diagnostic code and not just a symptom. We do have place for secondary ICD-9 codes and comorbidities to be included. There's space to explain more about the nature, severity, and extent of the treatment of the illness, the type of treatment, and if there's surgery or a procedure. For pregnancy, it's a due date. If the claimant continues to be ill or injured longer, it's fairly easy to extend it with documentation that the illness or injury is extending longer, but this requires a timely process. The extension has to be done within 20 days of the issue date. You can also, there is a form that's sent out to you as a physician, but you can also get an extension just as long as you include your letterhead, the patient's name and social security number, the ICD-9 code and diagnosis, and the statement that the patient is still disabled when their recovery date is expected, your license signature and date. The paid family leave form, as I said, is in this red optical character recognition type form, but it's basically the same. In this case, what is being asked of the physician is you have to have the claimant's identifying information, but then you also need to put the necessity for care and the time involved, the daily hours of care that are required. For what we call duration management, to try to have reasonable control over how long people are out on disability, we use a system. There's a website called MD Guidelines, which has suggested durations. We also sometimes will get back to physicians. That's why I encourage all physicians to fill out the forms well in the first place, so that it really identifies what the problems are, so that you don't have to be called back and say, asked why is this patient still out when clearly they're significantly seriously disabled, but you just haven't shared that information. We do also have a process called the Independent Medical Examination, or IME, and we ask for more IME panelists to join us for that. So we are looking for more panelists to serve as consultants to show that the claim is still appropriate or not appropriate anymore. It's not a pure second opinion because you're not giving a full treatment plan or anything like that, but that is just a quality control check that we do. Then I wanted to talk to you briefly about elective coverage. You have to be self-employed or a sole proprietor with the intent to have your business for at least 2 years and it not be seasonable. It must be a major portion of your remuneration, and you have to make at least $4,600 a year. So it's a very low bar. For elective coverage, you have to have been covered for 6 months prior to filing a claim, and the amount of coverage is up to 39 weeks, and you can automatically be also eligible for the full paid family leave, since that's shorter. There's no pre-existing diagnosis issues with elective coverage, and I think you'll find that the coverage, though it's fairly low, will provide a baseline that's quite inexpensive compared to other disability plans. And I've included separately from your, I think Tim passed around the actual forms you need to fill it in, to send it in if you are interested. We serve in both English and Spanish, and soon we're in the process of automating. So I will be looking forward to having patients be able to put their claims in online, and then the physicians will be able to do online their process also. So, are there any questions?
Do you have any questions, Dr. Levine?
So the program is essentially funded by employees.
Yes, the program is funded by employees. They pay 1.2% of their salary. And some companies have their own plans. They have to be better than the state plan to have their own plan. But the elective coverage is something that, as a pathologist who always worked on contract, I would have qualified for, and I wish I'd known about that.
How do the revenues, the annual revenues, compare to the payouts? I mean, the funding status of the...
We're doing well. I don't have that off the top of my head. I've been looking at the medical side of things and not the financial side so much.
Thank you.
Dr. Diego?
So just to clarify, the nurse practitioner can put somebody on disability without a doctor's signature. The physician assistants require a doctor's signature?
There's a form in your packet. The nurse practitioner's form is in there. And then the nurse practitioner has to have a relationship with the physician, but the physician's assistant, I'm not sure exactly how this happened, but physician's assistants can't do it. They have to have a physician sign it.
And when a person goes for an extension, sometimes it happens that they started with some doctor and then the doctor says, like cardiovascular surgeon says, go back to your primary, and they can continue that. They, push aside the form. Is that okay for the primary doctor to continue, or should it continue with the doctor who initially initiated it?
They can change if it's appropriate in the care that they no longer need such specialized care. It's time to go back to a primary care doctor. That they can take over, assuming they can take over in the status.
I hate to say this. The reason that I ask that is because oftentimes the person will come to the primary care doctor who will fill out the forms with no dollars attached to it, but there are some places that charge for the forms. Some provider's office.
Oh, providers' offices are charging for it?
Yeah, that's why they'll come to the primary care doctor who will.
Oh, that's interesting. I didn't know about that. I'm new, Thanks for reporting that. I'll find out about that more later.
So are you suggesting, Dr. Diego, or Dr. Waters, that might not be appropriate?
I'm not
there be a
sure
charge
about
for
that. That should be charged separately. I'm going to have to check into that and see, but I don't think that. I think that should be part of an exam We're not talking about big paperwork here. We're talking about a few lines. It can't take more than 5 minutes.
Right.
Dr. Solomonson?
Well, I'm just, curious how to optimize, let's say, a new baby who has a birth anomaly, and then they're going to have, the first stage of reconstruction, so then the mom would like to stay home and take care of the baby and not bring it over to daycare. How do those, three things, because it's kind of like the birth, the bonding, and then caring for the child. I guess
Dr. Solomonson, could you use your microphone, please?
I'm sorry.
Yeah, just trying to figure out how those could be optimized.
Well, normally after a vaginal birth, we do 6 weeks and 8 weeks after a cesarean section. Then there's 6 weeks for bonding.
Oh, good, that's on top of that.
And then the 6 weeks for bonding, though, is in a 12-month running.
Okay.
So that whether she could do 6 weeks for bonding and then another 6 weeks for caregiving is a new question to me. I'll have to get back to you.
Because typically, I guess the diagnosis I'm most familiar with is cleft lip and palate. So the palate repair would be at 9 months of age. So should they save up their bonding time so they were around, or can they get that separate? Because actually we do get that question. It's great to get somebody I can ask.
Yeah, can I get your card? Of course. Or actually, my card's in there.
All right, perfect.
Call me a quick email.
Okay.
And I'll find out about that, because I know that PFL you're supposed to only get once in a 12-month rolling time. But if one's for bonding and then one's for caregiving, I don't know if that if that counts as a separate new one. It's an interesting thought.
So let me ask you the question to just clarify this presentation. That in order to have this insurance, you have to pay?
Right.
In order to have this insurance, you not only have to pay, but you have to have been working a certain amount of time and generated a certain amount of positive cash flow to the tune of $4,600, correct?
The $4,600 a year, it's only a year, is for, that's for the elective coverage. The regular coverage, it's only $300 a quarter.
So what I'm basically asking though is that in order to have this insurance, you have to fill out the forms and be proactive and have worked, correct? That's all.
You have to have worked some, and it's a complicated thing about when your base period is.
So you don't,
So yes, okay, what you're getting at is that if somebody has not worked at all, then they will not qualify.
Thank you, that's where I was going.
But it doesn't take much.
I've got that. I just want to make sure that everyone was clear on the thank you.
And there are evaluation forms in your packet. I would really appreciate if you would fill them out, and I look for, any feedback you have. Thank you.
I want to thank you very much for your presentation, Dr. Waters. Thank you for being here, and members, thank you. I'm going to move on to first an order of business, and it's my error, and I apologize. When we did the approval of the minutes for the previous Education Committee, I did not ask for approval of the minutes from the Wellness Committee from November of 2011. So I would ask for a motion on approving the Wellness Committee minutes from November of 2011.
So moved.
Do I have any comments from the public on the motion and from any of the members of the committee? Ms. Chen, please.
Well, so if I wasn't on the Wellness Committee, I probably shouldn't vote for that.
I would have to ask a legal opinion. I wouldn't assume.
It would be a writing recommendation, since by action of the board, the two committees have been consolidated, that voting would be appropriate for any member of this committee.
So the answer is you may vote, or you may abstain. So all those in favor of the motion as stated, please say aye.
Aye.
Those opposed? Any abstentions? Okay, thank you. Let's move on the agenda to item number 6, presentation on pre-existing condition insurance program. This pre-existing condition insurance program and education of physician is really important, I think, to the education committee as well as to the consumers and the physicians around the state. It was something that was brought to my attention, and I was shocked that this even exists. So I hope that you find that the presentation from the Deputy Director of California's Managed Risk Medical Insurance Board, Mr. Ernesto Sanchez, informative, and I want to welcome you to our board, Mr. Sanchez, and first let you all know that Mr. Sanchez has been staff to the board since 1998. He has served as an Assistant Director for Healthcare Reform, Division Operations Manager, Special Project Section Manager in his current position. He administers 5 different programs that serve nearly 1 million subscribers with a combined budget of over $2.3 billion. You have a whole lot of money in your budget. Does anyone know about that?
Not for too long.
That's for sure.
With the recent budget acts, but thank you. We appreciate the opportunity, Madam Chair,
Thank
and
you.
board members, to talk to you about Mr. Mibb. Just give you a quick little background. We were basically created in 1989 to promote access to affordable coverage, comprehensive, high-quality, cost-effective health care services that improve the health of Californians, targeting the uninsured. We're a kind of a unique public board in that we sit under the Health and Human Services Agency, but we're independent. Our board members are appointed by the governor and the legislature, and we have 4 ex officio non-voting members. We oversee 5 programs, the newest being our pre-existing condition insurance plan, or PSIP as we know it, which is one of the probably first implementations of the Affordable Care Act. It's meant as a bridge for those individuals who have been denied insurance coverage in the marketplace because of a pre-existing condition. It's expected, and it's totally federally funded, very similar to the insurance exchange. States have the option to either state administer it or buy into the federal fallback. California felt we wanted to administer our own program to maximize the federal dollars. We were given an initial allocation of out of $5 billion out there nationally, we're given $761 million. California is on a path to spend almost $1.2 billion on the number of folks we have there. Our major risk program, which initially started our board back in '89, was the state's high risk pool. So we have both a federal and state high risk pool. From our perspective, the federal pool is better because the rates are lower and the benefits are more comprehensive. There are no annual limits and caps. We also administer California's CHIP program, which is known as Healthy Families, which covers nearly 900,000 children and has served nearly 3 million children since its initiation in 1998. We also oversee the Access for Infants and Mothers program that provides health coverage to women who are above the Medi-Cal level, and they pay approximately 1.5% of their annual income. And then we also administer a program through our CHIP funding to share some of our federal allocation with 3 county children's health initiative programs. On PSIP, we're going to just give you a general overview, some of the demographics, eligibility requirements, and the application process. And I think with all of our programs, we appreciate the opportunity to collaborate with the medical board and providers, because I think it works in 2 ways. It helps patients that you may be seeing now that are currently uninsured and have financial risk of the costs of care that they have to pay for out of their pocket. And secondly, for you, it provides a stable source of funding to fund those visits to your office and to the providers. We started our program in October of 2010. It's 100% federally funded, provides coverage to individuals who have had or have a pre-existing condition. The Federal Affordable Care Act did require, though, that an individual be uninsured for 6 months, that you cannot have had credible coverage. And that was something that a lot of states lobbied against at the beginning, because there are many people who might be in the state high-risk pool that's a lot more expensive that can't afford to drop coverage. It wouldn't be wise for their health. We currently spend about 6% on program administration. All the rest of the funds go directly to pay for care. As of our board meeting yesterday, we publicly reported that we passed the 12,000 enrollment milestone in the program. We are the biggest in the nation. We expect that because we're California. On top of that, we're getting to the point where we're almost doubling the second highest state in the nation. So we're real proud of that, and we continue to encourage folks to enroll in the PSIP program. Here's a quick view of our demographics in the program. Requirements for this: you must be a California resident, you must be either a U.S. citizen, a U.S. national, or lawfully present in the country. You must have a pre-existing condition, and there's a couple different ways to document that. You cannot have had credible coverage, as we indicated, and you can't be enrolled in Medi-Cal, Medicare, COBRA, or CalCOBRA benefits. There's a couple different ways to document that you have a pre-existing condition. You can get a letter from a provider to document that, and we also have a form that you can download from our website as part of our application to make it easier. You can have a denial letter from an insurance company that you've been denied individual coverage within the last year. You can also have been offered rates higher than the major risk program, the state high risk pool, PPO rates, and that will qualify you. And if you've been enrolled in credible coverage, you can get another letter talking about how high the rates are that you've been offered. This is just our application. One of the things we've done, since we run both high risk pools, is we've combined our application. We want to make sure that if you're not eligible for the federal pool, which is a better deal for most folks because it's better coverage and cheaper, that you can also be looked at to see if you're eligible for the state high risk pool, our Mr. MIP program. Who can apply? Individuals over 18 and over, and parents can apply for their children under the age of 18, legal guardians, step parents, foster parents, and emancipated minors can apply for themselves. Generally, if we receive your complete application by the 15th of the month, your effective date of coverage will be the 1st of the following month. If it comes in after the 15th of the month, your effective date would be the first date of the second month. In the extreme cases where an individual's been enrolled with an effective date 2 months out, they can call in if they need immediate care and ask to have their effective date moved up to the 1st of the next month. It's a federal change that they just recently allowed us to do. If you're denied for the PSIP program, as we said, we forward the application over to our Mr. MIP program to see if you're eligible for that. Basically, as what I was talking earlier, it's a win-win for both providers and the clients that they serve, because if you're seeing a patient who is paying for costs directly out of their pocket, they may not be filling all their prescriptions. They may not be getting the follow-up care because they can't afford to pay for that. So I think it helps in a lot of different ways, and I think collaborating with the medical board is just a win-win for all of us to try to get our Californians insured, making sure that they're following the treatment plan that you provided for them. Here's some general numbers on our customer service. As you can see, we're open 8 to 8.
Excuse me, Mr. Sanchez, let me just interrupt you. Members, what you've seen on the board is for clarification. It's all in your packets if you have it, so it came with your board materials. So I just didn't know. I wanted anyone to.
Yeah.
Everyone's writing furiously.
No, and you've got the handouts, and we have those for the audience in color also. Just to let folks know that we understand that a lot of our patients are working population, so our business hours Monday through Friday extend to 8 o'clock at night. We are also open on Saturday for calls. If you're looking for some outreach material, because we have the main source where a lot of our referrals come from us are the denial letters and the insurance agents and brokers that help and assist families in applying for individual coverage. We also have a vast network of what we call enrollment entities and certified application assistants who have helped us in the Healthy Families program, and they also are eligible for a reimbursement. Both the CAAs and the agents and brokers, if you help somebody apply and they're actually enrolled, get a $100 finder's fee for enrolling somebody. You can get information on the detailed benefits on our website. Quick overview of our other programs. Our major risk program, as I indicated, is the other state high-risk pool. We spend about 4% of our funds on administrative costs. Our current enrollment is at 6,000. It actually has been going down because most of our enrollees are going into the federal program. Just a quick eligibility requirements. The one thing is, if you don't meet the federal requirements of being a U.S. citizen, national, or lawfully in the country, you may be able to qualify for PSIP because the residential requirement is a little bit less than the other standard in the federal program. In general, it's the same idea of not being able to secure coverage and been denied coverage. General application process, we have 30 days to process. One of the other things I wanted to cover a little bit, because Mr. Mibb's involved with all these different programs, that we've been pioneering a number of areas that are talked about in the Affordable Care Act and are assisting with the health benefit exchange that's coming on and looks to be in place by January of 2014. We've used third-party administrators to quickly administer our program, to bring up new systems and provide first-class quality customer service. We also have contract requirements that are comparable to commercial products on performance and accuracy, and we've been able to assure and provide multiple levels of quality assurance and auditing, because in almost all of our programs there's federal and state funding, and we also require our vendors to get the international certification on quality management. One of the things with the Affordable Care Act and what the board has done for a number of years is to be consumer focused, looking to reduce the number of uninsured, strengthening the healthcare delivery system, working to get us towards guaranteed issue so nobody can be denied for a health status. We are very similar to PERS does, which is we're not a regulator, but we are a purchaser of health care, and we try to, through our pools and providing subsidies for the cost of coverage, to help people and buy the best quality service. We contract with both Medi-Cal plans. We also contract with commercial plans. We have 36 health, dental, and vision plans, and for the PSIP program, we actually are very similar to a larger employer group. We bought a network that provides services through that. It's not a plan itself. Because when we did try to start the PSIP program, none of the California insurance plans wanted to participate. So we had to try a different avenue than our normal model. Healthy Families, I'll give you a quick overview. Our CHIP program is the largest in the nation. We have nearly 900,000 kids. We are bigger than the second, third, and fourth states combined. We're very proud of that, to have served over 3 million children. The only thing, this year's budget brought us some bad news in that the governor kind of did a sideways of what the budget committee said at the last moment with the big three, and they are going, had passed in the budget to eliminate the Healthy Families program sometime over the 2013 if they get federal approval, and move those children all into the Medi-Cal program. Unfortunately, that will have some impacts that probably will impact your providers because the rates are different between our programs. Our AIM program, just a quick overview, provides health coverage to women between 200% and 300% of the poverty level. They pay 1.5% of their annual income for the program, and we currently serve about 7,200 mothers. This program will continue to exist even after healthcare reform. These are our websites and our 800 numbers. Just want to make sure you had all that information, and that's my email address and my direct line in case anybody has any questions. We're here to serve. We appreciate the opportunity to work with you and collaborate and try to get the uninsured insured.
I can't thank you enough for your presentation. I have a feeling that this is going to be the top of the pyramid, and hopefully what happens is that your presentation here will go into further information to be given out to our constituents, our doctors. So I want to thank you. I would assume we have some questions, so hopefully you can stay for a few minutes. I know Ms. Chang, Dr. Dussault, and Dr. Levine. We'll go in that order to start with.
I just have, well, for instance, there is this young woman who just turned 26, so they cannot be on their parents' insurance anymore, and then went to apply for a commercial program and got turned down for pre-existing conditions. The family is probably well-to-do. She has some money of her own, but she don't have regular insurance. Would she qualify for something like this?
Yeah, with the PSIP program, as long as she meets that she's either a U.S. citizen, U.S. national, or lawfully in the country, she would be eligible. There is no means testing. It's not based on your income. It's basically that you've been turned down by the insurance industry. Basically, in the individual market right now and until January of 2014, they can still redline you out of coverage. They can say you may, and the one thing about California, which is very different than other states, some states regulate how actuaries define risk. It could be from having had bunions to having had an abnormal pap smear to having cancer, or on how they deny you risk. California is kind of like the wild, wild west when it comes to that, but she should be able to apply for one of our programs and qualify.
Well, actually, this is my daughter, okay? I'm using that example. I thought, wow, this is unbelievable. And I never thought I would be looking at a situation like that for my kids. And it's very strange. The question would be, what kind of category? I'm just thinking, when she was being turned down, was it turned down in what program, or everything, or just any program?
I think she probably applied for individual coverage. Right. Normally, if you're in a group, you're not going to get turned down. If you're in a large employer group, just like state employees, you tend to not go through that same kind of risk assessment or that actuarial piece. you benefit by being part of a large group. What happens is, for sometimes with small employer groups, you get one individual who's had some kind of health issue. I mean, you have people that get arthroscopic surgery for a knee or ankle injury because of a sports injury. That stays with them forever. And right now, until January of 2014, part of the Affordable Care Act is the reform of the market rules, and it will become illegal to deny you for health coverage because of your health status. That isn't one of the categories. This is one of the good things of Obamacare, as everybody seems to label it. It becomes illegal. But up until January of 2014, they created PSIP as a bridge for those families. And the other thing is they peg the rates that you're charged at 100% of the individual market rate, not the bumped up rate for somebody with a higher condition or with a pre-existing condition. So they've made it much more affordable than it's been in the past. As you talked about, in the past, some people just, even if you had a lot of money, you just couldn't get care. Or you had to try to buy something like a major medical policy where you don't get basic primary care.
Thank you, Dr. Rousseau. You have a question?
Just looking at, while the California has the largest PCIP program in the nation, given the population, it seems like at this point it's still a small number. What is the capacity of the program? What could it serve? What number?
I think based on our initial allocation, we were thinking that we could serve up to about 23,000 people based on, and this is just on funding.
Sure.
I think one of the things that when they were talking about the PSIP programs in general nationally, they first came out and said, okay, how many people are out there that potentially have a pre-existing condition or have had one? Then they give a big number. And they were saying, okay, these programs should enroll all these things. But they didn't ask a couple questions. First of all, they didn't ask how many of these people have been uninsured for 6 months. You can't drop coverage and come into the federal program. The other part is, even though we talk 100% of the individual market rate, which is cheaper than what they may have been charged in the past, if they could get coverage, 100% of the market rate is not cheap. When we started the program, we asked the federal government if we could use some of the money to allow low-income citizens of California to apply for a subsidy so we as a state could help pay for some of the premium. And the response back to us was, you could do it with state dollars. And the legislation that implemented the program here in California basically told us we're not allowed to spend any state dollars on this program. So it's kind of a catch-22. I think there are more people out there, but I think the biggest barrier is that 6 months without coverage, because a lot of people, if I've got a pre-existing condition that's serious, I need my treatment, I need my meds, I cannot afford to take a chance and wait 6 months. We did an analysis, though, and saw that we have had some of our members, they used to be on our Mr. MIP program, the state high-risk pool, drop it and come over to the PSIP program, but I don't think I'd ever tell somebody to drop coverage. That's a risk. You don't know, but there have been people that are willing to take that to get better coverage. The other thing with the state program is it has an annual cap and a lifetime cap. So the most you can get in the Mr. MIP program is $75,000 worth of services in a calendar year, and a lifetime cap of $750,000. For 98% of the people in our program, it works, but those are that individual who has costly coverage, that really isn't effective for them.
Yeah, thank you very much.
Thank you. Dr. Levine?
Yeah, just a question in terms of transition from PSIP to the world of guaranteed issue. Is there a hard stop on PSIP December 31, 2013, or is there some overlap so people can transition in an orderly way to the exchange?
I think the idea, right now the way it's been put out to us is that the program would end in December 31st, but we are working with the exchange right now in discussions because a lot of our programs are kind of linked with this idea of no wrong door. Yeah. And one of the efforts has been this look to say, let's do pre-enrollment. And one of the challenges is with the exchange going on right now is they just got their vendors selected to create the system. and to create the portal where people would come in, they have to meet some dates in early next year, about January. No, I think January is the pre-piece, and then they come out and test in June. The federal government comes out to test that you're ready and functional, because interesting thing, which I'm not so sure we totally agreed in, that they've got a limited open enrollment period of when you can get into the exchange, and that's going to be from October until January. And having started 3 or 4 programs in my career, when you're trying to enroll people, you should be enrolling continuously for years for the first couple of years, then worry about an open enrollment period. But you know, we've got to follow what's in the Affordable Care Act. So I think that's the challenge. We're looking to work on a process where we can do the pre-enrollment process, get our information of our PSIP and our Mr. MIP clients over to the exchange, so they can try to pre-enroll them, so that we really walk them across the bridge to exchange coverage if they qualify for that, or subsidized coverage through the exchange. Because the other part is, if they don't qualify there, they couldn't qualify for Medicaid. One of the things, because these high-risk pools, they're not based on income right now, so we don't have income information on a lot of them. It's just based on being denied.
So in terms of healthy families, I guess the door is closed on that program.
Not totally. I mean, we are in, while they changed the law and we're not the decision makers, those are at the legislature and the governor's office. They passed a law that says it should transition no sooner than beginning in January, and in 4 or 5 groups, contingent on CMS approval. We're in discussions with CMS because as part of the bill, there was a lot of concern at the legislature that the Medi-Cal program, with its 7.5 million people that are currently served in it, is busting at the seams, and they don't have enough providers to serve their current population. They also currently have the move to move the aged and disabled into Medi-Cal managed care. They're supposed to be moving the dual eligibles, or the Medi-Medis as they call them, over the next piece. They tried to move the adult day health care folks out of that, or they tried to eliminate that program, and that kind of failed. The courts have stepped in. One of the things that DMHC has been required, the Department of Managed Health Care, is they're supposed to do a network adequacy study of report back to the legislature in October, and supposedly these things are going to be evaluated before any children are moved. I think that's going to be a real key, because there's a lot of concern, not only on the healthcare side, because you can say a doctor is a Medi-Cal provider, but most docs have a limit on what patients they are accepting in their practice, and just because you're certified doesn't mean you're actually taking new patients. So I think that's a challenge, and on the dental side, it's even more sparse. So there's a lot of concern. I mean, you had 70 advocacy groups and both budget committees that were against this proposal, and it was only when the big 3 got together that this got passed, which unfortunately we don't make those decisions, but we want to keep taking care of our kids as well as we can as we bring that bridge across to the Medi-Cal program, if and when the federal government approves that.
Thanks very much.
Sure.
Thank you. Let me just ask you a question so I understand clearly.
Different.
Right.
If it's part of the PSIP network, your out-of-pocket costs are less.
Exactly, but there's the option that the client has.
You can,
has, right.
in the benefit package, you can select to go out of network, and you pay a little bit more of the cost related to that.
Okay, so Dr. Diego, does that answer your question? Any other questions? Well, I want to thank you very much for this informative presentation. Really, it's good luck.
Our pleasure. We appreciate the opportunity. Thank you.
Very enough, yeah.
So we're going to move on to the agenda item number 7 and ask Mr. Wood to please come forward and do an update on the strategic plan objectives and the plan objectives. Let me ask you a question. In the packet that we have here, I understand under section 18 is the strategic plan, but that's not in this book, correct?
If you look on page 91 of your packet, is my report there, and that takes you step by step through the objectives and the activities.
91 is what you received
Under
Earlier
the
this week.
Education and Wellness
Just
Committee.
hand it. Okay, I just want to make sure members are in the same place as you are while we go forward.
Only one is blank.
No, this handout came a couple days ago. Agenda item 7. Are there extra copies, Mr. Einer, in the back? Could you make sure members have them, please? Well, you can bring them around. So anyone that doesn't have it, could you just let Mr. Einer know, and he will make sure you have it. I have one of this, correct? But the question I had is that in this notebook is not the, in this board packet is not the, it went out of my, the strategic plan. That's page 9, right, correct? It's not it.
I believe, if I understand what you're asking, yes.
Okay, so, thank you. I didn't want people to be looking for the strategic plan in this notebook if it's not here. And it's not here, so people shouldn't look, that's all.
Okay.
Thanks. Your presentation, sir.
Good morning, committee members. I'm Dan Wood, the Public Affairs Officer. I'm here to update you on the strategic plan of the Public Affairs Office, which, as I mentioned, is agenda item number 7, page 91 in your packet. There are objectives 3.1 and 3 through 3.9. I'll begin with objective 3.1, which is to improve and expand the professional educational outreach to students and new graduates about the laws and regulations that govern medical practice. There are 6 activities to this objective, and I'll begin the review with the determination to improve the public website of the board. And this is the first activity. Over the past 6 months, I have met with our Web Users Committee, which overviews the entire public website and what it contains. And we set forth a plan of action that will redesign and launch a new public website by the end of 2012. To speed this effort along, we have also created the Web Design Committee, which was formed strictly to deal with the look, feel, and functionality of the new set, while the Web Users Committee deals with the content. The timeline for the development of the site is included in your agenda. It takes you up to the first week of November, at which time in the first week of November we will actually begin group testing of the new site to determine the ease of navigation of the site and identify areas of concern or needs for revision of the site. The second activity of Objective 3.1 is to utilize the website and the newsletter to inform licensees of any changes in the laws, regulations, practice patterns, and issues of public health. Now, the Public Affairs Office is seeking cooperative opportunities with other agencies, boards, and associations to identify issues that impact health care and convey that information about these issues through email blasts, alerts on the board website, and articles published in the newsletter. Articles written by staff of these groups on these relevant issues are sought by the Public Affairs Office, and the focus of such articles is to be on the education of physicians and healthcare providers. The third activity is to work with state, county, and federal agencies to inform licensees of the changes in the laws and events impacting their practices. Now, when these changes occur, an alert can be placed on the board website, and in some cases even an email blast sent out informing them of the changes or the event. An example of this is when the FDA issued an alert just earlier this month on Cartridget pre-filled cartridges. The cartridges were overfilled with medicine to the point that a patient could actually receive double the dose of medicine that was expected. This could be a severe health issue. An alert was placed on the board website and an email blast was sent out to warn physicians of this danger. The fourth activity is to educate physicians about complying with the law, and the Guide to Laws Governing the Practice of Medicine booklet is now being updated. This will be the 7th edition of the book, and it is pending final review, which will take place in the first week of August, and then it will be posted online and sent to print. The fifth activity is the reestablishment of the teams of 2 and a speakers bureau. The Public Affairs Office is in the process of implementing a team of 2 on a local basis, that being around Northern California, the Sacramento and San Francisco area. And we are asking groups that are seeking speakers from the teams of 2 to give us 6 months advance notice so that we may arrange a schedule with a board member and a staff member and prepare the necessary materials for the event. Our target for this is spring of 2013. And the last objective of our last activity of Objective 3.1 is to conduct outreach to various organizations, hospitals, and groups. Colleges and universities around the Sacramento and hospitals are also notified of the availability of speakers. And in fact, in May of this year, I spoke to a health care class at Sacramento State University concerning the operations of the Medical Board of California and its mission to protect the public. Such outreach is continuing to go on, and we make those arrangements as they come into our office. Now, Objective 3.2 is to improve public education by expanding current outreach efforts and initiating more outreach programs to educate the public on the board's programs, the rights of patients, and how to file complaints. Activity 1 here again is to review the board website for improvements, and as I said, by the end of 2012, the Public Affairs Office will have the new website ready to launch, and when it's launching, all board publications will be available for download from the website. This will save us a considerable amount of expense, although printed issues will still remain available. Activity 2 is to identify consumer education groups and publications that will assist in the distribution of board materials. The Public Affairs Office has reached agreements for distribution of such board materials with the Board of Pharmacy, the EDD, the California Medical Association, the California Department of Public Health, and Major Risk Medical Insurance Board. And each of these groups has added or will be adding a link to the Medical Board website on their own website and reprinting articles from our newsletter in their own publications. Activity 3 is to schedule meetings with editorial boards once a year. Such meetings are scheduled to begin in November, but using available resources such as phone conferencing and possibly video conferencing. Present travel restrictions by the state have limited the face-to-face meetings to local media outlets in the Sacramento and Northern California region. Activity 4 is the updating of brochures to reflect the current practice environment. All board publications are being reviewed and updates made as necessary. Updated brochures are made available immediately upon approval for download on the board website, and that is, again, as I say, pending final approval from the executive director. Beyond that, then it goes to print. Activity 5 is to work with other state agencies to provide board materials to consumers. The activity is currently being achieved as the Department of Consumer Affairs and the Public Affairs Office of the board have developed an excellent working relationship, and we will actually be using DCA video production facilities for the production of public service announcements and a campaign. That campaign is designed to promote public participation in events of the board and awareness of the medical board and its programs. Activity 6 is the development of social media outreach. This is a very important issue as it has become a major source of communication for people worldwide. Social media sites such as Twitter, Facebook, YouTube, and LinkedIn are going to be utilized to convey information to the public about board activities, important notices, alerts, public service announcements, and even our newsletter. Social media will play an important role in achieving the mission of protecting the public. This is because social media is literally the fastest way to communicate with specific audiences. The social media outreach campaign will begin in mid-August of this year. And the seventh activity to the board is to add board information to the California Healthcare Benefit Exchange, or CHBE. That activity is scheduled for fall of 2013 and will take place following discussions between this board and the executive director of the CHBE, which is expected to begin in fall. Objective 3.3 is to identify more effective efforts to promote expert reviewer program and recruit qualified physicians. The newsletter and the website are being utilized to achieve this objective. And with the launch of the social media campaign and the Teams of Two Speakers program, this effort will be expanded with a focus on recruiting and educating physicians about the program and how to be involved. Objective 3.4 is to establish a more proactive approach to communicating with the media and the public, as well as educating both about disciplinary cases and investigations, including those to be done in concert with other agencies. Activity 1 of Objective 3.4 is to build relationships with major media so that information on all the disciplinary cases is provided to the appropriate outlets. Now, the Public Affairs Office uses every opportunity to educate media representatives on how to use the board website, how to research information on physicians. In fact, press kits have already been prepared, and we have those for distribution. We have been using those at board meetings since January, and we will continue to do that. In fact, the Public Affairs Office is going to have a much more visible media center presence on the new public website, and the Public Affairs Office will also continue to generate story ideas for journalists and producers and provide media outlets with video for use in news stories or broadcasts on the web. Activity 2 is to work with the DCA to establish a joint news release procedure. This is occurring at present, as once news releases are distributed, they are sent to the DCA, and the DCA is also notified of any on-camera or recorded interviews. The Public Affairs Office also provides what is called a look ahead to DCA, informing them of any actions or anticipated events that would generate publicity, either positive or negative. Activity 3 is, as we said, the creation of press kits. We have done this so far, but what you're looking for in the future is the creation of an electronic press kit, which can be distributed online via CD-ROM or literally by email. So we will be able to connect with media outlets literally worldwide. Objective 3.5 is to expand the newsletter to better inform physicians and students and the public. And Activity 1 is to evaluate how the current newsletter is used by readers. The fall 2012 edition...
Mr. Wood, could I just ask you to just soften? It's getting very loud.
Oh, okay, sorry.
Thank you.
Activity 1 is to evaluate how the current newsletter is used by readers, and the fall 2012 edition of the newsletter will include an extensive survey that can be taken online and electronically tabulated, allowing the Public Affairs Office to have the metrics with which to determine what sections of the newsletter are of most interest to readers and how to best expand to meet the expectations of our readers. Once this information is gathered and analyzed, changes will be proposed to better reflect the needs of readers of the newsletter. Activity 2 is to allow subscribers to choose to receive the newsletter via email or on social media. Presently, the newsletter is sent via email to subscribers and blasted out to licensees. When the social media campaign launches, an option to receive the newsletter on social media will be made as well. Activity 3 is to establish a feedback mechanism for content of the newsletter to determine who is reading it and for what material. In each edition of the newsletter, we ask readers to provide feedback by emailing us, and they do just that. And such feedback is tracked and consideration made to all suggestions. When the new board website goes live in late December, a direct link to the editor will be provided to make it actually easier to provide this feedback. Activity 4 is to promote readership of the newsletter, and each issue or each edition promotes articles that are coming up in the next edition. Also, by creating reciprocal agreements with other boards, agencies, and associations, readership is expected to flourish as these groups provide links to the board's newsletter and the board website. In addition, these groups are guaranteed to publish articles from the Public Affairs Office in their own newsletters and publications, thus expanding our readership once again. Activity 5 is to reach out to other agencies and foundations to contribute articles to the newsletter, and we began this activity in early spring of this year, and the continuation of that effort continues as it existed prior to my arrival here at the Medical Board. We have published articles from the Federation of State Medical Boards, the California Department of Public Health, the Centers for Disease Control, and many others. And this has proved to be a very successful exchange of articles and ideas. We've also created video and audio links which are in the newsletter for even more information. Activity 6 is to incorporate more information on board activities in the newsletter, and each edition publicizes upcoming board activities and covers ones that have already occurred in the last edition since the last edition of the newsletter. Those efforts will continue to grow with the advent of the social media program, which we will use to disseminate information about events as they occur. Activity 7 is to encourage professional associations to include links to the newsletter on their websites. As each association is contacted and we build a relationship with them, this request for a link to the newsletter and the board site becomes a priority for the Public Affairs Office. I basically ask each agency that wants us to convey their information to return the favor, and they do so. I'm happy to report that the efforts to achieve this activity have been successful, and many times the links are already in place. Objective 3.9 is to conduct outreach to ethnic and other language publications, and Activity 1 is to identify groups to be targeted. Now, California, as we know, is an extremely diverse state, and there's media to represent nearly every non-English speaking language spoken in the state, or where English is a second language. This list of media opportunities is being compiled, expected to be completed in the winter of 2012. Activity 2, to identify those media outlets for non-English speaking groups and reach out to them. And we are running that in concurrent with Activity 1 as the objective of Objective 3.1. And as these outlets are identified, the Public Affairs Office will provide full board materials to them in the language that represents their audience. The full board will be updated on this plan in the January board meeting. Activity 3 is to identify those staff members that may be able to communicate with these groups through spoken language or cultural sensitivity. At the January 2013 board meeting, the Public Affairs Office will present a plan to address these groups and expand the board's communication efforts. The Public Affairs Office will continue to update the committee on the progress of this activity. Lastly, Activity 4 of Objective 3.9 is to reach out to non-English speaking audiences in concert with outreach efforts to English language and general audience. This activity will also incorporate the Teams of Two Speakers program, giving the board a greater opportunity to reach to more people and explain exactly what and how the medical board serves the healthcare consumers each and every day. Now, this concludes my report on the strategic plan for the Public Affairs Office. Now, moving on, I'd like to update the committee on activities of the public.
Wait. This is, you read very well, but no. You get questions. No. So, thank you for the update on your strategic plan. But let's start, because there are some issues with this. And start on this side, and then we'll come around the room.
Sure, Madam Chair, thank you. And thank you for the report. And I gather by your voice you must have been in broadcasting or something.
Yes, ma'am.
Very trained voice. A couple of things, just to let you know, because I brought this up before, I actually teach healthcare administration. I had my students, as an assignment in 2 semesters, go through our website as consumers. And they didn't have high marks at all. They thought it was very physician-oriented, and that it was very difficult for a consumer to find out where to go to get the information they need. That it's not an intuitive website. And I'm an elected official. Many governmental websites are not intuitive. So I would hope when you're doing your focus groups that you actually get real live consumers and not government staff to, to determine how we can best make this, because it's a twofold website. It's obviously for the licensee, potential licensee, but also for the consumer. And the other big issue is in the Vietnamese community, particularly in Orange County. They've expressed to me that it's very difficult, if not impossible, to find out in their own language how to file a complaint. And that there's some concerns in the community that the community is not aware how to do that. And I'm wondering if instead of segmenting on the website, as I remember it, that you actually have a tab excuse me, for each particular major language. So they could just click on that, and in that tab they would find the information they would need as a consumer, including whatever publications are in their language. Because otherwise they have to have some knowledge of how to navigate the system to get in to find their own language, and all the materials that go with that. So that's just a suggestion. The other thing is, if we can, and I know you mentioned about webcasting, and one of the things we do in the city of Long Beach is we have a system called Legistar. And Legistar is excellent because it not only posts online our agenda, it does a couple of things. It allows the public to leave comments about the agenda, because if they can't be at a meeting, that way they can post, and then that's shared. Obviously, it's a public record. The other thing is that it links with the actual broadcast of that meeting, so that if you wanted to go back and see what I said on a particular issue on a particular council meeting, you can click on it and it will go right to the video for that meeting. It will show you what was discussed, and it links it then to the paper document. And it's very helpful because it allows the public to be involved in a way that they can't normally if they don't come to the meeting and they don't want to wade through paper documents. And it's readily available. It's called Legistar. And it would be great if our board could lead the way on the state level of making that accessible to the consumer in every way possible. As someone who uses social media, not only with Facebook and the blog and Twitter, I have real concerns about putting the medical board into the social media realm, because my concern is it will become a discussion group on doctors. People will start posting doctors' names, and there will be discussions in there. While we think it's a way to communicate information, and I think there might be a way, the way that those social media work, you would have to have somebody on there all the time monitoring it and deciding whether or not to delete a comment. And as we know, that's very, in a governmental realm, there's First Amendment issues about censoring communication. But we run the risk in the social media about people start discussing doctors.
One of the things that we've already determined is that social media would be a one-way street, strictly for disseminating information, because you can set it up so that there are not comments available, because exactly what you're talking about. And so we use it as just another avenue to disseminate the information, but we're not looking to create an open discussion.
So let me take the president's prerogative and suggest that what I'm hearing from Ms. Shipsky is that social media might not be at a point where we are totally fully integrating it into a system come August of this year, and that there might be some need for you to review policies and procedures with this committee as we go forward with use of social media and its appropriate use. And what else did you suggest? You said use and design. How's that? Does that cover it?
Right. And I think, obviously, and I've heard this, from my point of body, that they're very concerned about that, we make certain that the way that we're communicating, that we really ramp up the consumer outreach, and that we ramp up the information and accessibility. And I think people right now are very comfortable about going to a website and finding information, but also having a way to perhaps leave comments that can come to the board, but not necessarily then open it up for a dialogue, a public dialogue about specific doctors or that nature. So that would be my concern, that we want to disseminate the information, encourage feedback, but we really want to protect the licensees from a public kind of
Exactly.
bashing that often
So you
happens
need to-
more than not on those social medias, and that would include YouTube, and because on YouTube you can leave comments. And I don't know how I know you can on Facebook limit, but Twitter is the same thing. You can rehash and resend, and then what you've got then is a going dialogue where someone can insert some very harmful information on our licensees. So I would just say
Okay, let's continue the conversation. Dr. Levine?
Just a couple comments. The first is that there are multiple, in terms of reaching the provider community, specialty societies, American Congress of Obstetrics and Gynecology, American Academy of Pediatrics. It isn't just the county medical societies and CMA. They all have websites, and they are often visited by the licensees who, in many ways, identify closely with their specialty society. So those are sources. Also, CAPG, who I know has been very eager to help and promote the medical board's website. And my second set of comments has to do with, in a number of places, you talk about identifying staff members and board members to translate materials into other languages. And I think we need to be very careful that we've got certified people who are skilled and trained in the translation of materials rather than grabbing someone who happens to be fluent in a language.
Well, absolutely. We contract with outside groups to be able to do that. But in reference to double checking and to make sure that it is a readable document, because oftentimes translations are subject to interpretation. So it's a check and balance system.
I'm going to suggest that non-English speaking media sources have translators on staff, so that if you take a look at La Opinion, for example, I can't believe that there isn't someone that if you hand them a camera ready, here's an article about making sure you don't have doctors performing surgeries in the garage, they're going to be able to translate and put it into the... So I think it's more of an issue, what I'm hearing from Dr. Levine, is making those connections with either specialty groups or with organizations, and go down the regular route. We don't need the 50,000-foot visual. What we need is to start from the ground up and make sure that our sources are being... We're starting at the bottom, we're not starting at the top, what we'd like to see at the end. We want to make sure that the foundation is laid appropriately. Is that correct, Dr. Levine?
Yeah, I'm reacting to the language that says staff members who have the ability to speak other languages or translate materials are being identified. And it isn't clear what they're being identified for. Just to be certain that we actually have professionals doing the work.
Okay, thank you.
Oh, absolutely.
Ms. Jane?
I was just about to volunteer my service. Now I have to think twice. Well, just last couple of weeks, I've been off the city council for almost 8 years to get on this board. But the city clerk just sent me a election piece of paper, and for me just to review it, to edit, and to review it actually. I look at that. It was done professionally, but the whole thing made no sense whatsoever. Now I end up taking it back and have someone translated and checked it. I understand the election very well, so I send it back to them and say, check it again, but this is a better version than what you have. So having somebody who understands the process to review it, it's a good place. And it's just like, I'm willing to look at what you did with the Chinese version of your thing, and maybe somebody can do it the same thing as the Vietnamese portion. I think Jerry has somebody who actually looked at it and said it doesn't make sense, it's difficult. So that part I thought was important. And I still will volunteer some of my service if you really need it. But I'm glad you had gave us a very comprehensive report. Thank you for the hard work.
Thank you. Dr. Karen?
Yeah, thank you very much for your presentation. Let me make a couple of comments. The medical board is seen by the public and by the providers that we are regulators of medicine in the state. and use the social media as a source to the rest of the public is too social. It's too social. I think we are going to need to use the word education. I think that we need to educate who? The providers, starting where? In the medical schools, internship, residents, fellows. Why? Because these doctors, when they start private practice, they don't know the rules of the game. And they start playing, and they make mistakes, and they only learn about the medical board when they made the mistakes. That is the moment, that is the place where we need to educate. Who? The providers. And the public, we're going to need to find some promotion marketing experts, I am not expert, who is going to educate these people, the rest of the public. Now, in different languages, of course, but we're going to also need to have the experts who they are going to do that. And finally, we need to make this as an education. Cannot be social media. Especially everybody is going to start finding something wrong with us. They're going to start criticizing, like in the past. Why we have you here today? Because in the last 2-3 years, we were getting all these nasty articles in LA Times here and there. And we finally, with the leadership of Barbara, you know, we say we need to find somebody who is going to be what? Ahead of these particular people. And that's what we are doing today. But let's go do very professionally and not entering that social media, you know, that I don't think is the right thing to do.
Thank you, Dr. Karen. I'm going to start this end and come back this way. Dr. Diego, do you have something to say? Suggest?
Just like Dr. Cardio mentioned about making sure that what we do in the social media, I just don't think that physicians, the medical board really is, I don't think the social media is ready for a regulatory body at this point. And the other thing is, you know, in terms of like the newsletter, that is definitely the place where we want to somehow attract the physicians to learn about, like what he said, you know, learn about how not to come before us as a regulatory body. So it's, even when I read it, it's kind of very dry. I love reading Barbara's comments, you know, in the newsletter, but we really want to make it more educational for our physicians.
Well, I don't know if this is philosophically problematic, but I know in our professional society website, there's a section for physicians where you have your little password, and so there are things that are kind of internal that perhaps could be misinterpreted by the general public, and then there is the general website. So I don't know if that's considered lack of transparency, but I do think that's something to consider. And the other thing is when you do a survey about how you're doing online, I'm concerned that it's already biased by the people that are already comfortable online. So I think there might be some older physicians who are still missing the written form, and I just want to make sure that we know, has the transition to the online been well received, and how can we measure that? And then I just remember from my exam before the Senate rules or whatever about reaching the underserved communities. How will we know that we're achieving that goal? So, just some thoughts.
Thank you. Dr. Dussel?
I would just say that this is very good and very comprehensive. And I like your outreach approach to various groups.
Thank you.
So forth. Unless I missed something, yesterday in our executive committee, we talked about being more proactive when there's negative media that relates to the board. And and I kind of read through this, but I didn't see a section in there or an intent to be more proactive when we have such issues with the board and its activities. And so I would encourage us to think about that. How might we be more proactive in responding?
Part of the problem with journalists, myself being one for nearly 30 years, is that you can't control the journalist and what they see or what they interpret. Obviously, some of them have a particular bias or just they see to create or seek to create fear where there is none just for the sake of generating audience interest. Unfortunately, there's not much you can do about those kind of journalists. They exist, they always have, and sadly to say they will continue to be out there. What we try to do, though, is explain and talk with them, and then again, this is part of the meeting with editorial boards and producers, to get them to understand exactly what the board does, what our responsibilities are, and the fact that we are bound by the same rules of due process as everybody else. This is one of the biggest problems that I have encountered in my time here at the board is not every, but a large majority of the journalists saying, well, why wasn't this done months ago? Or when you first heard about this, why didn't you do that? And I have to explain to them that due process, a person is innocent until proven guilty. And I've tried many, many times with some journalists to explain that step by step, and they still don't get it. But that is the way they tend to think, and in the case of the journalists that like to sensationalize and make a mountain out of nothing, that's what they're going to do. And they seem to be the ones that everybody looks at and says so. I have actually had journalists call me after seeing a report on another station or reading an article in the paper and say, what about this? And I tell them what the situation really is, and they go, oh, okay, that figures. Basically what they're saying is they understand because they know the journalist that wrote or publicized the article in the first place has their own bias or agenda. And so you tend to focus in on the ones that are good journalists and work with them the most because they're the ones that'll get the accurate information out. The ones that are the sensationalists, they take a back seat.
So thank you, Dr. So let me suggest that with the objective 3.1, your first discussion point, this web design and web users and web committee that's meeting constantly, I would echo that I don't know who's on that committee, but I assume there aren't any board members, which is your prerogative. By the same token, I would hope that there are some consumers that are on there as well as licensees so that you get a feedback and an idea of how the web is working for people that are using it, not just from us at the staff of the medical board. That's number one. Number two, on the consumer education groups on objective 3.2 and number 2, the second activity directs the public information officer to identify consumer education groups. Industry, that's not real hard. I'd like to know, I'd like to have a progress report of which consumer groups are being outreached to, which media sources are being outreached to, which ethnic community organizations and media sources are being outreached to, because I want to know that this is happening. This is before your time. This predates your being here. You should know, but the request has been made, and the request continues to be made, and the request continues to show up. And I don't feel like we are doing as broad, as deep a job as we need to be doing. So talking about it, I'm getting tired of talking about it. So you're getting the brunt of this because you're here now, but it's been going on. So don't take this personally. It's basically what I'm saying. The idea that social media, I can't tell you how abhorrent it is to me. And the idea that this is going to be implemented in August of 2012 without any discussion, with public discussion, with resources, be it the professional entities, the CMA, the AMA, the professional societies. What are you doing about social media? How are you regulating it? How are you implementing it? When can it be used? it's just not ready for prime time. And I have to tell you honestly that it's my opinion that until we have our basics, our foundation in place strong and doing an excellent job, we can't be distracted from our core mission and our core responsibility. And that is to license and discipline the license of doctors. It's to educate them as well as educate the consumers what it is that we do for you here and how we can interface with you and do a better job. And I'm going to tell you honestly, you're going to have to shelve it, and in my opinion, but we will. I don't know how it's going to get to that point, but we'll have to discuss it because my frustration is even at the Federation of State Medical Boards, it's a discussion under topic, and I don't know what they've come up with. I don't think we can be the jet setter here. We could be the jet setter if we had everybody taken care of, if everything we needed to do was done, and we had all the money in the world and staff to do it, but we don't. So when we talk about what it is that our function, our core mission of this medical board is, it's not to have instantaneous news and instantaneous opportunities for information that we don't know where it's going. So I would like to have more of a understanding from your office as to what other entities in a regulatory manner, in a physician manner, in a consumer manner, what are they doing with the use of social media and what are the guidelines and restrictions that they've instituted, because we haven't heard about any of that. Okay, so wait, I'm not finished.
Sorry, you asked a question. Sorry.
Oh, I did? No, I'm directing my questions to our information officer. When you say that on our website that we have the opportunity now for people to click in and send questions to you directly, I assume that there are people that are collecting that data and that information. I would be real curious as to how many responses do you get to the web, and what are the kinds of things that people are concerned with, and maybe that might also generate some further discussion of where we go. Maybe it is social media. I don't know. Maybe they want instantaneous information. But I'd like to know some of those comments and how many of our readers are, in fact, how interactive is this process? The outreach to ethnic and other language publications has to be done in a localized area, almost like compartments. So if our meetings are in Los Angeles, it's a huge media resource, huge ethnic diversity, huge numbers. Take the time and the opportunity to do that then there, so you don't have to worry about travel restrictions, the same as here. We're in Sacramento or when we're in Long Beach. Wherever we're meeting, there's local media, and that's what we need to reach out to more. We need to not worry about the Wall Street Journals, the New York Times, the LA Times of the world, but to the local newspaper who everybody is reading. Without doubt, I think that's where we have to take a look, and I would like to see a plan. So those are my issues with the report. It's very full, and I thank you for making a very full report. But we also need time to digest what you've written and on a go-forward basis. Now I'm going to ask for a couple more comments from the people here, the board, the committee, and then I'm going to ask for public comment, because I think we have members of the public here, and if you have anything that you'd like to add or be heard at on this item of communication and how do we get our message out both to the consumers as well as our licensees, I would hope that this would be an opportunity for people to speak. So please fill out a slip and give it to Kevin. Kevin, would you raise your hand, Mr. Shunke, please? But Ms. Chang, you had additional comments, and Dr. Carry-On, and then I think we'll hear from the public, okay?
Yeah, well, can you hear me? Oh, yeah. The social media issue was discussed at the federation level, and it's advised not to do it. I didn't think I influenced you before, but it is advised not to do it by our lawyer. But the issue on the outreach to the ethnic group, I thought that was a very important issue. Since I got on the board, we had this committee, and we did I thought we didn't do enough. So therefore, I am very happy you're doing it. And since I'm going to be off the board, if I only concentrated on one thing, I will be happy to volunteer on this one.
Great. Good. That's good. Maybe you also read the publications and see if they're showing up. Dr. Carry-On.
Mr. Wood, let me give you a suggestion. Basically, what we try to do here is is a promotion of the medical board. I use that because marketing is for services or products, okay? Now, the promotion is going to need to be scientific promotion. How? You're going to need to find what the experts call a needs analysis. Needs analysis means that what they need the providers, what they need the public. How you are going to do it? You are going to do what they call also focus groups.
Right.
Okay, try to put together 5 or 10 doctors, 5 or 10 public people, and say, what do you need from the medical board? That is when you are going to have a conclusion how we are going to do it. That is how it's done today scientifically.
Okay, thank you. Do I have any members of the public that would like to address? Mr. Cuny, why don't you come forward? And you'll give me a slip in a few minutes, okay?
As a representative of a citizen organization, I want to acknowledge and congratulate the board for taking leadership on trying to get information to the public more. It's good work and needs to be continued. Thank you.
Thank you. Anyone else? Okay, so now we're going to move on to number 8. Mr. Wood. This is a discussion and consideration of the mission and goals for the new Education and Wellness Committee, and you're going to lead us in a discussion, please.
Agenda item 8 for the committee is the consideration and adoption of a mission statement and goals for the future. And with the historic changes occurring in the form of the Patients' Rights and Affordable Care Act, it's more important than ever for physicians to continue to be educated on these issues that affect their practice and their patients. Now, physicians obviously can expect patients to come to them seeking unbiased answers on the changes to healthcare. And as this committee moves forward, it will need a mission statement. Members of the committee may wish to consider as a mission statement the following. To further the board's mission of protecting healthcare consumers, the mission of the Education and Wellness Committee is to seek out and promote educational opportunities for licensees and consumers that enhances the practice of medicine, the well-being of healthcare consumers, and aids in the development of a sound balance of personal and professional lives so that physicians can be healthy of mind and body and offer quality health care. Should the committee decide to adopt this mission statement or a variation of it, the committee may also wish to adopt the following goals for the future. The committee may wish to promote cross-educational opportunities that promote the reduction of stress and contribute to a sound balance of personal and professional lives. Once these programs are identified, articles describing the programs and their benefits can be published in the board's newsletter and on the board website and through email. The committee may also wish to research how to educate consumers on the role that they play in being proactive in their own health care and how best to communicate with physicians. Again, this information can be printed in article form in the newsletter. In addition, such information can be incorporated into public service campaign. The committee may also wish to identify the changes in healthcare reform and what it has and the effect that it has on medical practice and healthcare consumers, and educate physicians on the best methods for implementing those changes. The committee may also wish to identify areas of education that promote healthy environments and lifestyles for physicians and patients. Examples of these programs are the Kaiser Permanente's Thrive, the Well Life programs like Cartelet Health, and the Healthy Lifestyle programs available from the U.S. Department of Agriculture. Staff further recommends that the committee review and possibly revise the proposed mission statement. Staff recommends that the committee review and possibly revise the goals of the committee. Staff recommends the committee direct staff to develop ways to implement the goals of the committee. Staff recommends the committee direct staff to analyze and report on the healthy lifestyle training sites that are available online. And staff recommends the committee direct staff to write articles on the best way to communicate with your physician for the creation of a brochure and publication in the newsletter, as well as being made available online at the board's website. This concludes my report for agenda item 8. Does the committee have any questions?
No, but we're going to have a discussion, since this is supposed to be a discussion. So what I'd like to hear from the members with reviewing this mission statement, does this seem to fill the void of what was, of the unknown of what the combining of the two committees left us with? Does that start, we'll start with the mission statement, is that okay with you?
Right. Correct.
So, looking at the mission statement, and not looking to wordsmith, okay, I'm not looking to wordsmith, but the opportunity to reformat what it is and what the purpose of this committee is, as stated, how do you feel about that? Or what is your input? Or what are your comments? Or is this what you want to go with? Yannick?
Barbara?
Yes, Dr. Terrian.
Thank you. I think that we are missing a word here that is extremely important. We jump from education to wellness. How about prevention? I think it should be education, prevention, and wellness. Okay? We are jumping something extremely important that if you review the healthcare reform, they make emphasis in prevention. I think it's the same here. It should be education, prevention, and wellness.
Okay. Any other comments? Ms. Shipsky, please.
The only thing, I think it is a little confusing. I know you've merged education and wellness, but I think the focus...
Please, could you use the microphone so that they can hear you?
Yeah, thank you. I think it's a little confusing. I know we've merged education and wellness, but I think the focus on wellness has been solely on physicians. And so what I think needs to be clear, are we then expanding this committee to include the wellness of consumers? Because that was never the focus of the wellness committee whatsoever. It was totally focused on physician wellness and the issues about that.
Sure.
So either we need to expand and say we're doing that, or I think it begs the question about why the two are together.
I know what you're saying, and I think the issue of education and wellness do go hand in hand, as well as prevention. The consumer is where we get into the gray area. So the idea of the ability to transfer and translate, educating consumers what they can and can't do, or should or shouldn't
about
be doing.
wellness?
No, about health. No, about doctors, about healthcare. No.
Well, and again, then I have great difficulty about the two being melded,
yeah,
because it's just they have different really
They have
missions.
different missions. Okay, so I understand that.
Yeah.
Dr. Levine?
My comment was the same. I think it is beyond our scope to be getting involved in, sorry?
Go ahead.
In taking on the issue of the responsibility for educating consumers about their own health status, health improvement. There are an awful lot of entities that have responsibility and accountability for that. I think it's beyond our scope. I think, to me, the link was educate, or the link, the bridge in my head was educating consumers about the function of the board, the role and responsibility of the board, and at the same time ensuring that we were, as a medical board, doing what we could to ensure the health and wellness and, if you will, preventive opportunities for prevention of stress-related illness within the provider community.
Providers, right.
I still believe they need to be separate, because otherwise my concern is you don't get the focused attention on the wellness component like we were going down that track versus pulling this whole thing in about educating consumers about the function of the board. And, you know, it just, this, I'm concerned that if, you know, committee can only do so much, and something's going to suffer. And I would really hate to see the wellness part suffer, because we've got so much work to do on the educational component for consumers. So that's just a concern.
Maybe what we should do is hear from staff as to the previous incarnation of why we combined or looked to combine both committees and what the rationale. I can see taking the word health, the words, you know, well-being of healthcare consumers out of the mission statement, period. That should come out regardless. But maybe is what I'm hearing, you would like an understanding if we're going to have a combined committee and what the combined committee should achieve or expect to achieve versus two separate committees. So, Mr. Wood, do you want to do that? Ms. Whitney, do you want to do that? Ms. Kirchmeier, does someone want to do it? Because I sure can't.
I'll be glad to.
Okay. How about if the whole team comes up and explains to us what we're doing and why?
Why healthcare? Oh, excuse me.
As part of your strategic plan, we reviewed all of the committees, and in your discussion of the continuation of certain committees, you consolidated some of them. And in this case, you chose to consolidate the education with wellness committee because they both had to do with the concept of education of maybe two different groups, not separate and distinct, but wellness, the education of physicians, the education of physicians and consumers. So that is why your discussion was to combine the two. It doesn't mean that in this committee you realize that maybe you need to separate to some degree and make a wellness task force within your committee, or that you maybe made a hasty decision and you would like to reconsider that possibility of having two committees. That's perfectly all right. That's up to you. There's no restriction here on what you do. It was just something that you had made in working through your strategic plan. So if you would like to discuss the possibility of splitting or an offshoot, that can be done too. But there are two distinct groups or reasons for educating. So,
okay, so given that background, Mr. Wood, do you want to add to that?
Given that background, it's entirely possible that you could separate those out and be more effective.
Okay, so let's start again. Which end? Mr. Hepler, please. A voice we haven't heard from.
I'm afraid to break that streak, but I'm afraid I must. So I'm afraid to break that streak of not speaking. Oh. I'm afraid I must. The discussion that's squarely before the committee right now is what to do with its mission statement and related materials. The issue of whether we should have a separation of the two committees would have to be, of course, noticed and undertaken at a later date, because it's not noticed properly for here.
You know that, but we're dealing with a mission statement, and you can't adopt something that isn't matched.
No, I was talking to my colleague as sort of, been around the board for a while. I was going to suggest that perhaps since we had separate committees and probably in some point in time either developed or embraced either working concepts or a mission statement for each, I was going to suggest that we go back and see what in fact the mission statement for, if we had one for the education committee was, and then what it was for the wellness committee, and perhaps then we could present both those and then a proposed merger, if you will, of the two things and see how well they fit together.
So, Dr. Levine?
Yeah, I think one option would be, number one, to clarify what the intention of the wellness piece is and of the education piece, and that rather than expanding wellness beyond what its original intention, we're clear when we agendize items within the committee as to what it is we're talking about and who the potential beneficiaries are. And then I think Kurt's suggestion of looking at a mission statement that doesn't blend everything together, but in fact calls out and identifies what our mission is in relationship to wellness and what our mission is in relationship to education might simplify the discussion without requiring us to go back and just.
So let me ask you a question. Looking at the statement as it is, if we were to take out the last 3 lines, starting with being of healthcare consumers, and just leave it further board's mission of protecting healthcare consumers, the mission of the Education and Wellness Committee of the Medical Board of California is to seek out and promote educational opportunities for licensees and consumers that enhance the practice of medicine, period. No, you're not happy with that.
You want to add the well-being of health.
Okay, and leave the and leave in no.
Madam Chair, I think the Vice Counsel, I think we need to perhaps either get both of those mission statements, look at them, and then revisit
Okay,
this
that's
as
fine.
an item.
I'm willing. I was just trying to save you some time
Instead of
because it's only
wordsmithing.
July and next meeting is October, so that's fine.
Yes.
So we're going to direct staff to bring back the mission statements of both entities as they were, and to pass them out in a timely fashion so that the members of the committee can review them and maybe send written comments back.
Well, and perhaps when we call for items for the agenda, maybe put this on the agenda for an upcoming meeting to discuss.
Well, absolutely. But, right. But at the same time, staff's going to have to present that. Okay, are
And
there,
maybe
Dr. Daigle?
recommendations of staff of how to, taking Dr. Levine's comment of separating this and that recommendation of how they would merge it, because, or else we'll have the same discussion. It's like you're going to have 2 different mission statements. Try, it's worth admitting that takes some time. That's what we're struggling with, right? You presented it. We all have this in our mind. It's just, mission statements just don't happen in 5 minutes.
So, again, we will put it on it as an agenda item regardless, but I'm just suggesting the process of within us receiving the material, that it be done in a timely fashion with an opportunity to maybe send back our opinions and our comments, and then from that would come forward recommendations of a possible workable statement. Is that okay?
That's fine.
Okay, so then we're going to, on this number 8, we're going to then table the acceptance or the approval of this mission statement. Okay? All right?
Madam Chair, if I may.
Yes? Yes?
I'm presuming that if the mission statement is essentially deferred to the next meeting, consideration of any goals that would be derivative of that mission statement would be tabled as well.
I think that's a good idea. No, it's not. I know. I've got, yes, but I've got public discussion on this motion as well, okay? So I want to acknowledge that if everyone at this side of the table has spoken, then I'm going to call on public comment and ask that Gary Nye come forward, a former member of the Wellness Committee. Please. Thank you for being here.
Thank you for having me. And the opportunity to speak. I'm glad to hear that the deliberations are being tabled, because I think this is such an important subject. And mission statements to me are something that need very deep and extensive deliberations. I would hope that there will be a role of those of us who were on the Wellness Committee before to give you feedback and input about that as well. I understood that that probably was going to be arranged, but since I wasn't sure exactly the format, I wanted to be sure before I had to leave that I think it would be wise, as I said, to get as much feedback as you can, particularly from those of us that served before. And I would also reiterate the statements of I'm blocking on her name.
Dr. Gregg.
Dr. Gregg made earlier, which I thought was very well said, because I think the wellness function of the medical board needs to remain, and hopefully can promulgate those things that the previous committee tried to engender.
So let me ask you a question, and I hate to do this because this is not the normal thing with public comment, but given that you are a previous member,
yes.
In your opinion, would a task force part of education be enough, or would your recommendation be what?
Well, I had very little concept in terms of what your umbrella of education was going to include. So I come into that part of the discussion with kind of a blank slate in my mind. I would certainly advocate for a task force looking at the mission statement for wellness, and from those comments that I've heard, certainly education is going to have to be a part of that.
Okay, thank you very much. Do I have any other public comment slips? Okay, so no, thank you very much. So as we go forward with number 8, I think that your staff recommendations are excellent. You know, that it's just going to take a little longer to get there. Okay, so that the review and possibly revision, which is what you're recommending anyway, is going to be revised. That your review and possibly revise and adopt goals, that's going to be revised. And that you recommend that you direct staff to develop ways to implement the goals, well, you're going to implement the revision first, okay? The direct. And that to write articles, I would hold on to your articles. You can start to prepare for articles, but we're not there yet. Okay? So is there any other business on number 8? So, I want to thank everyone for participating, and I understand it's going to be a work in progress, and as we go forward, hopefully we'll have a better, clearer, more concrete understanding of what we are expecting to achieve, because outcomes and measurement of those outcomes are what are most important. It's not the view from the 50,000-foot level, it's from the ground up, in my opinion. So I want to thank everyone, and I'm going to accept a motion for adjournment.
Well, Madam Chair, though, I do think we need to also publicly acknowledge staff, and I know we grilled you and put you through a difficult discussion period, and perhaps that wasn't expected that was going to happen, because I know the board had given much direction in the strategic plan and where to go. But we really do appreciate this, and we, hope that the dialogue will continue.
Oh, thank you.
Thank you.
Yeah, I agree.
Okay, so let's have, before we do a motion to adjourn, future agenda items.
Did we need to make an agenda item to discuss whether we'll be one committee or two?
Well, I think the whole discussion needs to be exactly there. That would be definitely the role and responsibilities of a education and wellness organization and what it should look like. But I thought that I gave direction that should come in advance of the meeting, that we should have the opportunity to review that and revise that and send suggestions to you on that. Are there other subject matters that you want to have?
I would think, though, concurrent is an update in terms of what is happening about the wellness focus. Also, then any educational items that we think we need to bring up. I would be very helpful, again, I think you had Herb Schultz here before, if he could come and give an update about the Affordable Care Act and how it's going to impact our physician population particularly. I think that would be very helpful.
So we should have an update, but you also heard from me clearly that I would like to hear the organizations and outreach opportunities that have existed, the publications and organizations that you have reached out to and what the response has been, the ethnic diversity, and as well as the local officials that you are, media sources that you've been working with. And Dr. Solomonson?
Well, this may be moot, but I think we all had some questions about that proposed legislation about the, however you phrase that, wellness bill, if you will, that we may...
You'll get that in legislation.
Okay, so that shouldn't come to wellness?
Legislation, no.
Okay.
That comes in legislation. Okay, so I think if you have, I think you've got a pretty full agenda opportunity for the next meeting. Okay?
Absolutely.
Thank you very much, Mr. Wood. It's been very
Thank you.
interesting. Okay, so we now have, it's now 1:10. If staff could give us an idea of what we're supposed to be doing since licensing started 10 minutes ago.
If we might be able to take a short 15-minute break to grab your lunch so the licensing committee can get underway by at least 1:30.
And where's the licensing committee going to be meeting?
Right here.
Right here.
Licensing is right in here, yes.
Thank you.
Enforcement will be next door when it starts.
Okay, and where do people go?
And it will start at 2:30. It's outside. Ali, there's a table set up. I haven't been out there yet.
Welcome to the licensing committee. We have a full agenda, and I'm asked to remind everybody that we're not surfing the net when we've got our computers on, but in fact we have the agenda on electronic format. So with that said, I'd like to call the licensing committee meeting to order and ask Ms. Lowe to take the roll.
Dr. Bishop?
Here.
Dr. Carrion? Ms. Chang?
Here.
Dr. Diego?
Here.
Dr. DeRusso?
Here.
Ms. Shipsky?
Here.
Dr. Solomonson?
Here.
We have a quorum.
Thank you. It looks like we shall begin with some public comments not on the agenda. I've been given some speaker slips. If anyone else would like to speak on non-agenda items, please. So I'd like to begin with Mitchell Feynman. Dr. Feynman?
Is that not on the agenda or on the agenda?
Oh, I'm sorry. You handed them to me too soon. Okay, any items not on the agenda? Any speakers? Okay, alrighty. 12 will be an interesting, vigorous discussion. Seeing none, let us move on to, I think we should have, indeed, approval of the minutes from the February 12th, 2012 meeting.
Motion to approve.
Any additions or corrections? Any public comment on those minutes? May I have a motion to approve the minutes?
So moved.
And a second? Second. Okay, all in favor of the minutes?
Aye.
Any opposed? The minutes are approved. February 2nd, 2012. Thank you for the correction.
Actually, I think it's...
That's not correct?
I think it's May 3rd.
Oh, well, that'll teach me to use a cheat sheet. There it is, May 3rd. I stand doubly corrected. Thank you. Am I using the right script? Yes, Thursday, July 19th. Okay. So now an update on licensing. Mr. Warden?
Okay, I would like to start off with updating you on the licensing staffing. First, I'd like to thank staff for doing an excellent job this past fiscal year. We did a tremendous amount of work and did it quite well. We currently have 3 vacant positions, which is the lowest we've had in a long time, and actually 2 of those positions are filled, and the position, people will be starting them on Monday. So that leaves us down to 1 vacancy in licensing. And we recently filled several positions, including a cashiering position, licensing position in the front end that helps initialize the initial process of applications, an additional international medical school analyst to work on international medical school recognition. That was a promotion for one of our analysts, so we backfilled that position, his position, with another person from within licensing, which caused the vacancy for my assistants. So that position has been advertised, and we'll be interviewing for that soon. We also hired 2 U.S. file reviewers and 1 limited term file reviewer for U.S. applicants. And upcoming challenges for licensing program regarding staffing is which will probably cause delays in the licensing workloads numbers, is that staff now must take 1 furlough day per month. That equates to 376 hours of lost productivity per month for licensing. That adds into a total for 4,512 hours of lost productivity for the fiscal year. Staff also must take 2 personal development days in addition to that, and that adds another 752 hours of lost productivity, and that's for a total of 5,264 hours of lost productivity that we'll experience this fiscal year from different types of furloughs and required days off. So that does not include our retired annuitants or assistants, that's just our permanent staff. Another thing that's going to impact licensing is all of our student assistants cannot work past August 30th. So we will lose we have currently 6 students working for us, and we will lose their ability to work for us at the end of August. And then we also have 7 retired annuitants working for us, and with the licensing, or the state's only allowing what they consider to be mission critical retired annuitants to work. We have submitted them as mission critical, but we're still waiting for the answer on that. And they can only work until August 30th unless they have been declared mission critical. And we also currently have approximately 12 licensing staff that are in some form of training for their jobs. And in addition, we have 4 staff on leave. Fortunately, one of them plans on returning on August 1st. The managers and I will continue to work on our goals and trying to maintain and make adjustments to maintain our goal of 45 days for initial reviews. And that concludes my update on staffing.
Thank you. Any committee member comments on staffing or questions? Any public comments? Then I think we can move on to the update on the business process re-engineering recommendations. Again, Mr. Warden.
Okay. So the staff has continued to work on the physician and surgeon's application and developed a new application fee and checklist. The latest draft of that has been submitted to us from our last revision of changes, and that will be reviewed by executive management in the next few weeks. Hopefully we're getting towards the end of that. It has had legal review previously. We're just double checking most of our work right now, and we plan on rolling that out very soon. Once that's been able to be rolled out, we're going to try to do the updates on the website, which is the main next step. So the website will be updated to include all those things, and we also plan to have maybe a interactive question thing for the new physician application to help answer some of the questions that they can click on, and it will tell them why they need to mark box for the criminal record checks and the boxes. So that was planned for that. And then the update on the policy and procedures manual is that's sort of been put on hold while we're doing other things with different priorities. However, some of that is also because we don't have the new application finished and we don't want to recreate it twice. We do have a new program for PolySom, and the policy and procedures are being drafted in that, and we'll be testing them out with our new applicants. I'm making sure that we got everything covered on that. That concludes my report on that.
Well, thank you. And I just, on a sidebar, have to say I just did the reapplication process personally online, lightning fast. And I'm not that computer savvy, so my kudos to your work on that. And hopefully the new applicants will find it equally pleasing. Any other committee members? Comments? Public comments? Thank you. Then I believe Ms. Lowe is going to give us an update on the implementation of SB 100, which is the outpatient surgery center requirements for the licensing program.
Good afternoon. This is to provide you with a status report on the progress being made to implement Senate Bill 100 regarding outpatient surgery settings. And if you could please refer to page 100 of your board packets. And before I get into the status of the implementation of SB 100, I'd like to provide some history on the laws regarding the outpatient surgery settings. Currently, California law prohibits physicians from performing some outpatient surgeries unless it is performed in an accredited or licensed setting. Existing law specifies that on or after July 1st, 1996, no physician and surgeon shall perform procedures in an outpatient setting using anesthesia except local anesthesia or peripheral nerve blocks or both, complying with the community standard of practice in doses that, when administered, have the probability of placing a patient at risk for loss of the patient's life-preserving protective reflexes, unless the setting is specified in Health and Safety Code section 1248.1. Outpatient settings where anxiolytics or analgesics, told you I would mess that up, are excluded when administered in compliance with the community standard of practice in doses that do not have the probability of placing the patient at risk for loss of the patient's life-preserving protective reflexes. As outlined in Health and Safety Code, certain outpatient surgery settings are excluded from the accreditation requirements, such as ambulatory surgical centers certified to participate in the Medicare program under Title 18, health facilities licensed as general acute care hospitals, federally operated clinics, facilities on recognized tribal reservations, and facilities used by dentists or physicians in compliance with Article 2.7 or Article 2.8 of Chapter 4 of Division 2 of the Business and Professions Code. Pursuant to Health and Safety Codes, the Board has adopted standards for accreditation and in approving accreditation agencies to perform the accreditation of outpatient settings, ensuring that the certification program shall include standards for multiple aspects of the setting's operations. The Board has approved the following 4 accreditation agencies: American Association for Accreditation of Ambulatory Surgery Facilities Incorporated, Accreditation Association for Ambulatory Health Care, the Joint Commission, and the Institute for Medical Quality. Current law provides that any outpatient setting may apply to an accreditation agency for certificate of accreditation. Accreditation shall be issued by the accreditation agency solely on the basis of compliance with its standards as approved by the Board under Chapter 1.3 of the Health and Safety Code. Pursuant to the enactment of Senate Bill 100, which became effective January 1st, 2012, Health and Safety Code section 1248.2 B, C, and D now provides that the Board shall obtain and maintain a list of accredited outpatient settings from the information provided by the accreditation agencies approved by the Board, and shall notify the public by placing the information on its internet website whether an outpatient setting is accredited or the setting's accreditation has been revoked, suspended, or placed on probation, or the setting has received a reprimand by the accreditation agency. The list of outpatient settings shall include all of the following: the name and address and telephone number of any owners and their medical license numbers, the name and address of the facility, the name and telephone number of the accreditation agency, and the effective and expiration dates of the accreditation. Approved accrediting agencies are required to update the Board on any new existing settings, as well as to provide updates on current settings. The database will be used to reflect current and future information and will not be a historical reference for past actions that may have occurred. Prior to Senate Bill 100, data was reported to the Board from the 4 accrediting agencies. However, it was not done in a consistent manner. We've now updated the reporting requirements, and data is being provided from all 4 at this time. SB 100 also requires the Board to investigate complaints related to a violation of Health and Safety Code section 1248, and upon discovery that an outpatient setting is not in compliance with a specific provision, bring an action through or conjunction with the district attorney to enjoin the outpatient setting's operation. The Board's licensing program is currently working directly with the Board's enforcement program to ensure that any complaints or adverse actions reported are reviewed and investigated as required by law. Further details on these processes and the procedures for handling complaints and actions will be presented by Ms. Katie in the Enforcement Committee meeting. Meetings were held between the board and representatives from the accreditation agencies in order to determine the logistics of obtaining their accredited settings data. Standard templates were provided to the agencies and data was provided in electronic format, which is compatible with the database design that we have been working on. Data has since been obtained and has been imported into the database. However, staff is currently working with the accreditation agencies to obtain additional information that has not been provided. We did go live with the database on July 18th, and it is now available from the board's website. As additional data becomes available from the accreditation agencies, board staff will be updating the records accordingly. Currently, though, if we've not received data as required, the fields in the database will reflect none reported. The board's IT staff is still improving upon the database and will continue to enhance the features, which will include incorporating the ability to view documents such as final inspection reports, plans of correction, and corrective actions completed. And although the documents are not available on the website at this time, consumers can contact the licensing program to obtain copies of those public documents if necessary. And now that the database has been released, the board will begin the process of notifying consumers of the availability by providing information in the board's newsletter, sending out information in an email via the board's subscriber list, and providing links to the database from the board's website homepage. So I can now show you the database, but just please keep in mind it is still a little bit of a work in progress. So right now, the only way to access the actual search feature is going to be through the outpatient surgery settings web page, which is already out on the web. It's just been updated with the new information. It has the information regarding what's required by SB 100 and the different accreditation agencies, and does indicate in the disclaimer that this information is being displayed is what is being provided from the accreditation agencies. It is not our data. We're not manipulating any of the data, and that's why you'll see multiple fields are reporting. Nothing was reported for that at this time. Okay, so when you open up the database, it's going to give you brief instructions on the different search features. You're at this time able to search by a setting name or an owner name. In the future, we will be enhancing it to also allow you to search by accreditation agency. I'm pushing the wrong button. Okay, so the search feature allows you to do keyword searches, character searches, or actual names of the facilities or owners. And it'll provide you with all of the settings for the 4 different accreditation agencies across the board. We have it separated up here by the 4 different types. If a setting is accredited by multiple accreditation agencies, there'll be multiple check marks reflected. I'll go ahead and select one. When you select a facility, I'll pull up the information, and all of the required fields for SB 100 are included in this, with addition of other fields that we felt would be useful information to the public, including the doing business as. There's quite a few settings that will be accredited doing business as another business name. Also, setting types will be listed, and specialty types. If there's multiple specialties, all of the different specialties for the settings will be listed, and all of the owners will be listed as well. Once you pull up a setting, if you want to review a owner's information, you can click on that directly, and it'll take you to their profile information in the database. You'll see that we have the owner's name listed, but we don't have a lot of the additional fields that we've asked for. This is something that we're continuing to work on with the accreditation agencies. So you're able to go from one record to the other. You can go from a setting to the owner and then see what other settings they're associated with as well. And it'll just continue to go on. So we're very happy to be able to have it out there to the public, and we'll continue to work on it and obtaining the additional fields of information from the accrediting agencies. So
Thank you. I'm going to specifically ask Dr. Bishop if he has any comments, because I know he has a lot of expertise in outpatient surgery.
Nothing specific. I worked in Virginia for a number of years. And we were accredited by Joint Commission, but I think I'm not aware of any great differences between the different accrediting agencies. I think it's a good thing.
Very good. Any other comments from committee members? Dr. Carrion, any comments? Again, another surgeon, like your perspective.
My experience in my early years as a surgeon was that some of these surgical centers, they didn't pass one of these organizations, and they moved to the next,
right,
and then moved to the next until they got some license.
Mm-hmm.
And usually those surgical centers were the ones who they really had problems. Now I think it's a little bit different. They're a little bit more strict, right?
they do have additional requirements that have to be met through the accreditation agencies, and there's also laws in place that say if one accreditation agency denies accreditation, they are able to go to a different accreditation agency. However, they have to disclose the reasons why they were denied from the one.
Okay. That's very good. We're making progress.
Hopefully. Thank you. Any other comments from committee?
I have a comment also. Thank you. How about these agencies or the settings where they're not required to be accredited by us? How are those being monitored? You know, the comment about certain outpatient surgery settings are excluded.
There are certain outpatient settings that are licensed through the Department of Health, I believe, and there's a feature on our website as well that you can click to.
So they have their own licensing regulations.
Just not through us or through the accrediting.
Thank you, Dr. Diego. Good question. Any other committee questions? I don't see any speaker slips from the public regarding this item. So with that, I'm going to thank Ms. Lowe, but she's not going far because she is going to present on the allied healthcare professions.
So I'm going to need just a minute to set up the PowerPoint. This is to provide you with an overview on the allied healthcare professions that are regulated by the Medical Board of California as part of Strategic Plan Objective 2.9. I'll be providing a PowerPoint that you can follow along with in your board packets starting on page 101. The board is responsible for the licensing and regulation of licensed midwives, the RDO program, including the registered dispensing optician, spectacle lens dispenser, contact lens dispenser, and non-resident contact lens dispenser registrations. The registered polysomnographic program, research psychoanalyst, student research psychoanalyst, and medical assistants, which are regulated but not licensed by the board. I'll be providing an overview of each program individually, so if you can bear with me. We'll go ahead and begin with the licensed midwives. A licensed midwife is an individual who has been issued a license to practice midwifery by the Medical Board of California. The license authorizes a midwife to attend cases of normal childbirth in a home, burn leave clinic, or hospital while under the supervision of a physician and surgeon, specifically an OBGYN in active practice. The licensed midwife provides the necessary supervision, care, and advice to women prior to and during pregnancy, labor, and the postpartum period, conducts deliveries and cares for the newborn infant during the postnatal period. This includes preventative measures, protocols for variations and deviations from norm, detection of complications in the mother and child, the procurement of medical assistance when necessary, and the execution of emergency measures in the absence of medical help. The standard of care for California licensed midwives document is available on the board's website and further clarifies the standards required of a licensed midwife in California. There are two pathways that one can undergo to become licensed in the state of California as a midwife. The first pathway would be education, which requires one to complete a 3-year post-secondary education program in an accredited school approved by the board. And currently there are 15 schools approved by the board within the United States. The second pathway would be by challenge mechanism. Business and Professions Code Section 2513 A through C allows a midwifery student and prospective applicant the opportunity to obtain credit by examination for previous midwifery education and clinical experience. And there are currently only 2 challenge programs that are approved within the United States at this time. Once an individual has met the educational or challenge requirements, they must take and pass the North American Registry of Midwives, or NARM, examination. The examination was adopted by the board in May 1996 and satisfies the written examination requirements as outlined in law. The exam is given twice yearly and is held at the medical board's headquarters. And although staff coordinates and proctors the exam, material is provided directly from NARM and returned to them for processing. The board does not determine the exam material nor determine if an individual passes or not. In order to apply for a midwife license, an individual must submit an application form, which is available online with a fee of $300. And upon review of the application, if the individual meets the licensure requirements set forth by law, a license will be issued. Renewal of the license is every 2 years and requires the midwife to pay the fee of $200 and to submit the renewal form certifying completion of 36 hours of continuing education. Also, as part of the renewal process, the licensed midwife annual report must be completed and submitted directly to OSHPD. Data submitted on the licensed midwife annual reports is compiled by OSHPD and then provided to the medical board, which we will then publish in the board's annual report. In the last fiscal year, there were 40 new licenses issued, with a total of 252 with active licenses.
Before we move on, if we could take the prerogative of taking each of these specialties as a separate item, if we could. Any questions regarding the midwifery program? Okay. Well, no, I do. And I can't help it because there's a verb in there, supervision, which comes up with
There is very few OBGYNs today that I know that they supervise midwives. I don't supervise midwives. In the hospital that I work, that we do an average of 500 deliveries a month. No doctor supervises midwives.
So I guess my question is, I'd like to know that this legal a requirement is being carried out, because if we are the authorizing entity, namely the medical board, that are issuing the licenses, then I'd like assurance that those practicing midwives are fulfilling their part of the equation, which is to have adequate supervision, and again, we may need regulations to flesh that out. And I'm looking at Ms. Shipsky because she knows how we wrestle with that word supervision in the other committee, and I just want to make sure that we are fulfilling our mandate, or the law that is being fulfilled.
Well, Chair, I think the other thing is that we also need to differentiate between licensed midwives and certified nurse midwives, which are in a total different capacity.
Right. I don't think we're talking about
So we're talking about license, but a lot of people don't understand there is a
that's true too, but we don't have jurisdiction over those, am I correct?
No, but these individuals do home births, and the physicians are not present in the home birth.
Yeah, no, I'm just concerned.
Licensed ones, right?
They are licensed.
I'm concerned about the ones that we have issued a license for, and apparently the legislation said that they are to be supervised by an active OBGYN, if I understand that slide correctly, and I'm just wanting to make sure that
But again, the definition of supervision is very fluid, because in the case of licensed midwives, they attend home births or birthing centers. Their physicians are not present there. So when we talk about direct supervision, they are not there. And my understanding that Kurt would like to weigh in, but they have a capability in terms of telephonic contact and obviously referral if there's a difficulty. But when we wrestle this thing about laser and other things, there is no on-site supervision.
So I'm just wondering what the legislature had in mind, and are we, if we're issuing these licenses, sure that the compliance is occurring? And I'm not sure what comes back on those reports that you alluded to, what information are being, we're being given.
The actual supervising OBGYN is not provided to us. And it does say in law, though, that supervision shall not be construed to require the physical presence of the supervising physician on the premises. So they don't have to physically be there, but further definition of supervision probably does need to be there.
That's a work in progress. The board has struggled with numerous sets and regulations, attempted numerous times to define the appropriate level of supervision as required in Section 2507, has so far been unsuccessful in promulgating regulations to that effect. Not for lack of effort, though.
Go ahead.
Wasn't at one point I was told to us that the insurance company are not insuring the OBGYNs if they take up a midwife to supervise the midwife? Is that correct, or is that a correct
That's what they've
statement now?
reported every time.
Yeah.
So basically, then the legislatures have set up a situation that is not possible to have, I guess, unless you can find some OBGYNs who would like to not have malpractice coverage.
So my comment is, in the only thing that we need to worry about is, do they have supervision? In order for us to issue a license, they have to have supervision. And if they don't have supervision, then we shouldn't issue a license the way the regulation states, right? I mean, that's, whether they should or shouldn't be present, not be present, the insurance get it, it's just what is stated to us is, in order to get a license, they have to have supervision. And if that's not happening, then we shouldn't be issuing licensing, and then we should go back to the drawing board and figure that one out, right?
Janet, my suggestion is that at the moment we issue the license for the midwife is going to name Dr. ABC, and the board is necessary to contact those doctors and be sure that they are supervising the midwife. That is the only way that we are going to protect the public.
Respectfully, Madam Chairman and members, I think we're straying a little bit off topic here. This is supposed to be a sort of a an informational, disclosure about the people that we license, the medical board license, other than physicians and surgeons. If the board or if this committee wants to take a look at the licensing requirements of a licensed midwife in case any regulatory or statutory recommendations or changes about having the supervision or disclosure of the supervising physician at the time of application or licensure, I would respectfully suggest that we agendize that perhaps formally at the next meeting, but it's.
I appreciate that. I appreciate that very much, and I'd like to suggest that someone might want to have that put on the agenda to make sure that our licensees are in compliance with the law.
Right. But wasn't there something that the midwife committee is working on this exact same subject of supervision right at this moment?
But it doesn't matter if they're working on it or not. I mean, eventually it'll get flushed out and settled. But for right now, this is how the law states. And so I would like to put that on the agenda.
Can we do that in conjunction with the advisory committee on midwifery? Because we have an advisory board on this entire subject.
They're working on it. So
Currently, the Midwifery Advisory Council is working on the supervision of student and assistant midwives by other midwives. It's not the
Okay, well, that
physician
sounds like
involved.
it's two different things, and a two-pronged attack doesn't seem wrong, because one is kind of a procedural thing, which I think is in the domain of licensing. So I'd like to accept that agenda item, but please, Dr. Diego, if you bring that up at the right time when we ask for new items, please recall that. Any comments further? Then I guess we'll move on to the next specialty, which the optician program.
Correct, the Registered Dispensing Optician Program. So this program is comprised of 4 different sections. There's the Registered Dispensing Optician, which is for the business, contact lens dispenser, spectacle lens dispenser, and a non-resident contact lens dispenser registration. The Registered Dispensing Optician, also known as the RDO, is required for any individual, corporation, or firm engaging in the business of filling prescriptions of physicians and surgeons, osteopaths, or optometrists for prescription lenses. This registration is for the actual business location. In order to conduct business or fill prescriptions at the RDO must employ a spectacle lens and or a contact lens dispenser. And the RDO cannot stand alone without the other types of license registrations.
Interesting.
In order to apply for an RDO registration, an individual must submit the application form, which is available online with a fee of $75. And upon review of the application, if they meet the business requirements set forth in law, and includes information on the spectacle lens dispenser and or contact lens dispenser that will be working there, a registration will be issued. Registrations in California. The spectacle lens dispenser registration is required for any individual working in an RDO who is fitting and or adjusting spectacle lenses. Spectacle lens dispenser cannot stand alone, again, without being associated to that RDO. To obtain spectacle lens registration, there's not an educational requirement set. However, they must take and pass the American Board of Opticianry, or the ABO examination, which is given twice yearly. This examination was adopted by the board and satisfies our written requirements as outlined in law. In order to apply for spectacle lens registration, an individual must submit the application form, which is available on our website with a fee of $75. And again, if they meet the requirements in law, we'll issue the registration. The renewal is also 2 years and is $75. And
Fees and how often are they evaluated?
There may be a readjustment of fees unless we're at a statutory cap, for example.
Thank you.
So in the last fiscal year, there were 196 new spectacle lens dispenser registrations issued, totaling 2,182 with current registrations. The contact lens dispenser is much like the spectacle lens dispenser. It's for the individual working in an RDO. They cannot stand alone without being associated, and it's used for those fitting and adjusting contact lenses. Again, there's no set requirements for education. However, for contact lens dispensers, they must have taken and passed the National Contact Lens Examination, the NCLE, which is also given twice yearly. And the exam also meets the requirements of the board. And again, in order to apply for this, one must submit an application, which is available online. The fee is $75. And the renewal for this is every 2 years with a renewal of $75. Last year, there were 73 new registrations issued, currently 902 with active registrations. The non-resident contact lens dispenser is required pursuant to Business and Professions Code 2546.1, which is required for any individuals, partnerships, or corporations located outside of California that ship, mail, or deliver contact lenses at retail to a patient in the state of California. With regard to any person subject to registration pursuant to this, only replacement contact lenses provided may be provided pursuant to a valid prescription, may be shipped. In order to apply for the non-resident contact lens dispenser, they must submit the application with a fee of $100. For this, there are additional requirements because a lot of these are online businesses, so we make them submit proof of a specific warning that's required by law, as well as proof of an 800 number available for consumers. And they also have to show current active registration within the state that they are if they have laws requiring it for businesses selling contact lenses. The renewal is also every 2 years for this, and the fee is $100. Last year, we did not issue any new registrations for this. There were a total of 11 current last year. I do know of a couple that are coming through right now. I think we've recently issued one, and we have one that is about to be issued. I believe that we'll be seeing more of these types of registrations with the internet sales, and I'm sure this number will be going up.
Any questions on any of the optometry specialties? Okay, thank you. We'll have you move on then to the polysomnographic program.
Okay. The polysomnography is a treatment, management, diagnostic testing, control, education, and care of patients with sleep and wake disorders. This is a new program to the medical board that we began regulating in February of 2012, so it's new to all of us. Polysomnography includes, but is not limited to, the process of analysis, monitoring, and recording of physiologic data during sleep and wakefulness to assist in the treatment of disorder syndromes and dysfunctions that are sleep-related, manifest during sleep, or disrupt normal sleep activities. Under the polysomnography program, there are 3 types of registrations that can be obtained. There's the polysomnographic trainee, the technician, or the technologist. The registered polysomnographic trainee registration is required for individuals under the direct supervision of a supervising physician and surgeon, polysomnographic technologist, or other licensed healthcare professional who provides basic supportive services as part of their educational program, including but not limited to gathering and verifying patient information, testing, preparation, and monitoring, documenting routine observations, data acquisition and scoring, and assisting with appropriate interventions for patient safety in California. In order to qualify as a polysomnographic trainee, one must have either a high school diploma or GED and have completed at least 6 months of supervised direct polysomnographic patient care experience, or be enrolled in a polysomnographic education program approved by the board. They must also possess at the time of application a current certificate in basic life support issued by the American Heart Association. The registered polysomnographic technician registration is required for individuals who may perform the services equivalent to that of a trainee under general supervision and may implement appropriate interventions necessary for patient safety. In order to qualify for the technician registration, an individual must meet the initial requirements for a trainee and have at least 6 months experience at the level of a trainee. The polysomnographic technologist registration is required for individuals who are under the supervision of a physician and surgeon, are responsible for the treatment, management, diagnostic testing, control, education, and care of patients with sleep and wake disorders in California. Registration requirements include having a valid credential as a polysomnographic technologist issued by the Board of Registered Polysomnographic Technologists. They shall have graduated from a polysomnographic educational program that has been approved by the board and shall have taken and passed the Board of Registered Polysomnographic Technologists examination given by the Board of Registered Polysomnographic Technologists. However, on this requirement, if we receive an application on or before October 22nd, 2012, in lieu of this, submission of documentation from the supervising physician indicating that the individual has engaged in the practice of polysomnography safety for 5 years will be accepted in lieu of that. Again, in order to apply, the applications are available online. The application must be submitted with the application fee of $200, and upon review, if they meet the requirements in law, we would issue the registration. Renewal is every 2 years, and at the time of renewal, the form must be submitted with a fee of $150, and again, verification of the basic life support is required at the time of renewal. And we have not yet issued any polysomnographic registrations at this time. However, we do have applications pending or are in the process of getting those issued.
Madam Chair, do we have a definition of what constitutes supervision for these folks?
Will you not?
No.
I noticed the word direct was in there a time or
Only
two.
on one of them. The other one was general supervision. And having undergone this kind of testing, there are no physicians present on those facilities. These are all done by tech. So when we are trying to grapple with the issue of what we're calling about supervision, it is across the board. It is
No,
not.
that's why I'm saying that we grappled with that with the laser as well. So no, absolutely parity.
I just like to say, reiterate what I've said at the prior committee. I think that the concept of supervision should not be compartmentalized to any specific discipline, any specific location. The concept of supervision is a generalized concept that has to be based on a few general principles that I won't elucidate again today. If you want to hear those, we spoke about this last time at the Supervisory Committee, and I'll speak about them again today. But I think reproducing this discussion again and again really is not reasonable. We should have one basic definition of supervision.
Yes.
It's a concept that's not difficult. In my profession as an anesthesiologist, I supervise anesthetists and have done for 20 years. And it's a very clear concept, I think, within the medical field with great background. So I think we should really try to grapple this with all of our licensees.
I appreciate that. Thank you.
Well, and the other thing, are we making a requirement on this for these people to disclose who their supervising physician is? No. So if we are going to make these changes for other licensees, it seems to me we need to do this across the board. Otherwise, we are singling out
I agree.
an area.
So the optician people have to disclose where they're practicing. They can't do a standalone. Correct. So, there's...
That's a corporate indication of where they're dispensing from, not necessarily requiring an ophthalmologist or an optometrist to certify that they're supervising them in any way.
Right.
They're really free agents in many ways.
Right.
Yeah.
If I could just for a moment, Ms. Shifsky is exactly right. The RDO program is uniquely distinct, and it's one of the few licenses / registration / permits we issue to actually bricks and mortar physical location. Most of the licenses we issue are personal.
Right.
Okay. Any other comments on the polysomnographic program?
The only thing is, I see where the trainee and the technician and the technologists, the trainee and technologists seem to have more defined duties, but I don't know what, for the technician, what appropriate interventions mean.
Just a second. This is Mr. Salgado, also a licensing manager, and he worked on the regulations for the Polysome program.
Basically, the technician is a position outside of the trainee who has accomplished the education. The trainee is a person who's still in the schooling, and so a technician would be one who completed the school but yet has not had 6 months of experience outside of the school.
What I'm more concerned with is the technician may implement appropriate interventions necessary for patient safety, and I don't have a good sense of what appropriate interventions are.
It usually means to the sleep apnea center that they can initiate CPAP.
Or wake them up.
Or wake them up.
Oh, that's
right.
Jaw lift, sleep apnea.
All right.
We'll be getting more information out on that, not only to us, but also on the medical board's website on what can and can't be done. So.
Okay, fine, thank you.
And I have a comment in regards to the supervision. These individuals are not just supervised by physician surgeons, but they can be supervised by the polysomnographic technologists that we approve and by other health care professionals. So we'll more define the supervision, but it's not just physician and surgeons that are the only people who supervise these individuals.
Okay, so we'll be moving on to research psychoanalysts and student research psychoanalysts. A research psychoanalyst registration is required for any individual engaging in psychoanalysis as an adjunct to teaching, training, or research. Additionally, students who are currently enrolled in an approved psychoanalytic institution are registered with the medical board as student research psychoanalysts, and they may engage in psychoanalysis under supervision. Again. Psychoanalysis is defined as a method of analyzing psychic phenomena and treating emotional disorders that involves treatment sessions during which the patient is encouraged to talk freely about personal experiences. Registration requires that an applicant has a doctorate degree or its equivalent and has graduated from a psychoanalytic institution approved by the board. And there are currently 19 approved psychoanalytic institutions that have been approved. In order to apply, one must submit an application with a fee of $100, and the renewal for this program is every 2 years and requires a $50 renewal fee. Last fiscal year, we issued 8 new registrations for psychoanalysts, analysts, and there are currently 92 with active registrations. And now, last but not least, our medical assistants. Medical assistants are unlicensed individuals who perform non-invasive routine technical support services under the supervision of a licensed physician and surgeon or podiatrist in a medical office or clinic setting. Medical assistants are not licensed or registered through the medical board, however they are regulated. They may obtain certified status through a private agency approved by the Medical Board of California. Currently, there are 3 different approved certifying agencies. Medical assistants may perform non-invasive, routine technical support services under the supervision of a licensed physician and surgeon or podiatrist in a medical office or clinic setting. The supervising physician and surgeon or podiatrist must be on the premises in order for the medical assistant to perform those non-invasive technical support services. And I've provided some examples of what are and are not in the scope of practice for a medical assistant. Training for a medical assistant can be under 2 different ways, either under the licensed physician or podiatrist, or a registered nurse, a licensed vocational nurse, a physician assistant, or qualified medical assistant. That'd be basically hands-on training in the office. or they can obtain training through a secondary, post-secondary, or adult education program. Supervision for medical assistants are a little bit more defined. In every instance prior to administration of medicine by a medical assistant, a licensed physician or podiatrist or another appropriate licensed person shall verify the correct medication and dosage. The supervising physician or podiatrist must authorize any technical supportive services performed by the assistant, and the supervising physician or podiatrist must be physically present in the treatment facility when procedures are performed. And that concludes my presentation. Are there any questions?
They're unlicensed, so then they just register with us?
They're not even required to be registered through us.
Okay, so then this was for point of information what they could not do because they're unlicensed?
They are not licensed by the board or certified. However, they're regulated in law. So if there was an issue with a medical assistant,
got it.
We would be able to look into that.
Helpful. Thank you. Any other questions? All right. Well, thank you, Ms. Lowe. Any public comments on this topic? Well, then I think we're not letting...
I do have one question.
Oh, thank you.
It dawns on me that they're not licensed, or really what sort of disciplinary measures could we take if we had a problem?
I think it's against the doctor.
Yeah. It would be against the supervising individual.
Yes,
I see.
correct.
Okay, so this one
Who shall go unnamed?
What?
Dr. X.
Part of the board strategic plan 1.1, and if you could please refer to page 102 of your board packets. The board has adopted and administers standards for the continuing education of physicians and surgeons licensed in the state of California. The board requires each licensed physician and surgeon to demonstrate satisfaction of the continuing education requirements at intervals of not less than 4 nor more than 6 years. Currently, each physician is required to complete not less than 50 hours of approved CME during each 2-year renewal period immediately preceding the expiration date of their license, except as permitted by current law, which states that any physician who takes and passes a certifying or recertifying examination administered by a recognized specialty board shall be granted credit for 4 consecutive years of continuing education. Approved CME consists of courses or programs designated by the American Medical Association or the California Medical Association as Category 1 credits, which are related to one of the following: patient care, community health or public health, preventive medicine, quality assurance or improvement, risk management, health facility standards, the legal aspects of clinical medicine, bioethics, professional ethics, or improvement of the physician-patient relationship. Physicians are required to sign a certification statement indicating that they have complied with the requirements, as well as answer statements related to the CME that they have received as part of the renewal process. If the certification statement is not signed or any of the CME statements are not completed, a hold will be placed on the license and the renewal will not be completed. Follow-up to the renewal deficiencies is performed by the cashiering unit of the board as well as Department of Consumer Affairs cashiering unit. At the time of renewal, documentation of hours is not required. However, Title 16 California Code of Regulations, Section 1338, does require the board to audit a random sample of physicians who have reported compliance with the continuing education requirements. If selected for the audit, proof of attendance at CME courses are required to be submitted. And if a physician fails the audit by either not responding or not meeting the requirements set forth in law, the physician will not be allowed to renew their license. The physician will be allowed to renew their license one time. However, following that period, they will not be able to any longer. Furthermore, a physician may be charged with unprofessional conduct for misrepresenting compliance with the CME requirements. And in the past, the board performed the CME audit once annually. And this kind of gets into the history of the audit. It was performed one time a year, which was a major endeavor for board staff because the process was mainly a manual process. It resulted in the audit taking an average of 6 to 9 months from start to finish, and once the audit was completed, it would be starting all over for the year, for the next year. With the advancements in technology and the experienced IT staff that we have at the board, the process to complete the audit has now been mainly automated. It was revamped in January of 2011. Currently, the audit is able to perform an audit of approximately 10% of physicians and surgeons with current licenses in California. The process to select the physicians and surgeons to undergo the audit is now an automated computer-driven procedure based on requirements that are programmed into the reporting system. And upon receipt of documents, the process is still the same in that it is manually reviewed by staff to ensure compliance is obtained prior to the next renewal period. The new process is much more streamlined and efficient, and it's allowing us to audit more physicians to determine compliance, which will allow in the end better consumer protection by ensuring that the physicians are meeting the requirements for continuing education. In 2011, there were over 10% of the physicians audited that had failed. We're always looking at ways to improve numbers. And some ideas that we are looking at in the licensing program is to provide additional information to physicians and surgeons about the available opportunities for continuing education and the requirements that are set forth in law. The board's strategic plan, Objective 3.1, does mention that to conduct outreach to various organizations such as hospitals and group practices through providing speakers or articles for their publications. And this may be something that the licensing program can work directly with the Public Affairs Office to get more information out there in the public. We've also provided articles in the board's newsletters, and we'll continue to do that to get the word out and provide some additional information. And this does conclude my presentation. I'd be happy to answer any questions.
Any comments from committee members? Yeah, I certainly agree that in the days of automation that probably you could eliminate the audit by having the where it's just automatically reported. Save the
It does save quite a bit of time, and we're able to audit more. So
it's the honesty thing that's very discouraging, actually. That's discouraging. Doesn't look good, does it? Any public comment on that item? Well, then I think we are ready to move on to the next agenda item. Get it right? Yes. Let's see, that will be Ms. Ocido? Oh, and Mr. Salgado, it looks like. Excellent.
Good afternoon. This is an update on the polysomnographic registration program. The medical board has created a report based on the renewal survey of renewed and current physicians and surgeons, and we have identified their practice specialty, either their primary, secondary, or board certified in sleep medicine. And approximately 700 licensed physicians and surgeons were identified and were notified via mail with a letter announcing that the registered polysomnographic program is operational. The board's website is in the process of being continuously updated. Currently, we are in the process of developing an announcement page and a facts, answers, and questions section. The board has seen an increase of telephone and email inquiries regarding the program, and we have been promptly responding. As of date, the board has received a total of 59 applications. 55 of these applications are for the technologist level, and 4 are for the technician level. All of the applicants have been notified via mail that their applications have been received and are in the review process. The board has obtained and filled a new position which incorporates the duties of the outpatient surgery center reviews and the registered polysomnic program. Currently, Daniel Mendenhall and I will continue to handle this program until an appropriate time for transitioning is identified. We are also in the process of fine-tuning and developing the policy and procedures and developments with the new licensing systems that we're in the process of. And this completes my update on the polysomnographic registration program.
Excellent. Any comments? Perfect. And then Ms. Cito on the licensing format.
If you'll take a look at your agenda packet, at the May board meeting, Ms. Yaroslawski requested that the members have an opportunity to comment, engage in discussion, perhaps make suggestions or recommendations for the board's annual report. So within your packet, we've included 4 samplings dating back to 1999. And as you will notice, the years as they went through, we improved the format. It became much clearer. We've also included new data that's required to be reported. So at this point in time, I'd like to open the floor for any comments, any suggestions, recommendations that you would like to make to staff that might make this clearer or perhaps more informative.
Any comments from committee members? Public comment? Wow.
Okay.
Very good.
On that case, we'll conclude this report, and the next annual report will look very similar to this one, the 2010-2011.
Beautiful. Thank you. Now, an update on international medical school recognition, Mr. Warden and Dr. Silva.
Okay, I'd like to start off with, if you would turn to page 140 of your packet, I'll give you a summary of what's basically in the packet, and also in the attachment of which is on page 148. Basically, international medical schools, the board is authorized to approve medical schools based on Section 2084 of the Business and Professions Code, and the schools that must meet the requirements of 2089 and 29.5 of the Business Professions Code, in addition to also Section 1314 of the California Code of Regulations. U.S. and Canadian medical schools are approved through the LCME, which is the Liaison Committee on Medical Education, and they are not part of the same review process, but the review process for the international medical schools is very similar to what a U.S. school would go through that the Medical Board of California does. Prior to 1985, the board staff did not conduct any international school reviews. If the school was listed by the WHO organization, which is the World Health Organization, the staff sort of just issued the code back at that time. That was sort of the standard that people were using. If the school got put on that list, then they were considered a medical school. However, there's a flaw with that, and is that anybody could request to be put on the list. If somebody opened up a school, they could actually get their name put on the list without any review of the school. Since that time, there's another organization, the International Medical Education and Research, was established by the, as well as the Foundation for Advancement of International Medical Education and Research, and it was established by the Education Commission for Foreign Medical Graduates. They've established a list that we call the IMED list, which is the International Medical Education Directory, which lists medical schools that are currently out there internationally. But once again, they do not actually review the medical schools for whether or not they're competent or not. However, ECFMG does make a determination on whether they allow someone to take the USMLE's exams and get an ECFMG certificate, which is a requirement for licensure. Right now, there's over 2,000 plus medical schools, and for our purposes, it's close to 3,000 because any medical school that has any ownership change, name change, or anything of that nature would require us to review it again. And there are several schools that, even though they're on our list, we have approximately between 14 and 1,500 schools on our list. Many of those have had changes, and they need to be re-reviewed, and some of those schools have had multiple changes. All international medical schools originally were founded to train that were, in the old sense prior to the 70s, were generally founded to train citizens of the country that they were going to practice in. That has sort of changed. In the early 80s, they started having medical schools that were being open to train non-citizens to practice here in the U.S. In the spring of 1983, the U.S. Postal Service discovered a scandal involving a widespread production of fraudulent medical diplomas and other practices in some of the medical schools. Specifically, CTEC and CFIS were in the Dominican Republic, and they were run by other people within the U.S., and they were just issuing diplomas, basically. As a result of that, there was an investigation, and that several schools were found to have been falsifying education. Two of those schools have been closed, and all those schools that were licensed here in the United States, medical boards all over had to review these applicants and determine if they actually qualified or not. Several people did not pass that test. So the Division of Licensing realized they needed to take corrective steps to protect Californians from patients being treated by students and graduates from schools that did not meet the minimum requirements of law. The Division's first act was to disapprove 6 of the proprietary medical schools that were either implicated in the scandal or were in violation of California law. Subsequently, the Division conducted on-site inspections of some of those medical schools and developed an orderly process for evaluating new proprietary international schools that attracted U.S. citizens. Of the 12 schools that the Division reviewed in the Caribbean and the Dominican Republic, 4 were recognized, 3 were disapproved following a site visit inspection. In addition, 5 disapproved schools after they failed to respond to our inquiries. In each instance where a school was challenged, our authority to disapprove them, the courts upheld our authority. A task force was formed in 1983 to help develop and sort out the documents of schools and applicants. Upon the recommendation of the task force, the Division of License adopted a set of guidelines for the licensing program, staff to follow in evaluating medical school education of individuals who were trained outside the U.S. or Canada. The policy was adopted by the Division in 1983, including the concept of remediation, allowing students who are short in training areas to have options to take additional courses and correcting their deficiencies. This permitted a eventual licensure of numerous applicants who attended Caribbean medical schools, and after the guidelines were implemented on an interim basis, the task force conducted a survey of the curriculum of all 128 U.S. schools and used that data to develop the regulations that we now use to evaluate international schools. Currently, there are several medical schools. While in the late 1980s there was dwindling enrollments, school closures in the Caribbean, the 1990s saw an expansion. All targeted U.S. citizens and some Canadian citizens at that time, and all promised clinical clerkship rotations in the United States. In addition, a number of the Eastern European medical schools opened English language programs. The promise to prepare students to pass USMLEs and practice medicine in the United States. Several of the countries involved in this were Hungary, Poland, Czechoslovakia, Slovakia, Russia, Armenia, and recently China has opened several English language programs. The approach to their teaching is that they will teach in the 2 basic years at their country and allow students to either do clinical rotations in their country or possibly elsewhere. And a lot of the elsewhere is in the United States. And some of these medical schools do not have any way of actually knowing when the students actually completed their rotations. So that's one of the reasons why we do that. So even though the medical school might be recognized by us for their education, for their primary citizens, these English language programs we consider to be preparatory schools, and they must meet the requirements of California Code 1314.A1 or A2, so .1 A2. So based on that, you'll see on page 142 we have a chart of schools that we have recognized with site visits, recognized without site visits, English language programs granted recognition depending on the review of the documents, and also medical schools that have been disapproved. And that chart goes all the way over onto page 143. Right now, there's medical schools are opening in lots of places and lots of English language programs. We get telephone calls every day regarding some schools that I'm not even aware of existed and for a while. And we recently received an application from an applicant for school, and the school is not even listed on the IMED list at this time. So there's schools everywhere that a lot of us do not know about. The review process from international medical schools consists of 2 basic types of medical schools. 1314.1 A1 exempt schools. Those schools are sort of meet the requirement by being a school that was established for the country's citizens and are nonprofit entities, and the schools are designed to teach the citizens of the country to practice medicine in their country. The A2 schools require a much more in-depth review, and they're basically, they can be, most of them are for-profit, and their primary purpose is to teach citizens of other countries. And specifically, we're looking at them for meeting our requirements. So those are the 2 different ways. How do schools apply to us is depends on how they come to us. Some medical schools know they need to apply to us for recognition, and they submit the self-assessment report asking for recognition. Other types of schools, we receive an application from an applicant. The school isn't recognized for one reason or another. A lot of these applicants are some schools that may have gone to a school that we recognized at some point in time, but there's been a change. So we make a determination to try to determine whether the school falls within 1314.1 A1 or 1314.1 A2. If they fall within the review of A1, we have a streamlined process to try to determine that they actually meet that requirement, and we contact the school with that process, and expecting their school to provide us the necessary documentations for us to be able to legally determine that they meet those requirements. Once we receive all that information is reviewed by the medical board's legal counsel and myself, and once we have determined that that school actually meets that requirement of law, then we will issue that school a school code, and we'll license graduates from that school. For the A2 requirement, they must complete a full self-assessment report, and that is a 25-page document requiring lots of information. We have several of those in progress right now, and at different stages. It is a lot of work for the school. It's very similar to going through an LCME recommendation approval process, and it starts with the school submitting the documents, board staff reviewing it, trying to determine if we received enough documents and what documents they might be. We prepare a report. We provide that report and ask, if after we've determined we have all what we believe we need, we provide that report to our medical consultant. The medical consultant reviews all the information and our report. They will determine whether or not they need additional information. They almost always do, because they have the experience to know what to ask for that the staff does not. That process goes back and forth a couple of times, and then at some point we make a presentation to the board to determine whether or not we believe a site visit is necessary. The board will make a decision on that. If the site visit is determined to be necessary, then the staff will start scheduling the site visit. The medical school has to pay for the site visit. On page 145, you'll see a list of 7 schools that currently have full self-assessment reports here at the board. Of those, we have some that are with medical consultants, some that are almost ready to go to medical consultants, and some that are just recently received and will be going to staff for review. So those are where we're at. This is a very important process to ensure consumer protection to the public, to ensure that we're getting good education and not fraudulent education. There are schools out there that do not require anybody to attend their class at all. You can sit at home and do it. So it is important, and it's an issue that's sort of not just here for the California board. Each state has their own requirements for determining whether a medical school meets the educational requirements. However, we do know that a minimum of 19 states use our list. Other states, I believe, also use our list, but they're not quite as upfront about it with us. So based on that, we also need to reevaluate the medical schools on a regular basis. We have not reevaluated actually any of our medical schools that we previously approved. We need to do that. We are going to be working with our medical consultants to develop a plan on how to do that. And also, we're going to be looking before we do that at our current self-assessment report to make any necessary improvements to it to meet today's educational needs, so that we're actually evaluating them for what we currently need the schools to be meeting. And we have put off the reevaluation because we had hiring freeze, vacancies, and no one to do the job. We're at the point where we have added an additional analyst to help with that, and so we now will have 2 analysts specifically going to be working on that. Plus, we have our 3 medical consultants, and I have Dr. Silva here today with us, and who is one of our medical consultants who's reviewing schools for us, and he's we're extremely fortunate to have him because he's an expert on international medical schools and has visited many of them. And I'll let you, Dr. Silva, explain to you why this is an important process and why what he sees when he reviews these schools.
Thank you for allowing me to appear before this committee. Just a brief bio. I've practiced medicine nearly 50 years now and over 30 in California. I'm Dean Emeritus of UC Davis School of Medicine. I've been back on recall for a couple of years to assist them in developing global health programs. In addition, I've been employed by the National Academy of Sciences under contract with foreign governments to review medical education systems in a number of countries, Armenia, Georgia, Russia, Kazakhstan, Poland. I'm going to Uzbekistan in late September this year. So I've been around a tree. I've been to over 80 countries. 80 medical schools, about a dozen of them more than once, and I've been over 60 countries in my career. So I've invested a lot of attention in what's going on. I think what I like to do is just provide 4 areas of definition where these schools are stubbing their toes. And a major thing that's going to occur that you have to become oriented to is that the LCME is currently changing a lot of its educational standards. There are 5 sections for an LCME review. One of them are the educational objectives. There are 45 in there. And the 2 that are killers, that are even tripping American medical schools, is one that you have to advertise when a medical student, goes on a rotation, no matter what it is, pediatrics, OB-GYN, emergency, what kind of patients are they going to see? And then the students have to complete a diary to be certain that they're getting a complete education. The other component is that they're asking schools to develop their own program learning objectives, and you have to have data. Are your students hitting areas that will make it important for them to practice medicine in the future? 2 of them these schools can hit, and they've demonstrated that. But that's not all medical training. The 2 that they hit, of course, is the database, medical and scientific knowledge, and then also patient care. The other areas that we're asking students to provide, they've achieved mastery, are areas like communication and interpersonal skills, professionalism, healthcare systems, what do they know about it, and then reflective to their own practices and personal development. These are all new standards. These schools are not set up to understand the complexities of a country like America or a country like California with all the different ethnicities. It's an important area that we're going to put more and more demands on American and Canadian medical students. That country has obviously a lot of multiple ethnicities. I've been a consultant for about 2 years. I've enjoyed it. Staff works very hard. They're very detail-oriented. I'm not, which helps me to get my job done. But the ones that I see really where foreign medical schools hit a wall, particularly the new ones forming in the old Soviet Union, are related to not providing enough training in pediatrics. Very often they don't have departments of pediatrics. They're housed in internal medicine or family medicine. Also psychiatry is the real big hurdle for many of these schools. No training in psychiatry. They don't even recognize such a thing as a mental disorder. The other area that they continue to have trouble with is assessing their clinical rotations. Many of them list 80, 90 places in the United States or elsewhere around the world, and then you ask them, well, what were the rotations? What evaluations did you complete? How good was the training? It's just a vacuum. They're really just letting the students go out, setting up their own rotations. Many of them are in this country, and dollars are exchanged that are sizable in order for a student to go, but there's no really evaluation. And a student could leave after 2 years or 3 years, some of these are 5-year programs, and not come back for the last 2 years, never return to that parent university. So that's a real problem. The last area that they really are not asked to develop, but they will in the future, they're going to comply with LCME regulations, are all the cross-topic areas that are important for not only medical students, but residents have training to. Cross-cultural medicine, geriatrics, spousal abuse, pain control, neonatal screening, just a whole number of these areas that we have to have cross-cutting, and that they go over to 4 or 5 years of training so that they are introduced to concepts that are important for future practice that are not related to any single discipline. And of course the state has certain laws for CME to keep physicians up to snuff in many of the areas we felt that the medical schools were deficient, and we were, and we're trying to solve that. So that concludes my report and observations.
I wondered if either of you gentlemen, we were briefly on price bill, where the legislature now feels that we do not have to evaluate medical schools. In fact, for someone to be licensed in California, all they need to show is that they pass USMLE and that they have also done an internship somewhere. And even a disapproved medical school would be adequate for licensure.
I think it would be a disaster. It's on a trajectory that will cause harm to patients in the state, bottom line. And I've rounded with students my whole career. We're still round with students and residents, trained thousands. And the textbook stuff, the things we can test for, are only a small part. I don't care what your degree is, but in the healthcare professions, there's always a huge amount of data necessary to be successful outside the classroom and the textbooks. And that's what these schools lack.
Thank you.
Well, I so appreciate your expertise and your comments. Any other comments, Dr. DeRusso? You've some great experience in education.
The only thing I would say is I've had the opportunity to work with Dr. Silver at the University of Davis Medical School for at least almost 30 years. Yeah. And everything he said is is true, and I think he's being a little modest in that regard. So I'll say that. And I had the opportunity as a board member to represent this board in evaluating a school that's on the list. I think the American University of Antigua, which was recent, but sort of recent, and they seem to have got it.
They got it together.
Got it together. And if that's kind of a model, I mean, for the others to emulate, it would be a pretty good model, I think.
Agree.
And so, but I agree with your assessment, Dr. Silver. And the thing I wanted to say, though, is I wonder if we, as we look at the requirements, as we look at the contemporary issues, as we look at healthcare reform, I mean, you spoke, Kurt, of the needs for California. And in my view, in a couple of years when healthcare reform is fully implemented, that is going to suggest a great need. And I don't know how we communicate with these schools who want to be certified by this board, that are international schools, to begin to meet the need, or even if we are considering those kind of policy needs and big needs that maybe go beyond what is prescribed by the code.
Well, I'm not sure about going beyond the code, but of our schools that are on our list, our goal is to contact each one of those schools, because none of them have been contacted for a long time, to find out and get updated information on them, and that is part of the goal. As I said, we currently have the 7 self-assessment reports, but we also have over 100 applicants pending right now that have school codes, well, school issues, and some of those schools may be recognizable and some may not, and some may be A1 schools and some may be A2 schools, but that is a process that we have started to work on, and when we have that, we are proactive, and instead of automatically telling the applicant you're not eligible, if they've applied and we've made a determination, we'll make the contact to the school for that, to try to get the school to respond to us. And that's one of the processes we look. We sit down and we try to determine, based on the information we're able to gather, whether we think it's going to be an A1 school or an A2 school. If we're not sure, we send out letters to get more clarification. But it is a proactive approach, but it's not a perfect approach because we don't have the staffing to do 3,000 medical schools.
Well, you guys are doing a great job.
Could I just ask Dr. Silva a quick question, and then Ms. Chang? I was just appointed to the USMLE STEP committee, and they grapple with the fact that they can't test for everything. And because if that were true, it would be quite valid to just sit home and study and go take the test. What areas would you think are the things that are most missing? I mean, I've got some thoughts, but I'd be so curious with a real professional, what are the areas that you think can't be tested for and that really we need the on-site, it's got to happen at school and get evaluations?
Observations by us, not only a supervisor of a student or resident, but allied health, because more and more will be performing in teams and a group process. There's no way to get around it. The database is too big, the complexities are too great. But to have that one-on-one evaluation and consistency in advising and feedback. And of course, you want to help students along the way. Many of these are things they don't know that they're doing. And I think most healthcare professionals that I've been involved with really want to be the best person possible, whether it's a nurse or a physician, no matter. So I think that's the hardest thing. And you must induce in them systems so they can evaluate it. And a lot of it's electronically based. You have faculty leaving, a student leaving a clinic after a week, faculty member could just get on an iPad and punch in right away to the student, to his record, to his advisor, how he performed or she performed that week. So you have a lot of continual dialogue and work with students in trouble. Same thing at the residency level. So it's not going to go away. We're not talking just 4 years.
No.
We're actually talking whatever the residency period is too. Because the ACGME standards now are what the LCME has adopted as the program learning objectives.
And if you talk to these, some of the educators in foreign medical schools, some are very hip. I mean, the Germans get it, French, Italians, Scandinavians are great. You talk to them about a training rubric, and they go, what? And you say to the translator, what? And you have to have a set matrix to evaluate the students. It's not just enough to write a 2-3 line note, but you got to pick out 4 or 5 areas, and it could vary from year to year.
Right.
So it is more complicated.
Oh, totally. Well, I appreciate that. Ms. Chang.
Well, by traveling with some of the other state board members, it's actually this job of reevaluating the international school with California is important for a lot of the state because they use our list. They occasionally will say to me, Teddy, when are you guys are going to update your list? I found something in there which may not be there.
Yes.
So I thought this is a great job that you guys are doing. Now, ECFMG is talking about having a goal, setting up a list of approved schools, and they have a goal for 10 more years from now in order to come up with something.
Correct.
So do we have any conflict, or are we going to see what their criteria are?
Well, they haven't provided us very much information on that, other than that they are looking into it and what their timeline is. That when you look at the information they have, and we're on their email list for contacts, and it's been moving sort of on what I would call slowly for us. So because it's obviously a huge endeavor when you're trying to claim you're going to evaluate all the international medical schools. And so they're trying to look at ways that they can do that, and I don't know if they've evaluated all of that yet. I have heard that they may be testing a process right now, but you're still looking at the earliest they were looking at 2023, I think it was, and that's a long ways away, and we have a lot of schools between now and then. So,
thank you for the good work.
I can also add a ray of hope to this committee. The USLME has been working very hard at old national boards at revising their tests, and they're still projecting for 2015 to come out with new kinds of tests. You won't recognize it. There's no discipline in there that says anatomy, physiology. They're all case-based, but they have a lot of patient demonstrations. So it's going to be like a undifferentiated practice. You walk in the room as a medical student, take the test, and someone's there with a syndrome or a complaint, and they'll test various things that you've picked up about some of the cross-cultural areas. That you can test for.
Janet, I have a question. I am very surprised that I don't see too many Latin American universities. Maybe 1 or 2, the rest are European. They don't apply, or they don't have enough.
They may be the higher category that don't need the inspection if they're
really?
national
Thank
schools,
you.
not for profit. Is that right? If I'm
well,
understanding?
yeah.
What's the reason?
Well, as the schools, they fit one of 2 areas. If they are a government-owned and operated non-for-profit school, and they provide us the documentation for that, then we would consider them recognized. If we're not sure what they are, then we need to contact them directly, or they contact us directly, and they provide us the documentation that we're looking for. But one of the major changes in medical school education is a lot of the government-owned schools that were government-owned are not government-owned anymore. Some of the countries are going into, they're not government-owned, they're still government-accredited, but they're either private, non-profits, or they're for-profits. They've changed. I mean, it's an economic thing, and so that's why I said when ECFMG is saying there's about 2,400 schools. For us, it's more like 3,000 because we have to look at every school change. When they do it, their list is basically the current name of the school, and they might list 6, 7 other names, but they won't tell you what happened to why those names changed or what government changed. We have schools that have changed countries, not list locations, but the countries changed. right? So, you know, when that happens, sometimes they're not government schools anymore.
No, I guess not.
Right? So that's why it just depends. There's a lot of changing going on, and we haven't been keeping up with that change, and we're trying to improve our list so that we can get as many of our applicants that we can, at the same time protecting the consumers and making sure that they either fit one of the two processes.
I can tell you, since they asked about geographical area, I've visited Central South America a lot, particularly about 10 years ago. And the countries I was at, the schools are doing a much better job training than what's occurring in the Russias where I go now quite a bit, or the old Soviet Union, Eastern Europe. They're really quite ahead of what's going on in Europe right now.
That I think is a very good news for me.
Okay. But I haven't been to all the countries. I don't know what country you're from.
I am from Peru, doctor. One of the suggestions that I gave the authorities in my country is that during our medical school, we learn in Spanish.
Right.
For us, we think that we know the English very well when we arrive here, and it's not true.
Yes.
And I try to encourage that the whole medical school should be taught in English, like happening in India, Pakistan,
right. China,
Philippines, and the Philippines. That are the three main countries that they have international medical graduates here.
Very smart. Very strategic.
Well, there's a lot going out there, and I know this board has other things, but the expatriates from countries that come to the United States and are successful, very often after 20, 30 years, they want to reinvest in the country of their origin. And WHO has looked at some of the changes occurring. You said India, Pakistan, and I've been with expatriates visiting those countries in China. And they make a hell of a difference in bringing those countries up to the level where American medicine, and it's not that we're the best, but in many ways we can deliver more cures than a lot of these countries can. And they've had an amazing effect on postgraduate education just by their recurrent presentations in their home country, the country of origin. That's all I end with.
Well, I think that kind of segues into item 12, which is the discussion and consideration of a legislative proposal regarding eligibility for licensure from unrecognized and/or actually disapproved medical schools. And Mr. Warden and Mr. Hepler are going to speak to that, but I don't want Dr. Silva to go too far away. We may be asking for additional comments.
It's mostly Mr. Warden.
Okay, so please turn to page 150 of your agenda packet. In this, I'll provide a summary of this basic report we prepared for you. Some of the pages we'll be looking at I'll identify as we go along, and some of the attachments. So the first two attachments are very important, which is attachment 1 and attachment 2. Attachment 1 is on page 150.8. Attachment 2 is on page 150.10. And so to start off with, let me give you a brief summary of Senate Bill 122. Previously, Senate Bill 122 had language in it that would require the board to evaluate and license individuals who attended an unrecognized or disapproved school or who graduated from an unrecognized or disapproved school. Current law in California requires that all medical education that is eligible to be eligible for licensure must be obtained from a recognized or approved school. As we previously discussed, an approved school is an LCME school, and a recognized school is the international school that we recognize through the other process of 1314.1, and whether it's an A1 or A2 school. During the licensing committee, or not the committee, but the board, as I said, has about the 1,400 to 1,500 schools on our list that we recognize, and 10 are disapproved. there are two basic types of schools: the non-government, non-profit schools, primary purpose of teaching their citizens, and then also the school's primary purpose is to teach and educate non-citizens, and that's the two. Right now, the school recognition is critical because the board requires an applicant to be education received from a recognized school. The board does not consider education acquired at an unrecognized or disapproved school as satisfying the standards as set forth in applicable statutes and regulations. In other words, an applicant who did not acquire all of his or her medical school education from a recognized medical school would be deemed ineligible for licensure. Section 2135 and 2135.5 of the Business and Profession Code authorizes the board to issue medical licenses in non-traditional circumstances. However, the board interprets these sections to require that the applicant obtain his or her education at a recognized medical school. Additionally, an applicant must have 4 years of licensure in another state and meet other specific criteria. The specific the language that was proposed, and as I said, would have permitted exceptions to that. The basic overview of that language that has been removed from the bill currently was this: the language that was in the bill in the section code that they were going to call it was 2135.7. Would have allowed an individual who had attended and or graduated from an unrecognized or disapproved school to be licensed as a physician and surgeon in California if or she met the following: taken and passed a written exam recognized by the board to be equivalent in content to that administered in California, held an unrestricted license in another state, country, or the military for 5 years, had no disciplinary action or adverse settlements or judgments, completed 1 year of approved postgraduate training, and holds an American Board of Medical Specialty certification, and committed no acts or crimes constituting grounds for denial. That was the basic requirements. Some of those requirements are actually less than we require of our new applicants at this time, because we require a minimum of 2 years of postgraduate training for an international medical school graduate at this time. So that is part of the concern. For the basic analysis, the board's obviously the highest protection for the board is consumer protection, and if Senate Bill 122 had passed with that previous language, and which is a copy of that previous language is your attachment 1, would have jeopardized the board's ability to protect consumers from doctors who may be unqualified due to training received in an educational institution that does not meet the standards set in California law. The proposed language would have eliminated requirements for applicants to complete some or all their education at the school recognized by the medical board. In essence, this would remove the need for medical schools to undergo the review process that was designed to ensure consistency and equivalency with U.S. standards. The recognition process requires the medical education program to provide assurances that its graduates exhibit general professional competencies that are appropriate for entry into the next stage of their training and that serve the foundation for a lifelong and proficient medical career. Under the proposed language, a graduate of any medical school would be eligible for licensure in California, even if the school was not accredited or recognized by the country in which it is domiciled, or even if the board had previously determined the school did not meet acceptable standards. Even medical education obtained online, which is currently being offered through some schools in the Caribbean. So the statutory requirements serve as an incentive for many of these private for-profit schools to raise their education standards to be equivalent of that provided by U.S. medical schools. As I previously stated in the previous presentation, there's approximately 19 states that use the California list that we are aware of recognized schools when evaluating applicants for eligibility for postgraduate training or licensure. A California recognition becomes highly valuable to a school as it has direct impact on the school's abilities of the school's graduates to be able to train and practice in the United States. It's not just California, but there's several states that it affects. The Caribbean schools that have attained recognition have gone through this process of being able to prove that they have met this requirement. Without the requirement, this incentive would be removed and the drive toward equivalency would be greatly reduced. Currently, schools voluntarily apply for recognition for those type of schools. It is likely that schools will no longer subject themselves to this in-depth review or expense for the recognition process it entails. Nonetheless, under the proposed language, these schools would still be able to claim that their graduates are eligible for licensure in California. That's a huge problem for us as protecting our California consumers. Finally, although specialty board certification is a measure of physician skill and knowledge in particular specialty, California only issues one type of license, and that's a license to do any kind of medicine. Okay. And any person who has a California license can practice in any specialty. So we need to ensure that the person has had adequate education in all areas, not just one specialty. There is no way we can determine and guarantee that a physician would practice only in their specialty. You'll see on page 150.2 a possible combination of the list of types of medical school education. I believe I counted them, there were 16 possible combinations. That includes the LCME combinations. And there's quite a list of that, which would open the door to very large number of people that we currently do not accept for application. Almost all international medical schools were founded to train physicians to address medical needs of their country. And as we previously, I won't go over everything we talked about before, but as we previously stated, that is no longer the case per se. And so as the board determined that we needed to do this education review, it is important that we don't go backwards, in my opinion. So, because right now we have the 7 schools who are going through a lengthy process for us. I'm sure that some of those schools may not choose to do that if this law is changed. Okay? And the other schools that are they competing against probably will not either. Even though we do not have a fee to apply for our medical school recognition, they do have to pay for the site visits, and the site visits are expensive. Okay. As medical school education has changed throughout the years, more and more schools are opening up English language programs in their countries where English language is not the primary language of education. And so we've seen that in Europe. Now we're seeing it in Asia and China. We're even seeing it in some of the South and other countries. So as Dr. Silva alluded to, the oversight of those students versus the oversight of the students from their own country is not the same, even though they're getting, quote, the same degree. Okay? We need to make sure that we're getting the same quality of education. So, for an example, we are aware of one English language program in China that allows students to arrange their own clinical rotations in the U.S. with nothing going back to the school. Okay, so that's a problem, other than to get a signed paper that said they were there. There's no oversight of what the actual student learned. Other schools in China who have English language programs do not allow their students to go anywhere but at their own medical school. So there's a huge difference between each individual school and how they operate that. In summary, the proposed language will eliminate the need for applicants to have received their medical education by a school recognized by the board. And as I said, it basically eliminates any incentive for any school to even seek recognition by us. It is obvious that there's in Senate Bill 122, they have a concern that there may be physicians that are qualified that don't meet this requirement of law. Unfortunately, the way the law was written, it would have a huge impact fiscally on this board because of the number of potential applicants we could receive. You could expect to see at least 200 during the first, second year, and probably closer to 500, because even though these individuals are licensed in another state, they know they cannot come to California. Many of them would like to come to California and say that, see, my school is recognized in California. It increases the value of where they went to school, and it comes to us. With the way the law was previously written, we would have to accept all those applications, and it would require additional staff of at least one initial file reviewer, one additional senior file reviewer, and the additional time for a manager to review all that, because each one of these would have to go to the ARC for review. The chief of licensing has to perform a review, and the application review committee would have to meet. Currently, the application review committee meets no more than quarterly when we have applications, and generally for no more than a half an hour. It would take between close to 15 to 30 minutes per applicant to be reviewed in this process. So you were looking at, that's a lot of applicants for the ARC to review, and a lot of staff hours. It takes a minimum of 20 hours to prepare an application review committee, a memo, and provide all the necessary documents just for the senior analysts, and then for the managers and myself to review it, not to mention the preparation for the board members who have to prepare themselves for the meeting. So at 200 applicants a year, that would mean the ARC would need to review approximately 50 applicants a quarter, and that equals to approximately 24 hours per quarter, which would be sort of unreasonable for one ARC committee. So that is a fiscal impact with the way the law was previously languaged. There would be additional costs for the board meetings, additional costs for ARCs. Probably would have to have them at different times than the regular board meeting. So there's a lot of extra cost involved in that. To address some of the concerns that Senator Price was trying to address, the board has come up with some proposed alternative language for you to consider. That is on page 150.10 of your packet. So in that, the proposed language that we think would provide greater consumer protection for Californians, but still sort of reach the goal that may be acceptable for the senator and maybe even help California in the long run. It would be the following: we would increase the number of years of limited practice for those who just went to an unrecognized school to a minimum of 10 years. And for a person who went to who attended a disapproved school, that would be increased to 20. They'd also be required to have ABMS certification, and also more time for postgraduate training. So those are some of the differences that the board should be looking at on those. The fiscal considerations for the alternative language is a little bit more difficult to provide analysis for, due to that there's other options for the board to consider. And I'd like you to look at the staff recommendations on page 150.6 for some of those options. Some of those options would be trying to determine if you needed regulations or to request the regulations as part of the alternative language to identify which applications would require ARC review and possibly which ones would not require ARC review, which would have an impact on how much that would impact the board. So those are some of the recommendations. Specifically, staff is requesting that the board examine the proposed language for 2135.7, determine if the requirements are adequate for consumer protection. 2, determine if the years of licensure are adequate for consumer protection. 3, determine if there should be a provision for the possible development of regulations to implement the provisions of hybrids as listed in the previous section of the 16 different types of combinations of schools, such as attending a disapproved school but graduating from a recognized school, attending an unrecognized school, graduating from a recognized school. Those are things to be considered, and determine if all these applications need to be reviewed by ARC or if that should be addressed in regulations. So that's sort of where we're at with this possible. We do believe that some kind of language will be put back in Senate Bill 122 to address this issue. We would like to try to make it so, offer a suggestion to the Senator Price and his staff of a possible alternative that provides better protection and less cost to the board.
Any comments?
I mean, the obvious comment, right? It's like we're trying to protect the public by saying 10 years and 20 years, but what we really want to say is no, right? They're unapproved schools.
Well, I think the difference is, if I may, on 150.8, you saw what was coming out of 122. In 150.10, this would be a proposal to go back in, essentially, to 122. Dr. Diego, you're exactly right. What's on so-called this proposal clearly differentiates between a disapproved school and an unrecognized school, under the theory that an unrecognized school may be one that we haven't gotten to yet.
Mm-hmm.
But a disapproved school is something different. It's something that we have gotten to and we have looked at it, and it said it does not conform to the board standards. So that's why the difference. We have to remember that too, when you're talking about 21, this type of thing, this is not a denial, this is a question of eligibility. Eligibility for a license, they're not exactly the same thing. And finally, as one of the legal counsels to the board, my colleague here talked about regulations. I would suggest that regulations, a phrase or a clause, a subdivision D should be added if the board feels this way, if the panel feels this way, because ultimately this committee will be making a recommendation, if it so chooses, to the full board, that the board have regulatory authority to implement the provision of this section. I think there is some room for regulations here. If you look at the bottom end of subdivision A1B, you'll see, for the purpose of the subsection, we may combine the time of an applicant held an unrestricted license in various states under the theory that, if you're good in a lot of states, perhaps you don't have to be good in one for the entire 20, and I think that would call out for regulations. Also, there may be some circumstances when we talk about closed schools or schools that are no longer operative. There may be issues where you simply cannot get the necessary documentation because they may no longer be in existence. So this is modeled at 2135.7 on 150.10. It's loosely modeled on, as Mr. Warden pointed out, the existing 2135.5 section, which does allow the board to grant a license in unusual circumstances. The circumstances in this case would be that the applicant had received whole or part of their education at a disapproved or an unrecognized school. So with that, I'll shut up and answer any questions anybody could have.
And I'd like to just add one more thing. It is required that we have primary source documentation of medical school education, so that's also something you need to consider. It's not only required by our law, but the federal government, I have to sign every year that we require primary source verification. So they don't even let me do it once. They require me to do it every year. So,
it's really important. Let me tell you why I think it's important that we have to verify those schools. We talk about Sabat University, and recently a neighboring kid of mine, my neighbor, went to Sabat and then come back and telling me that they actually have very good standards there, because the first semester they let go 40% of their students they cannot pass. But look at how many people are going there. What I'm saying is, the people who goes there, that it's not like the same standards that the students come to our medical schools. They are low. I think they are people like me probably who wanted to go to medical school right at this moment, and I cannot get anywhere else, but I can get in Saba if I just apply and pay. I will not make it. I shouldn't put myself down like that, but you know what I'm trying to say. So the standard is there because they are a qualified school, so they keep a standard there. And I was impressed with that because she was working very hard. She said to me, I have to work hard in order to maintain in that school. So I truly believe the evaluation of the schools set that tune. Because otherwise, if we don't do it, there is not a true systematic way in the United States right at this moment. The only people, New York, it's accepting all 15 offshore Caribbean schools without any judgment. Anybody who goes there get accepted and goes into New York. And they can work there and then get their rotation. They buy their rotations and they get that done. So, I'm torn at this moment at, the compromise that we have to come with it. But I wanted to tell you how I feel is we should be, if we wanted to do any compromise, be tight about it.
If I may, one of the things that the board's tried to do in this proposal is essentially preserve the existing system that it has now, because if you go to a recognized school, or if you go to an American school, once you fulfill the licensing requirements, the 2 years of postgraduate training and pass the USMLE, all steps, and have necessary education, you are eligible for licensure. This would suggest that in order to make sure that there is still some value in the medical school's recognition, that there are certain additional requirements to be eligible for licensure if you have not gone to a recognized school. So that's the medical board's attempt to sort of preserve its existing recognition program.
All right. Okay. Yeah, I guess I'll buy that because I just one more point. I think the point about if it's not a approved school, I will have hard time swallowing that. Saying if it's not approved.
You mean a
school.
specifically disapproved school? We looked
Yes.
at it and
We
it was
looked at it,
disapproved.
we
You see that
disapproved
is
the
very
school.
different from not approved because maybe we haven't gotten to it yet.
Yes. Yeah.
Thank you.
And that point, I felt we shouldn't take it. That just.
Please, any other comments from Dr. Corrione? You must have a thought about this.
Well, I was just going to say, at least it's 20 years that you're putting into it, so most people probably after 20 years of practicing in somewhere in the United States must be good at doing medicine if they intend to come get licensed in California. And I would wager to bet there's not very many who are going to wait around 20 years to then get a California license. So I don't like the compromise, but there it is.
The only thing I would say personally, and I want to hear from Dr. Bishop, about the years, I feel more comfortable that they be in one or perhaps two locations, because I do think there is an issue with people moving from state to state or location to location to avoid a problem. So lack of a problem that we're aware of could be moved before they could find the problem. Dr. Bishop.
Yeah, I just want to be very cautious that we don't dilute our standards significantly. We have a great practice of medicine here in California and in this country, but I think placing language out there that says we'll allow somebody to get a license from a disapproved school for any reason sends a terrible message to people. And I think our medical school admissions process here is flawed in the United States, but it is what it is, and it certainly is better than others. And I know anecdotes are always dangerous, but let me just tell you an anecdote about a very wonderful individual that I've worked with who graduated from a foreign medical school, did their residency in that foreign country, and then came here and had to repeat their entire residency because they were so totally incompetent in their specialty. And when they started, they were a wonderful person, and they finished up the residency here and were awesome. But prior to that time, they were not functional. So I just think we have to be very cautious when we do anything. And I suspect her medical school even was an approved one, but nevertheless, the training was just not what we get. And so I want to be very cautious again not to create a two-tier system of those coming from our schools and those coming from other schools. And ultimately, I think it just is I don't totally disagree with doing something, because I think it's not, if we have great doctors, where they come from, that's great. But let us just be cautious before we jump with 2 feet into this pond, because it might have rocks in the bottom and glass and things like that.
You know, and I so appreciate that. The one thing that gave me a little comfort with respect to the compromise is that in a way, we're setting the bar a little bit higher in terms of requiring ABMS certification, and not just 2 years of some form of postgraduate training, which could be, you know, discontinuous years. So, but I do appreciate that argument that we don't license to specialty, so that person could do anything. But at least with the ABMS, we know they have. I would think I can't think of an ABS program that has less than 3 years to be board eligible. So I'm thinking indirectly that probably gives us 3 years in a program. Can you think of a specialty that's less than 3 years?
No, I think they're all three.
So I kind of, Dr. Silva, could you help us out with this?
No, I'm trying to, and nothing's coming up.
So I think if we require ABMS, we probably have 3 years of observation. I think.
I mean, there are some limited boards, but you can't take them if you take the standard.
Correct. So, okay, so I'm thinking that perhaps by having the ABMS certification in there, we're going to have 3 years of postgraduate education in programs that we do have a handle on. Do you have any I know I guess we can move to public comment, so if I can ask you, do you have a feeling about this compromise language?
I like compromises. Not everyone can walk in the same set of shoes or the same circumstances. It allows for tolerance. You have reasonable people on the board and take these one-on-one. I don't think you'd be jeopardizing the public very much with that track record. I do know, having served on the Defense Health Board for 6 years, President Bush put me on and President Obama extended me 3 years, that if they come in from an international medical school and are active military, get citizenship, they know within months the caliber of that person. They would never survive 4 or 5 years in the military unless that practitioner was really good.
Okay, that's really helpful. That's helpful. Thank you.
I would like to, with the training that we have, is when I start my residence, they told me this is like the military. And I said, yes, sir. And that's it.
With that, I think we're ready then
Madam
to
Chairman, if I could, I'm sorry. Perhaps before we entertain public comment, if we could, the committee could perhaps consider a motion, and that way anybody who wishes to offer public comment could be directed to comment on what the motion of the committee is.
Okay, very good. May I have a motion from the committee regarding, well, are you moving that we accept the compromise language? Okay. All right, well then I think it's time, and I think we've had board comment. Any more specifically, now that we have a framed motion?
Can I ask one more question? Certainly. We have to compromise?
No.
I'm sorry? And if we didn't, if we said no, unapproved schools remain unapproved schools, then what do we get?
To be candid with you, Dr. Diego, I think that's more of a political question than a legal question. If I'm fairly confident, I don't work in the legislative arena. Ms. Mose could probably answer that question, but it seems to me intuitively that this issue will be addressed legislatively in some manner.
Could we ask Ms. Whitney to comment on that?
And I'm sorry to be a stickler. Did the motion include also the suggested amendment that we would have some regulatory authority in there to implement this?
I would think yes.
Okay, thank you.
Now, does anybody, I guess I'm the one who felt strongly about if it's a disapproved school, we shouldn't give them a license. But is everybody okay with that, or can I make a friendly amendment to it?
Well, I think that's what Ms. Whitney was going
This we want to know what our latitude is, because we'd all prefer to say no completely, so perhaps you could give us a little context for what our realistic options are.
So what your best bet is to have a motion with a second and listen to public comment. We do have staff from the Senate Business and Professions Committee here who can address you, and I know there's some other folks who can address you, and then you can make some amendments to that motion if you so choose, but you need to hear from the public and the author's office.
Thank you. I think then are we ready to invite our public comments? And it looks like Dr. Mitchell Feynman wishes to make a comment.
Chair Salmonson and committee members, good afternoon. My name is Mitchell Feynman, and I'm a triple board certified rheumatologist and internal medicine doctor practicing medicine in South Carolina. I support the change of the law and the policy of the Medical Board of California to permit physicians who have over time and with appropriate credentials practice medicine in California. After my graduation from the University of Southern California, I attended World University School of Medicine in Santo Domingo, Dominican Republic. Upon learning that the school was not academically on par with USA regulators, I proactively applied to Ross University School of Medicine, an approved California foreign medical school. After their review of my medical records, or my academic records, I was admitted as a second-year medical student. From that point on, my medical education and career has been, by all accounts, fulfilling, rewarding, and successful. I did several of my clinical rotations at Boston University. I was accepted in postdoctoral programs in 1987 at St. John Hospital and Medical Center in Detroit, Michigan. I completed my rheumatology fellowship in 1992 at Washington Hospital Center in Washington, D.C. I took my boards in 1990 and 1992. I obtained licenses to practice medicine in Florida, the District of Columbia, Maryland, and Michigan in 1990, and South Carolina since 1996. I have maintained professional and academic affiliations, and I have practiced medicine in the United States for over 20 years without any disciplinary actions against me in any jurisdiction I have practiced medicine. I think I have proven to the public at large and the medical community that I am competent to practice medicine and protect consumers. I have learned that the interpretation of the law by the Medical Board of California does not even permit me to apply for licensure, not because I am not qualified or did not graduate from an approved foreign medical school, but because a small part of my medical education was at a disapproved school. That interpretation is not the letter of the law. I graduated from an approved medical school, which is the law. I have met all the other requirements under the law. As such, I support the recommended change in the law and policy to permit me to practice medicine here in California. Thank you very much. And if you have any questions, I'll be happy to answer them.
I appreciate your comments. Next, I see Mr. Stuart Hugh. Shay.
Good afternoon, members of the committee. It's nice to be before the medical board again.
To some of you who don't know me, I served on the medical board for 7.5 years in the 90s and have an active healthcare practice. The only thing that's missing here is Anita Scurry today. Yeah. But that being said, I do represent Dr. Feynman and a number of other physicians who have attended foreign medical schools. And one of them asked me to remind you that he was chairman, president of the medical board at one time, Dr. Robert DeHunko. And so foreign medical schools do play a major role in California medicine. But we are all in support of this motion because there are people like Dr. Feynman, and I have another client, Dr. Suyaba, and she practices in Connecticut, licensed in Connecticut, licensed in New York. Went to a school that no longer doesn't even exist. It was disapproved. She's double boarded. Has a fairly good proven track record. She hasn't only practiced medicine for about 12 years. She would like to come back and matriculate back to California. Her practice is essentially to the needy, the areas of don't have access. She practices in the lower areas of Harlem right now and New York and the areas in Connecticut that don't have medical care for free, pro bono. She's fortunate that her husband's fairly well off. These are people that have and willing to prove themselves and have proven themselves. And Dr. Feynman, who's been here 20 years without any problem, over 25 years practicing medicine, he's got a little glitch of 1 year that was at a disapproved school. And I bring to the attention of the board, the school was neither disapproved or approved at the time that he left. So it's a little anomaly there. The other physicians that I represent, one of the other physicians I represent, he's faculty member at Baylor University Medical School. He's double boarded. So it's interesting, we have physicians out there that have gone to foreign medical schools, disapproved medical schools, that have proven themselves, and there's got to be a mechanism if they choose to come to California that they are eligible. And that's a key word. They're not getting their license. They're eligible for the application to apply for medicine. They're not saying that just give me a license. Give me the opportunity for the medical board to go through the licensing process to see if I can be licensed in the state of California. So I want to make that nuance pointed out, that you're not carte blanche approving them for medicine. Your carte blanche, what you're saying is, yeah, you meet some requirements, we'll make you eligible to apply and let the process find out whether they really are able to practice medicine. Thank you very much. Good afternoon.
Thank you. Next, I have a slip from Christetta Summers.
Good afternoon. I'm also here with Dr. Gargat, and I think on a slip further down you'll see
yes,
the two
I see
of us
both
together.
names, so you can pick your order.
Thank you.
Presentation.
I will go first. I am from the law office of Albert Robles. I am his assistant, and our office represents physicians such as Dr. Gargat, who graduated from foreign medical schools and are seeking admission here in California. I think the points that were made by the speaker before me are points that we would also agree with, and in particular to stress that these standards that the committee is looking at are not admission or licensing standards per se, but whether the applicants are eligible to be considered for licensure. It is our position that the statutes as presently constituted already give this board the discretion to decide whether someone who graduated from a foreign medical school under certain circumstances should be allowed. to practice here in California. We don't see necessarily the need for SB 122. However, we are supporting the bill to the extent that if there were any issues about its interpretation, and obviously there are, that the bill would make clear that in fact there is a path for foreign medical students to become licensed in California. The regulatory climate that existed in the 1980s and continuing to the 1990s was a very different regulatory climate than exists today. In the context of information society like ours, where you can, with the push of a button, find out everything that you would want to know and more about any individual, the concerns that cause the promulgation of the restrictions for foreign medical students no longer are as valid as they once were. Today, you cannot produce or even reproduce a certificate that is fake. It will be discovered well before it even reaches the medical board or any committee of the medical board. So the concerns that cause the regulations in the first place and the restrictions on medical licensure of foreign medical students are not the kind of regulations that would be as important to have in today's climate. The premise of Senate Bill 122 is that there can be really good doctors practicing in California who would not otherwise be allowed just because at some point in their life they attended a foreign medical school that was not recognized by this board. You've already heard from Dr. Feynman, you've heard about other doctors, and you'll meet Dr. Garagat in a moment. The reciprocity requirements that exist in the code already and that are part of SB 122 are very separate and distinct as a path to licensure than the path for initial applicants. What protects the California consumer in the reciprocity requirements is that there has been a practice that's been developed. There is a past and a history that the board can assess. And for Senate Bill 122, it has determined that 5 years should be sufficient. I believe 5 years of practice is a long time anywhere in this information age where you can practice and not have an adverse judgment or not have some type of proceeding against you. So that I think 5 years is sufficient as protection for the consumer for eligibility. Again, it is not for automatic licensure. And so I would hope that the board would entertain or reconsider the compromise solution as being too rigid or too strict, because it would still prevent a lot of really good doctors from being brought into California. 10, 20 years wait or history of practice, by the time you've had that, as one of the board members pointed out, you're probably in your years closer to retirement, and you would not likely be uprooting to come to California. So it would cover just very few people and would not address the long-term problems that we now see with healthcare reform and that we anticipate with the shortage of good doctors here in California. Thank you.
Thank you. Ms. Doctor?
Thank you. Good afternoon, committee members and board members. My name is Ravi Garagat, and I am a board-certified pediatrician working as a pediatric hospitalist. This agenda item, as it's important to many others, is particularly important to me on a very personal level as well. Let me first say that I have a great deal of respect for the board's mission to protect the citizens of California and applaud your efforts to ensure that consumers receive the best care possible. I understand the concept behind the approval list of medical schools. However, as we all know, graduation from a school on the list doesn't necessarily guarantee one's abilities in the real world of clinical medicine. If I may, I would like to briefly just shed some light on my background and my personal reason to seek licensure in California. I hope to provide an example of the type of physician that could benefit from the changes and perhaps your consideration. My decision to pursue medical school overseas was not based on my inability to gain admission to a California-approved medical school, but rather to gain a practical experience in underserved countries. I was 20 years old at the time and basically wanted to save the world, one child at a time. And as an East Coast native, I never had an intention to come back and practice in the state of California, and had no knowledge at that time even of an approved list or a disapproved list of schools. It was only during my third year of medical school that I did gain knowledge of such restrictions in certain states. In regards to my clinical training, all of my rotations through medical school were completed at university hospitals, and in fact, with a great deal of oversight from attending physicians throughout my entire clinical training. I was actually one of the students that had all of my clinical reports sent back to my university, took the same tests during my clinical rotations as the U.S. medical students did, and passed all of them. After completing my clinical training, I completed my residency training in pediatrics at the University of Texas, and during which time I actually did win awards for teaching both residents and medical students, as well as awards for research activities that I carried out. I was also subsequently offered 3 fellowship positions at the University of Texas. Since I completed my residency at the University of Texas, I've maintained a completely impeccable record without a single complaint or violation of any kind, and practiced medicine in multiple states and continuously since completing residency. In 2006, my wife actually gained acceptance into veterinary school here in California, and due to this reason, for the past 6 years, I've actually been commuting to Las Vegas for work and living in California. As you can imagine, this has not been easy for me or my family, but the regulations that we adhere to really have left me no choice. During this time in Las Vegas, I've actually been appointed as the Vice Chairman of Pediatrics at one of our hospitals, as well as the Medical Director for Inpatient Pediatric Services at one of our other hospitals. My current responsibilities actually include training, U.S. graduated residents as well as U.S. medical students. That being said, I cannot express in words the deep desire I have to be able to practice finally in the state of California, where my family and I live. Currently, I've actually been offered 3 clinical positions in the state of California, all of course contingent on my licensure. I do feel that the confidence of my peers in my abilities is a much stronger indication that I'm a qualified physician over the fact that I may have attended a foreign medical school over 10 years ago. I truly hope that my personal story can show that there are in fact qualified, ethical, and dedicated physicians who may not have attended a school on California's approved list. And I do hope the board can consider applicants on an individual basis if possible, rather than solely based on the school that an applicant attended. Thank you very much for your time.
I thought we had a hint that we might be hearing from Bill's sponsors. I'm not seeing any more speaker slips. I'm missing speaker slips? Oh, okay, very good.
I didn't fill out one. Okay, thank you.
I think they want us to do that.
Okay.
We're very law-abiding here.
Thank you. My name is Bill Gage. I'm the Chief Consultant for the Senate Business and Professions Committee. Been a consultant with the committee for 20 years, been with the State Senate for 25 years. Worked closely with the medical board on a lot of different issues over the years, and with their committees. I think we've resolved some very important issues with the board over the years. And hopefully we can resolve this one today. What happened is it came to the attention of the senator that, as you've heard today, that we have physicians, so we're in a situation that they've been practicing in other states for many years. And there are states, obviously, that approve certain international schools that California has not. And they've applied to California and have been refused licensure because one of the schools is not on the list or has not been approved as yet. Senator felt that the board, and we thought the board possibly had discretion in terms of looking at a physician that had actually been practicing in another state for a number of years, especially if they're board certified, and could make a decision, even though they had gone to an unrecognized school, that the board still was able to possibly grant them a license to practice in California. We actually went to our legislative council and asked them if they thought that based on what's in the codes, whether or not the board did have discretion. They thought the medical board does have that discretion. But then we discussed it with the medical board, with the staff and legal counsel in terms of whether it's clear enough in terms of what the board could do under this situation. And I think we all agreed, we had a meeting with the senator, I think we all agree that the language is not clear enough in terms of what the board can do under these particular circumstances. I think the senator felt strongly, we're now going to be dealing with national health care. We do have a shortage of physicians in California, that we at least need to be looking at the idea that if there are physicians that are practicing in other states and are in good standing and have been practicing for a number of years, that they do have an opportunity at least to apply for licensure in California, and that just because the school itself may not be on the recognized list, that the board could take into consideration that they have been practicing in another state for a number of years and that they are board certified. The language we came up with at SB 122, I actually just had counsel talk to your legal counsel. I think the 5 years was just an arbitrary number of years in terms of what they thought should be necessary. We actually, and the only reason we had to put in language, we actually wanted to wait till we had this meeting with you. The only reason we had to put in language in SB 122 at the time, because it was in the Assembly Business and Professions Committee, we had to give them a heads up that we were going to be dealing with this issue. And so they actually asked us to take it out in committee. So it was just the opportunity that everybody knew we wanted to deal with this issue, but at the same time that we would come back to you as the board and make some determination of what would be the best approach, what would work for the medical board. I think your staff has done an excellent job of laying out the problems, potential problems, everything from costs to the number of applications they may have to deal with. But I think the bottom line for the senator is just that if we have a situation of physicians that have been in good standing, practicing in other states, that at least the board does have that discretion to look beyond the fact that the school is still, somehow it's still on an unrecognized, it's on the unrecognized list or unapproved list. And there are situations, I mean, you have a few schools that are disapproved. I mean, certainly you don't have a lot of disapproved school, but I know there's one school that's more recently been put on the disapproved list. So I'm not sure how the senator feels about the idea of 20 years for disapproved schools versus 10 years for unrecognized schools. And we may get into this whole situation in the legislature about what years are appropriate in terms of that. But at least for now, at least we know the board, from its standpoint, is feeling that 10 years should be at least the outside number in terms of somebody who's been practicing in another state before they feel comfortable making that decision about that person who's come from an unrecognized school. I mean, I know that 19 other states follow the medical board in terms of its approved list, but that means there are 31 other states that does not. So this is very much concern for us. You currently have a backlog in terms of schools, foreign schools that are actually being approved. That has to be taken care of. And I hope that, when I was listening before, we were talking about the other issue about approval of international schools. I think the process itself is something we can look at more closely during our sunset review of the board and come up with a way. First of all, I think all your costs should be covered. We just went through with the nursing board in finding that they expend a lot of their own money and staff time in terms of approving nursing programs. And so we now have built, we're carrying this year, actually to assure that their costs are covered, both from the time of application to any site visits to anything else that the board has to do in the context of approving schools. That should be the burden on the schools, not the burden on the medical board in terms of their costs and staff time. With that, as I said, the compromise language, I think the only issue may be the number of years, but I think it's a good start. And I just want to let the board know that there may be some more discussion about the number of years you have so far proposed. With that, I'll take any questions.
In light of the fact that it seems like it's going to take a lot more time and effort to perhaps vet these applicants, would you feel that the differential in the cost to the applicant would be in reason?
I would. As I said, we always
would that be fair? I mean, you feel that'd be a fair expectation?
Certainly. We always feel that the costs of the applicant and the application costs and the administrative costs should be covered by those that are actually applying for the license. In many of the other health boards, we've assured that those costs are covered, and if they're not, they should be, and it's something we should change in terms of if we have to raise the fee. I think in terms of
what I'm hoping for, though, is not to raise the fee for all physicians, to cover the costs of a few.
Right.
Such that
exactly. Those would be strictly application costs.
Yeah, great.
Excuse me, Bill. Yeah. Just for the record, I'm talking to Dr. Feynman. My clients would be happy to pay.
I assume so. I assume so. And I wouldn't want to make it draconian. I'm just saying, let us cover our costs.
But what I was talking about also is I think the schools need to cover the costs of application.
Yeah, absolutely. That is
There's no reason that cost is not being covered currently. Site visits, I think we want to look at, because as I said, we went through the nursing board for the past 3 years in terms of streamlining their process. And I think there's a few other ways that we could streamline the process, especially now that you have a backlog. I think there are things we can do. First of all, cover all the costs. But secondly, maybe we don't need a team site visit. Maybe the fact that you have a medical consultant that starts looking at this school initially, and that's what the nurses board does, is they have a nursing consultant that follows it all the way through the process, and then they come back and make the recommendation, and then staff comes forward to the board, rather than this back and forth between the board and a site visit and all these other things. So I think there's some things we can talk about in terms of changing the process, hopefully make it more streamlined, but also covering your costs in terms of looking at these international medical schools.
Can I?
The only thing, this is sort of off topic, but only with site visit, and since our hospital is just going through JACO, which now, as you probably know, is no longer announced. It's unexpected, and I do think that's something to think about for site visits as well, because I do think they can prep so much if they know they're coming. So perhaps we have to buy the tickets and then ask to be reimbursed so they don't know we're coming, but that's an aside. Any other comments with respect to this?
I'm just asking on that same point that if the board has already disapproved that school, can we not putting it in the regulations anywhere? Pretty much is because I really do not want the Medical Board of California approve some license to some people who went to a disapproved school. Would you have any problem with that?
Not really. I mean, in the code, it specifically says the board does not have to consider an application of a person from a disapproved school. When we ask counsel about that, it says, well, at the same time, it doesn't mean they can't approve the person from a disapproved school. I mean, that's when we got into this whole idea of whether the board had discretion or not. And so the board has currently, under the code, we believe the board has the ability to say, if you're from a disapproved school, you do not have to approve that person from a disapproved school. But at the same time, it doesn't say the board cannot do that. But again, that's where we were unclear. And so that's, I think, when we talk with your legal counsel, well, let's make it clear then. If we are going to be talking about those physicians coming from approved schools versus disapproved or unrecognized, that we set some parameters in terms of what that's going to be and how that approval process is going to work.
Bill, you mind?
Yeah, go ahead.
Hi. To be clear, though, for Dr. Feynman's one of those physicians, he went to a school that was not approved at the time, Mundell. He figured out on his own, wasn't up to par. He transferred out. After he transferred out, got accepted into Ross, graduated from Ross. While he was at Ross, Mundell got disapproved. Now, if you say you can't, if you attended any disapproved school for any portion of his medical career, education, he can't be licensed in the state of California. And so and here he is, he's triple boarded. He's practiced for over 20 years in the United States, done all his rotations in the United States. And I think that would be a crying shame. And he actually, all his family is now out here in California and thinking about, would like to come out to California, back to California. So that would be the issue.
But to due respect, we cannot just do a legislation for one person.
Well, on that, Bill made a good point. And mind you, this is only an application. This is only eligible for application. You do not have to accept the application.
Yeah, you all make that point saying you don't have to accept that. But if the criteria is saying that you're supposed to look at this and accept them, then it is accepting. I don't know where else that I can look and say not approve this person, if the criteria is exactly the way it's putting.
It says it's eligible for application. I think it's quite clear it's eligible for application. And you would be eliminating anybody that had attended even one class at a disapproved school. What if, and by the way, Dr. Feynman had to take other classes to get up to a second year. He graduated from an approved school that actually vetted through his records and made a determination that he was qualified to go, and he actually graduated from an approved school, but he did attend some education at a disapproved. I have a physician client of mine. He was a master, the American College of Physicians. He's a master physician. He had to hang up on his license in another state because he had no undergraduate degree. He skipped college and went to med school, and they had a problem with that. Right. And so there's a typical example where it'd be out of the ordinary.
Yeah, I think I'm going.
One more point.
Okay, because I think we can't do this as a hearing for individual cases at this point.
And not only that, the school he went to has vetted the other school that he went to is not approved. That's a different case about a person who went to a place where it is totally disapproved school.
Yeah.
So I think if the school which he went to...
I think I've gotten a little word from our attorney. We might be in jeopardy if we're sort of hearing
I would
this case.
respectfully, everybody, I would suggest we not talk about onesies and twosies and individual applicants. Perhaps the best way to consider this, because I have a very small brain, is to consider it like this. The attendance or receiving of a resident course of instruction, 1 class, 2 classes, 1 hour, or you're driving by and you got a good thought as you drove by, or whatever, is that it would no longer serve as an automatic bar for licensure. That's probably the easiest way to think of it, is that just by attending or graduating from an unrecognized or disapproved school, that does not automatically bar you from getting a physician's and surgeon certificate issued by the medical board. This bill would do, leaving away, casting aside the permutations and the years and all that sort of stuff, would essentially, as many speakers have said, make you eligible for consideration to receive a license. You're not automatically going to get a license. What it does do is allow you eligible to be considered for a license, which is kind of a change from the current status quo of the board was. Right now, it kind of serves as a de facto bar to licensure. And I believe that's what the senator is trying to change.
what we're trying to do is set a threshold. In other words, you shouldn't have to consider those folks, obviously, that don't meet the threshold, whatever that we come up with, and right now it's the 10 years. But that it's discretionary, though. It is still, we believe, the board should have the discretion. And we're not saying that you have to. We're saying we're not making a mandate. We're just saying you should have discretion once that person reaches that threshold, whether or not they should be licensed in California. And that's why I think we have a little problem with the 20-year idea of a school that's unapproved or disapproved, because we are turning discretion back over to the board in terms of if you reach this threshold, then it's up to the board whether or not this person would be licensed. We're not saying just because they reached the 10 years they have to be licensed if they're practicing in another state. Just so you know, I think we were looking at most of our other health boards. They all pretty much have the discretion to look at practice in another state and approve that person. And there's no timeline. I mean, if you've been practicing 1 or 2 years in another state, you're still eligible to be considered, even though you came from, in their circumstances, an unaccredited school. Now, obviously, we're in a unique situation that we don't accredit foreign medical schools. It would be a lot easier for us to deal with that if we had an accreditation of these schools. But the idea being that since we don't do that, it's state by state that we're dealing with. But from the senator's perspective, shouldn't we be considering the fact that a physician has been practicing in another state for a number of years without any problems, board certified, and that there may be some problem with the idea of the school having been recognized or not by California?
Do we feel ready to vote on our motion? If there are any more comments we're ready to call the question.
The motion that I have with the second is that the committee would recommend, would adopt this proposal. I'm sorry. The committee would adopt this proposal and recommend its consideration by the full board tomorrow, with the addition of the regulatory authority that I discussed when I was waxing eloquent up there.
Are you are you going to say was that portion you just said is a criteria for looking at it, not necessarily approving it? Is that part of this motion?
That's what it is, right?
It's a recommendation to the full board, ultimately the full board.
Application, right.
Okay, and the other one is I'm just asking the rest of the board whether, committee, whether they'd be interested to take a friendly amendment and taking the unapproved school portion out.
You would have to ask the maker of the motion and the second whether they would take that as a friendly amendment.
No? Okay.
Yeah, I think in all fairness, we can have a discussion with the full board, and at that point, if the full board feels they want to do that, at that point, we can take it out. That way, we're advancing the entire package, and then we can let the full board decide at that point.
Okay.
All right. Then we're ready to have a vote. Do I have all in favor of the motion as stated, and it's merely a recommendation to the full board that we accept this stated language? All in favor?
Aye.
Any opposed? Do I have one opposed?
Yes.
Okay.
I oppose.
It does pass. Now we are still not done, but we're getting close now. Let us have, please, agenda items for the next meeting, which will be in October, the 25th and 26th in the San Diego area.
I had requested to put I'm not even sure, look at the supervision for our midwives and
Could we broaden that to say allied
professional, yeah, their supervision, what that exactly entails. The compliance, that's what we're at.
Thank you. Okay, any other items for the October meeting? I'm sure you're free to suggest anything. Well, with that, last, we can entertain a motion.
The regulation that alters or impairs or enlarges the scope of a statute is null and void. And so the question I have is, to the extent these proposed regulations deal with physician availability, they would be consistent with the statute, which, if I recollect my administrative law, is that the test for a valid regulation is it has to be consistent with the statute and reasonably necessary to effectuate the purpose of the law. And so to the extent talks about concepts regarding, I think you could go to a physician being competent, because that's kind of availability. You want to avail a physician that's, you don't want necessarily any physician. Hey buddy, walking down the street, this isn't a carjacking. I'm from the medical, I'm a healthcare professional, I need a physician. I think you want somebody trained in that, but enlarging the scope of the regulations is something I think we ought to be very mindful of. Do these four proposals, as the chair said, do they differentiate between licensed healthcare provider? No, they do not. They do not embrace the difference between an RN or a physician assistant. And with all full disclosure, I was PA's counsel for a while. I think most of you know that already. Do these four proposals address training? No, they do not. Do they address things like a backup plan and everything else? And of course, no, they don't do that. They don't do that either. Mostly because and as I was heavily involved with this writing of this memo, was trying to keep it consistent with the statute. Now, it may be the case that this committee is unable to come up or can't come up with with a regulatory proposal, and perhaps which case it would be necessary to go back to the legislature and say maybe physician availability isn't the silver bullet we're all looking for. Maybe it's training, or maybe it's who, or maybe it's what or whatever. So I just want to kind of try to draw a little box around there, that the reason these options are kind of flavored the way we are is that I was doing my best. I think staff was doing its best to honor.
Well, if I can, let me put my attorney hat on for a minute. My understanding, when we do draft regulations, you can do in the definition clause. When we do definitions, when you put physician, you could put the definition that this physician, to be adequately responsive, has to be somebody, and we can put it in that definition.
I would agree with that.
Okay.
Yes.
Well,
Could we just say the supervising physician? Because that would, therefore, by definition, the supervising physician must be in that field, right? So you have...
Not necessarily. Nurse practitioners, nurses get asked to do this all the time, and they don't have... But the physician supervising them does not have to be adequately trained. There's no requirement. If we get ads all the time, come and do laser at this med spa in Laguna Niguel, and it doesn't mean that physician has to be in that field or trained in that field.
No, but that's what I'm saying. If we made the regulation that instead of a physician shall be immediately available, a supervising physician. Because
what I'm saying, supervising physician by definition doesn't have to be adequately trained in what that person is supervising.
But I thought you
No, that's
putting that in the definition.
They don't.
Wait, I thought if you're under standardized procedures, whether you're NPPA or an RN, your supervising physician has to be trained in what you're doing.
Not necessarily. All they have to know is that you can do what you're being asked to do. In standardized procedures, there has to be a thing that shows back that you were adequately trained in it. And that's what's going on out there.
I know what's going on, but I thought the nursing board rules.
No, the nursing board gave a presentation to this committee and specifically said they are independent providers, and a physician gives an order. They do not supervise. They do not do anything else. They give an order.
What I'm saying is, if we craft in the definition that the physician who has to be readily available has to be, and we could say appropriately trained in this particular technique that we're trying to regulate, that might be the way to catch it in there without being overly broad.
And the patient shall be notified as to who is the physician on call or whatever. Because I think if your name is attached to something, you're going to be way more careful about what happens to these patients.
Well, the way we might have to phrase that so we're not overly broad and have the legislature come back and, say, this is what we ask, is we would have to say as part of the availability that somehow that has to be communicated to the patient how the physician is available. We can say they have to be available and the means they have to be available, and that has to be communicated to the patient as well.
I have had no less than 20 people come to me to get problems fixed because they couldn't even find the physician. There's no on-call, there's no nothing.
Mr. Kepler, would that be appropriate if in...
I was trying to create a diversion.
I know you were. I know you were. But if we do in the definitions and what we are trying, obviously, capture what the legislation has asked us to do about availability and supervision, and then make those definitions.
It would be a bit of, in all candor, it would be a bit of a stretch.
Well, let's stretch it.
Okay. Stretch Armstrong here. I do want to point out, we've talked about length about supervision in various incantations of today. I'm not seeing a whole lot of supervision in the statute. What I am seeing is a whole lot of availability. Right. And I want to make that key distinction. I don't think supervision, being PA counsel, I mean, let's be candid, as was stated before, there's sort of a tethering that goes on there. The PAs are sort of tethered to a supervising physician. The law prevents the medical board from telling the scope of practice for an RN, I rely on Ms. Shipsky. I don't think that supervision element is necessarily there, and so there's the standardized procedures a little bit different. So I kind of want to knock us off on one leg on the supervision issue and like to concentrate on availability. I think you could have a regulation that said, again, it would be difficult to do right now, but you could say, when we talked about a physician availability, you could talk about which physician you're talking about, and not a physician walking down the street, but a physician who's competent in whatever is happening, whatever the procedure is, because logically you would say, if I'm going to call for backup, to use a Hawaii 5.0 or CSI metaphor, you'd want somebody backing you up who's confident in whatever is going awry. It seems logical to me.
And I would argue that by us stretching it, this satisfies the legislative intent. The whole purpose of this legislation was the concern about the lack of competency training and supervision, and so we can oblige them and stretch a little bit.
So my question to council would be, would the wording I'm going to read to you stretch beyond the boundaries of acceptability or wherever we would get into trouble? And that would be taking it from about the middle of number 4. A physician with relevant training and expertise shall be immediately available to the provider. For the purposes of this section, immediately available means contactable by electronic or telephonic means without delay, interruptible, and able to furnish appropriate assistance and direction throughout the performance of the procedure and provide appropriate backup care plans, something like that. And the word appropriate, to me, is a way of getting into the ideas of what procedure is it, what provider is it as a PA or an RN or an NP or whatever, what's the location, where are emergency services, all of those things. If you're going to, if you say able to provide appropriate assistance, you have to include those kinds of things, but you don't have to write it into the language. Would that language pass muster?
The problem is, in all candor, it's not me you have to convince, it's the Office of Administrative Law. But in my legal opinion, you'd be right on the edge, because you're essentially not right on the edge, but you're getting close. Yeah. I think you could give it that old college try if you get it. My fundamental concern is the more sort of appropriate and relevance we sort of add in to sort of soften that. In my opinion, and I'll defer to Ms. Dobbs here, maybe you start bumping against the clarity standard then is what does that actually mean? Right. And so I think it's sort of, we're sort of walking a tightrope a little bit, but Diane, would you?
I agree. I think your regulations need to be as clear as possible. And if you have something in there that then causes someone to say, well, what does that mean? What does appropriate mean? Then you're missing the mark on what really meets the clarity standard.
Unless we put it in the definitions area.
If you put in the definition, then that helps.
Right.
Yes.
And I want to address 2 points that have been brought up by people to make sure that this is inclusive. One is the issue of, because you removed the physical boundary, and that what the issue was, can you be out of state and telephonically available? And I don't know that that was ever the intent, but the way that this was crafted, you could be. Number 4, you could be out of state and telephonically available. So that's one issue that needs to be addressed. And the second issue, it sounded like we need to address, is that and that the patient shall be informed of the availability of the supervising physician, or whatever, if you want to address it that way. So then that covers the patient being able to get the information of who to call if the physician isn't physically present at the site at which this procedure is being done. Dr. Kumar.
Okay, I cannot go with the out-of-state thing. You would not deliver a baby and have your doctor be out of state. You would not do surgery and have your supervising or whoever physician be that far away.
Oh, no, that's why we brought that up, because the way this is written, it says without physical boundary, which means we have to out of state. Yes, Dr. Robbins.
There's another bill that has been
Hold on.
recently...
Mic over.
I'm sorry. There's another bill that's been recently passed by the state legislature, which I'm not sure that it directly hits what we're talking about, but it certainly comes close. And that was a bill that was introduced by the derm surge people, and I think it's AB, somebody will help me on these numbers. 1548. Pardon me? 1548. It's AB 1548, and it was directed exactly at the corporate practice of medicine, and the lack of training of those people who were pushing into this field from corporations. And the interesting thing about that was that it passed with everybody's approval, and there was almost no conflict of interest in it. And I think we can take some of the wording from that law and use it in crafting our own.
We can read it down.
And I'm just recommending that we look at it.
If we could do this, if we could just go down the table, if you have one more comment, and then what I'd like to do is ask for the public comment now that they've heard our discussion. So, Dr. Kumar, if you have anything you want to add.
I have a question of legal counsel before we get into that, if you don't mind. I know Mr. Kepler, we looked at other states that were dealing with some of these similar issues, and especially med-spas and the scope of practice and everything. And it was found out that the state of Iowa, the state of Oklahoma, and Florida have passed laws that have defined this, have drilled it down to where they wouldn't have this discussion in this room right now because the law has been passed, that you have to have a scope of practice within that entity that you're practicing. And in fact, in Florida, they say you have to be a dermatologist or a plastic surgeon to give these services. They've even drilled it down even further. So I don't think we have a prayer to include the word scope of practice into this. I think what Dr. Finney was saying, that a person who's backing up or the person who's doing the procedure should have a relevant training or whatever language that was used there. But using the word scope of practice kind of drills it down even further. But I don't think we have a prayer of doing that, or do we?
Scope of practice as it sits now, I think the reason that scope of practice is mentioned in this is because, as was pointed out, there's only the medical board. Let me back up. The medical board has authored a precedential decision saying you penetrate the skin. Penetrate the skin, that's the scope of, you're into medicine now. And so, at a amount of clarity, what I was trying to suggest is I didn't want this to be appropriate, that you could let your licensed, I used to be counsel at bar, your licensed smog check technician perform laser because your supervising physician said it was okay. That's the reason what I was trying to avoid. So my rationale was, if in fact your scope of practice, whoever, because the law clearly contemplates that it's not a physician that's going to be doing the procedure. It's somebody other than a physician, because if a physician was doing, we probably would not be having this conversation. It's somebody else. So who's that somebody else? And whoever that somebody else is has to have that ability to do laser within their scope of practice. That was sort of my rationale. Crossing that threshold, and the next one was, okay, then you got to have a supervisor, you got to have a physician, not a supervisor, a physician around somewhere. How close, how far, the proximity, the connectivity, that's all the issues that are trying to be braced here. Candidly, the way that number 4 is written, or is you could conceivably use hyperbole, have somebody on the moon, and as long as they were NASA or Houston, we have a problem. As long as they were readily available, they could conceivably do that. I use that for hyperbole only. So there are states that, Dr. Bruner, you're exactly right. There are states that have beaten us to the punch. There are, and I think we had one of our initial meetings, I think we talked about some of their approaches.
On that note, then, Dr. Bruner, what I'm wondering, could we be so politically bold as to send a message back to the legislature that we don't feel that this statute adequately protects the consumers in the way it needs to be crafted, and that what we do need from the legislature is a law similar to what you're indicating, that more spells out the requirements of those that provide it, in addition to who supervises, as well as the availability. I mean, we, quite honestly, politically, we always have, I think, have that option. If we're not comfortable that this adequately protects.
You know, within our, sorry for interrupting, but within our codes, maybe is there a midwife here? Perhaps you know where I'm going with this. In their code, it says the midwife will be supervised by someone who has some sort of OBGYN training.
You give me just a second, Dr. Jack. I'll pull the...
Thank you. But it says that very specifically, and it's, I mean, I think it's a very relevant fact that a midwife, has to be supervised by...
The practice constitutes the furthering undertaking of any licensed midwife under the supervision of a licensed physician and surgeon who has current practice or training in obstetrics. So clearly it's not, while we do license plenarily, we do not, it's clearly this is not any physician. It's a physician. Training. I'm sorry?
It's cleared out. It is stating that it is required they have training in this area. They don't have to be certified, but they have to have
current
training.
Practice or training in obstetrics.
Yeah.
You go down the table, and then let's listen to the public, and then we can come to some kind of recommendation. Dr. Himon,
yeah, go ahead. So I just want to reiterate, I think we could say the physician, because we're talking about laser intense pulse light, physician trained in these devices, so you could say it that way. And I want to make sure we have some way to limit how far the feet can walk.
I think 4 is as close as I think it's article number 4 we're talking about. Is that right? Mm-hmm. Yeah, I like it. I think to define a distance to go, it's going to be impossible because of what I said a while ago about the downtown LA is different than the upper desert. So I would say it's probably a poor substitute, but the standard of practice of each community has some weight in these regs. So a standard of practice, I think, might prevail in something like this and help.
That actually is option number 1, is the community standard.
Okay.
Dr. Samuelson.
Well, I go with the hybrid. Choosing number 4, but not putting a time restriction on it, because I think if we pin down who that responsible physician is, their own fear of liability should keep them within the striking distance of the site.
And remove the physical boundary?
I wouldn't define the physical boundary, personally.
Take that out, because if you say without...
readily available, but I wouldn't specifically say electronic. Readily available, period.
Changes everything. Well, we have telemedicine physicians that actually testified, and that would significantly change their relationship to be able to...
Yeah, well, I don't see a reason to be that specific. I would say readily available, because I think it's one thing to telemedicine to diagnose, do you think that's a melanoma, do you think it should come off? I think telemedicine, beautiful, great. But to respond to anaphylaxis, not that great. So that's why I wouldn't offer up the electronic option, but simply define it as readily available.
So a Twitter account wouldn't do it. Just never know.
It's obvious from my previous comments where I stand in this, but the ray of light that I have heard actually comes from you, and as it usually does, and that is to go back to the legislature and say that none of these, as they stand right now, offer the protection of the patient nor the professionals adequately, and that we would like to consider other issues that have been brought out in our discussion.
And perhaps we could define those issues once we finish, if we want to go in that direction, about supervision, training, competency, those kind of things.
Yes.
Yeah.
But I would hate to lose ground and not have something happen after all this. So couldn't we have this be there and then say what we need in addition is defining training supervision?
Personally, I don't think that you can talk about where they are until you know who they are.
Right. Dr. Bishop?
I may be wrong. I might have misinterpreted the recent required meeting I went to, but does not the medical board have the ability to craft regulations in the absence of the legislature?
We have, Dr. Bishop, we have generalized rulemaking authority, but please understand that the purpose of regulations is to implement, interpret, or make specific statute.
I think we are. I think what I'm saying is I think we would be interpreting and implementing the gist of this statute. They may not have specifically said this, but they really meant that they want to protect the patient. So I think, although I can, as a fallback position, I can agree with 4, but I would like to say if we agree with 4, we should go forward with trying to craft something that really is based on the spirit of what they really wanted to do. And I think we should push the envelope here. And if it gets kicked back to us, it does. But I do think that this was a incomplete legislation, not by fault, but by perhaps ignorance. And I think that we can do better with what we've learned. Yeah.
Yeah, I agree. I like 4 with a further definition of what that position should be. The only other thing that we haven't discussed at this meeting is whether some kind of ratio is appropriate.
What's the supervision ratio?
Only because I think some of the concern is that medical doctor in name that has 20 nurses running laser.
There is a law.
For RNs? In an outpatient
I
setting?
think there is a law, how many nurses and how many nurse practitioners physicians can supervise. It's 4.
27, 25, 27.
Yeah.
I think it's 4 at the moment.
For RN?
4 for an 4 to 1 for a supervising physician to a nurse practitioner.
Nurse practitioners and PAs are 4 to 1, but I don't think it applies to RN.
I don't know about non-advanced practice RNs.
But there is for nurse practitioners.
Yes.
Because they're not allowed
Right.
to sign more agreements than I think it's 4 or 6 actually. I think it's 6.
It may it may help to limit the concern of that multiple centers using one physician and having the physician not truly available by putting some ratio in there. But I do also think that it would be appropriate to consider sponsoring legislation or co-sponsoring legislation that would define what the competency and certification is, just like, I mean, there's definitely precedence with the fluoro, there's definitely precedence with Accutane, Suboxone. I mean, there's things that you have to pass a certification before you're allowed to do that. So I think that wouldn't be a difficult legislation to pursue.
I would agree wanting to do that separately and concur with Drs. Kilmer and Simon that I think we ought to do this here and can do this here and maybe even if we have to stretch it a little bit. Ms. Chispy asked me to complete some language that I would suggest will fill out option number 4 in a way that I think our discussion implies to me at least we would be comfortable with, and starting again on line 4 of option 4 after the word license, it would continue, a physician with relevant training and expertise shall be immediately available to the provider. Where am I here? For the purposes of this section, immediately available means contactable by electronic or telephonic means without delay, interruptible, and able to furnish appropriate assistance and direction throughout the performance of the procedure and inform the patient of provisions for post-procedure care. Because I think that was something we were worried about. So I think if those pieces are in there, and I disagree about ratios, I think that's getting, because there's so many variables, I think you'd have a hard time defining which procedure, you'd have to get into which procedure and which, is it a PA or an RN, and I think it'd sort of be a rabbit hole. But I think with the language, something like this, it would cover enough bases and not get counsel too far out. If there are ambiguities in the language that we could address in the definitions, perhaps that would take away that, okay, what does that mean, issue that was brought up over here. But that would be my suggestion.
I think any of those qualifiers, such as appropriate, we could handle in the definition area as to what, we could try as to what constitutes appropriate, and any of the other qualifiers. What I'd like to be able to, and relevant training, what I'd like to be able to do, if I can, is call the public. They've heard our discussion, and then after we're done with the public, we'll bring it back behind the rail, and then we can make a motion of where we want to go with this. So the speaker, Yvonne Chung from CMA. Did I get that right? Mm-hmm. Okay, thank you.
The CMA.
Yvonne Chung with the California Medical Association. In listening to the discussion of this committee, I think we're largely in agreement with most of what's been said, and particularly with Dr. Finney's comments. I think those are good additions. A couple other things you might want to think about adding is after acting within the scope of his or her license, and something along the lines of in adherence to standardized or agreed upon procedures or protocols, because I think that addresses the PA issue, and that you have they have a scope, but your scope is dependent on your agreement. So I think, putting something that says that the provider and the physician have agreed upon, when they're going to contact and in what situation that conversation has been had. And in defining immediately available, along this issue of whether or not, you can have a physician who's out of state, possibly saying, or has designated an attending physician who could be physically present, or, just to show that they have covered themselves in that way. So that's another thing that you might want to add, but otherwise we're in agreement. Thank you.
Okay. And I think we can actually tweak this language, because usually, I know it would say that this shall be contained in standardized procedures and protocols, so that we're making the requirement, we're defining the appropriateness and the backup, and then saying that this shall be contained in their standardized protocols. That also would help actually RNs. There have been numerous cases where RNs have worked and done this and didn't know, the physician supervising didn't know they had to have standardized procedures. So this would be very helpful on that end too. Carl Powell, Dr. Carl Powell, California Academy of Cosmetic Surgery.
Good afternoon. I'm Dr. Carl Powell. I'm a general cosmetic and laser surgeon. I own 2 medical spas. I've dealt with this for about 9 years now. The first point that I would like to make, that a medical spa is a medical practice. It should fall under all regulations for any other medical practice. I think that is perfectly clear. There should be no differentiation. The second point, laser procedures with class 3 lasers are surgical procedures. Medical surgical procedures. What we do in medical spas are medical or surgical procedures. They penetrate the skin, they destroy tissue, or they alter tissue. So they need to be regulated just like any other medical practice. What you are dealing with here, I have this advertisement from a magazine in San Diego, a nurse who basically practices medicine without a license. It's a medical spa. Her medical director is in Orange County. He has graduated from medical school but done no residency, has no board certification, runs an acute care clinic, and spends most of his year traveling with professional surfers as their doctor. So he's not available at any time for this nurse who practices under his license. This is why this is a very important thing that needs to be addressed. It really boils down to medical director or whoever owns that practice supervision. That's really what it is. You have these medical directors that work for these major corporations. They get a paycheck every month. They never show up. They never do any training. They never do any chart reviews. Charts may not even be kept. They're not available for help with the procedures. They're not available for any problems that come up with the treatments, and they're not available for any injuries or emergencies that come up. So from my point of view, the medical director or the physician that owns that practice, and he has to own 51% of that practice, that is law. 51%, and a layperson cannot own that practice. That doctor needs to be has spent time on a monthly basis in that practice. That could be one day a week or one day every other week, but he needs to be there. He needs to see what's going on. He needs to supervise. He needs to provide training. He needs to do chart reviews. There needs to be peer review. There needs to be credentialing, which means training, which you all have been talking about. So I hope that this committee actually addresses that. I make myself available. If there is an injury, I can be there within 30 minutes. I think that's a good time limit. The doctor cannot be out of state. I know another practice where the doctor's in North Carolina for surgical procedures are being done, and the practice is being run by lay people. Sorry it took so much time.
No, thank you. Kathleen McCollum, Northern California Aesthetic Nurses Association.
Hi. As a nurse in this field, I really appreciate the direction you're headed today. The issue is, as you know, people operating these offices, medical offices that are not primarily physician-owned and not appropriately trained or supervised. Clearly, that's where the issue lies. I do want to say the standardized procedures is really important and often overlooked. When there's an emergency and there's anaphylaxis, I better know that I need to reach for that epinephrine and not be waiting 10 minutes to get a hold of my physician. I have to have those standardized procedures there now. And that is critically important for every single complication we have. The other thing is I love the talk about the on-call after hours. Most often with light-based devices, you see evidence of a problem hours later when the burn becomes evident. So it seems like that is a really good and appropriate direction, because a lot of times you can do an IPL or other treatments and there's really no evidence at that moment that it's too hot. The issue about the state line is kind of interesting. What if my practice is 10 minutes from the state line? It gets a little funny if you think about where people are located, and yet it does seem logical to be within the state, but really immediately accessible is more important in my opinion. We can always call 911 and that can be one of our protocols, but being an hour away may not be adequate at that time no matter what, even if you're in the same community behind a traffic accident. So again, it goes back to knowing your standardized procedures, responding to emergency, communicating with your physician, getting their oversight immediately. I think that, the only other thing I wanted to also suggest is, and it kind of came up, we are defined as to what procedures we can do by rules that are already in existence, the Class 3 classifications of these devices, although there's a few that are kind of fallen outside of those classifications right now. Thanks.
Thank you. Norman Davis.
Hello, I appreciate the chance of taking 3 minutes, and what would a committee meeting be without some comments from Norm Davis, right? I really appreciate the chance of being here, and I want to congratulate this group. If you synthesize what came out of this group today, it's more than has happened in 5 years. Your comments, Dr. Finney, are totally appropriate. Your comments about adding some time dimension of response, either by the supervising physician or his designated appointee, that's critical in this. Without it, you don't have any teeth. You've got to have something that relates it. You've got to define the supervisory physician. You have to define that by definition, or nothing happens. You have mush. Dr. Powell has indicated ever so well exactly what's going on in this field. It's a tragedy that these centers are being run by lay people who hire a doctor who lives in North Carolina and has some doctor that might take a phone call because he's getting a few $100. It's a sin. And there's no accountability, there's no supervision going on. And I just want to say another thing on this, that what's happened that a lot of you are not aware of, what's happening to our nurses out in the field, and that's my reason for being here today. One nurse called me in a frantic fit that she just got a letter from the nursing board, and this was the comment, that they wanted to talk to her to investigate her because she's alleged to be engaged in gross negligence and unprofessional conduct by operating a med spa without having a medical doctor available. So I was asked to come and meet with this investigator and the nurse, who was, by the way, finishing up her FNP training. She's been doing this for 10 years, and yet she's lost sleep for several weeks because she was accused of gross negligence for operating a med spa without having a medical doctor available. Turns out that her doctor has been trained adequately, is very, very competent, has worked with her for 6 years. They jointly, doctor and nurse, 51%, own this practice together, and he's been intimately involved. And she had to go to the expense of producing documents and going to an interview and going through a half a day of interview on this thing with the fear that she was being intimidated about gross negligence. I think it was a real sad case. And just one other case that just has shocked me a great deal. I got faxed a copy of this, and it's my certainly favorite case. When she received an accusation about her practice that she's been in for several years, that the doctor lives a few minutes from the office, the nurse lives a few minutes from the office, the MD is totally available, has been involved in the practice for years, and this case was generated by a complaint from a very disturbed patient, I mean mentally disturbed patient, 5 years previous to this citation. The patient complained that the nurse's laser treatment caused blistering and eventual scarring. The case was reviewed by the BRN and was determined that, number one, the treatment was performed without an exam by an MD prior to commencing the procedure. Number two, the MD was not notified of the adverse reaction of this treatment. And number three, the RN failed to provide protective eyewear during the laser treatment performed. People, none of these have a causal relationship to the injury supposedly sustained by these patients, by this patient. Now, assumedly, if these facts were accurately verified and true, you would suppose that that RN would have to have some reprimand, would have to have some increased training in lasers and general practice, but certainly a warning about this prior exam, which we're now emphasizing, but this is a case 5 years ago. Shockingly, the RN has been deemed to be grossly negligent and incompetent for these actions. She now faces severe penalties for these allegations. They've now taken the form of an accusation. She now has to defend her position. She's a professional, and she is in serious trouble. I'm asking this committee and the members of this committee, what is going on the enforcement side right now. They're taking bits of information and attacking nurses, sometimes turning it over to the city officials, the police department coming in with bulletproof vests.
Madam Chairman, if I could be heard on this issue.
That's another board.
If I could, if I'm not mistaken, the accusation against the nurse is filed by the nursing board.
Yes, and may I comment that her doctor was interviewed before this regarding his role in this supposed
I'm
case.
just trying to point out to the members, in fact, that it's not this body
that is correct.
or the medical board that have jurisdiction over a nurse.
Mr. Davis, can I ask you to kind of wrap it up? We've got one more
Give me
speaker.
30 more seconds and it's wrapped up. Thank you, Mr. Hepler. I again plead with this committee to conclude and end the charge that you've been given over 5 years ago on the Figueroa bill. The comments that were made today, if you synthesize those and hand them back to Mr. Hepler, I think you have the meat here for concluding and wrapping this thing up. Why am I concerned? Because enforcement in the Med Board and now the BRN are intimidating and they're putting people's profession at risk because there's no definition that's tangible. Their enforcement are taking little bits of information and going out, both from the BRN and the Med Board, and causing havoc in the field. And I say, please do whatever you can as individuals on your board position with either board, and please help those in the field that are trying to do a good job, and we'll follow whatever standards you come up with.
Thank you, Mr. Davis. John Valencia, American Society for Dermatological Surgery.
Good afternoon, Madam Chair. John Valencia, representing ASDSA. I'm a partner in the Sacramento law firm of Wilkie Fleury et al., where for the better part of 90 years we've defended physicians and other healthcare professionals against medical malpractice, licensing, and business transactions. So I think I can say with a fair amount of authority, if there's a physician foible or a healthcare professional foible known, we've seen it. We've probably defended it. As much as the American Society for Dermatologic Surgery is steadfastly in favor of a standard in elective cosmetic medical procedures that speaks to a physician on-site and immediately available, it's my personal opinion that no amount of physician supervision is going to cure some of the issues that you've been exploring over the last several hearings. I think the gem of the proposal that's been offered up today is that you punt and go back to square one, because frankly I think very little will be lost by that, because no amount of supervision in truth is going to legitimize an illegitimate practice. That's fundamentally the case. And in our experience, both as defense counsel and on behalf of physicians in dermatology, the problems that we see, the problems that Dr. Kilmer, that Dr. Robbins, that Dr. Bruner and others treat are by and large not problems created in legitimate settings, but in illegitimate settings. My concern with the proposal, for example, that's on the table is that it will be exploited, quite possibly by several people that have appeared before you. I have my own favorite case, and it's the people of California versus Garrison, now completed. That's a story for another day. First and foremost, and Dr. Robbins, thank you for mentioning AB 1548. That's a matter of statute. And Madam Chair, with your indulgence, a couple of extra minutes. As a matter of law now, signed by Governor Brown, Chapter 140, Statutes of 2012, which was formerly AB 1548, a business organization that offers to provide or provides outpatient elective cosmetic medical procedures or treatments that's owned or operated in violation of Section 2400. That's the corporate bar. That's what you've heard referenced. It is illegal today for any person, not layperson, any person, regardless of their profession, other than physician, to own a professional medical corporation at 51% or greater. The other shareholders, the other stakeholders are also specified by law. Other than that, it's illegal to offer medical care in those kinds of settings that are not properly organized. And what will happen now, as a function of this bill, is that when a party like that contracts with or otherwise employs a physician and surgeon to facilitate its offers to provide, or the provision of outpatient elective cosmetic medical procedures or treatments that may only be provided by the holder of a physician and surgeon certificate, is guilty of violating Penal Code Section 550. That's a felony, and if you charge in a med spa or some other setting that's been gussied up to look like a legitimate setting, if you charge $951 or more for service, it's $50,000 and up to 3 years in prison. Because that's the kind of fraud that's going on in this field, driven by the dollar incentives that you heard about. $950 or below, also a felony, but $25,000 and lesser time potential. We've heard from district attorneys over and over and the medical board from time to time that what's needed is better enforcement of existing law. And with the medical board's support for this measure, many of you voted in support of this measure through the Ledge Committee and at the full board, it's now a function of law. It was our objective to give the medical board and other consumer protection agencies more tools to better enforce existing law. My concern with trying to bootstrap supervision, which again can only apply in legitimate settings, in legitimate medical practices, is that somehow that will be exploited to induce unlearned docs. I've always promised physicians and surgeons I would never practice medicine if they agreed never to practice law. And unfortunately, we get the calls way too late in the proceedings. It is already a matter of law in a legitimate setting, and if you were to extrapolate in these illegitimate settings, that no one can walk into a med spa in a strip mall and subject themselves to treatment that day. You know that's against the law. Because the Donda West bill that was signed into law last session by then Governor Schwarzenegger says, notwithstanding any other provision of law, any elective cosmetic surgery procedure may not be performed on a patient unless the patient has received within 30 days prior to the elective cosmetic surgery procedure and confirmed as up to date on the day of the procedure an appropriate physical exam by and written clearance for the procedure from any of the following apex healthcare professionals: physicians and surgeons, certified nurse practitioner, licensed physician assistant at direction. I guarantee you, you go to the suspect and illegal settings, that hasn't been attended to. So I would caution you against, in closing, I would caution you against trying to fix the multiple problems that you have accurately identified throughout the course of today's hearing. I'll close with this observation. In your May hearing, you had Deputy Attorney General Lee talk to you about this circumstance. What was ironic was that his testimony was followed by an Orange County physician. May or may not be the same Orange County physician that was referenced earlier, but he talked about his experience in cosmetic procedures. Bet he didn't tell you that he's also the medical director for a facility in the South Bay. And we examined those kinds of circumstances. There's no ownership structure there. So supervision will not cure an illegitimate circumstance. It will focus attention
Valencia, could
internally.
you wrap it up?
Thank you. Thank you, Madam
Appreciate it.
Chair, and appreciate the opportunity to appear today.
If we can, see no more public comment, if we could bring it back here and would entertain a motion of any recommendation to the full board.
Dr. Finney, could you share with us the language that you have there, and we can make a motion on that perhaps?
Okay, the one day I didn't bring my laptop, you know? Boy. Okay, it would start with not physically present but immediately available. Quote, whenever an elective cosmetic procedure involving the use of a laser or intense pulse light device is performed by a licensed healthcare provider acting within the scope of his or her license, a physician with relevant training and expertise shall be immediately available to the provider. For the purposes of this section, immediately available means contactable by electronic or telephonic means without delay, interruptible, and able to furnish appropriate assistance and direction throughout the performance of the procedure and inform the patient of provisions for post-procedure care. The one piece that I'm not quite sure how...
And such shall be communicated or contained in standardized procedures.
Okay, and that would be a comma, and such shall be contained in standardized procedures and protocols. Maybe need a grammatical tweak there, but that's the gist of it.
And that the patient knows who to contact. Is that okay?
I'd like to make a motion that we accept that language as a committee and carry forward with it.
Second.
Discussion. Yes, Dr. Robbins.
I think that
Microphone, so we can hear you.
I think that the rush to judgment is doing a disservice to the procedures, to the profession, and to the responsibility that we have assumed as members of the panel to provide medical supervision to the allied healthcare providers by adopting this motion.
Dr. Bishop?
We really aren't rushing to judgment. We're simply presenting this to the full board where further modification can be achieved. I think we've done what we can do today. I think any further crafting, we're at the limit of what we can do.
And did you raise your hand so I can acknowledge you? Doctor, are you done? Okay, Dr. Kilmer.
And can we suggest that we do look into a way to do some sort of certification or licensing, or like some way to decide who's appropriate? Can we say we've addressed this issue, but we do feel that there's a need for certification, licensing, whatever
Mr. Kepler, and if I could kind of intervene for a minute, if we could go forth on this, meeting our obligation that we've been directed by the legislature to do, and then bifurcate, and then additionally communicate with the legislature that we do not feel, while we've met the requirement they have asked of us, we feel that more needs to be done legislatively to adequately protect the consumer of these services. And then give instance, for instance, legislation needs to be crafted addressing the level of training and any of the other items that, that we feel was necessary.
I think you could actually wrap it up on a motion. You could say, in fact, this is our regulatory proposal, but going forward, this committee believes that further work is needed to be done legislatively to at least contemplate changes in these other areas.
I think we need to be specific about why we feel it doesn't totally meet the bill, so that we communicate, as Dr. Robbins and others have said, that the legislature needs to go farther on this, but that we've met our requirement statutorily by, going forth on the issue of supervision. But we need further legislation. So can I entertain a...
So if you want to go that far, then I would suggest you want to amend. If you would suggest that as an amendment to the.
I'll take that as a friendly amendment.
Okay. How about the second?
Yes, second.
Can I just ask that you change standardized procedures and protocols to or protocols? Because PAs don't use standardized procedures commonly. And then I just questioned the word that you inserted, furnish appropriate assistance. Is that going to be questioned about what appropriate? And is it necessary?
Can we make a definition in our definitions?
At this point, I think it would be best, maybe one of the things we could do is run with appropriate, and perhaps clearer minds would prevail tomorrow and see if there's a better word that comes to mind. But I think for the purpose, candidly, of getting it to the full board, the committee may want to consider going with appropriate.
Any other commentary? All right, I'd like to call for a vote on the motion as read and with a friendly amendment on that. All those in favor?
Aye.
Any opposed? Okay, Dr.
And then just remember, the motion is going to be recommendation to the
full board, and obviously
right,
the full board.
This committee is not authorized to make regulatory decisions all by itself.
And if staff can prepare a summary so that we can obviously tell the full board the meat of the discussion and the concern that several have expressed that, that while the legislature was well intended, that it missed the mark, and that we'll go forth, but, we would like them to consider some additional legislation. All right.
I'd like to propose a motion to adjourn.
I would very much like to entertain that. Yes, yes.
Not to be
Voting
the most,
again.
not to be the most unpopular guy in the room, but I think we have one more thing about future agenda items, do we not?
Well, the future, if we can call for future agenda items, again, and obviously I hope we continue to meet, I do believe that we should iterate that we would like a presentation on medical spas and possible definitions. Also about the fictitious name permit, because I do think under the new legislation that we may have some real room in there, to tighten this up. And then I understand that we don't agree with the case, but if we could have a presentation on the outcome of the case on the supervision of certified nurse anesthetist, that would help. Okay. Any other items that you'd like discussed?
I'll just ask a quick question. I'm always digging around for these words. The word appropriate is in the code very often, do you know?
The word appropriate, kind of, like I said, it's not really an absolute stumbling block. It just goes to a question of clarity, because appropriate is a very good word in my mind for statute. It's perhaps not the best choice of words for regulation, but we can cross that bridge.
Well, perhaps between now and tomorrow, you can help wordsmith that so that when we present it to the board, we'll be more comfortable. Yes, Dr. Robbins.
As it's presented right now, I had to not give my vote in favor of it, but I do have a question, and that is, do you have to include in this motion who is going to determine what is acceptable or appropriate?
I will defer to Mr. Kepler, but my gut feeling on that would be it would be the community standard that would be applied.
So we're getting back to that area where we have one expert saying this is the standard of care and another saying this is not, and I thought we dismissed that concept at the very beginning of our discussion.
I think that was discussed, but I do think that might be the legal standard by which...
Has this meeting adjourned?
Pardon? The meeting was adjourned.
This is off the record, okay.
Okay. All right. And I'd like to thank everybody for being here and for your input and testimony. I think it was a very productive meeting, and good night. Yeah, why don't you give that to her?